Welcome to Gallup. We're all good on tech. Okay. And for those of you who are listening, it did say Veterans and Military Affairs on the webcast, but I think that's fixed. I'm getting texts about, okay, it's fixed. So we will start with introductions, and we'll start with Representative Jones.
Good morning, everybody. I'm Representative Jennifer Jones, and I represent District 32, which is Doña Ana, Hidalgo, and Luna counties. Good to be here this morning.
Good morning, Madam Chair. John Block, House District 51 State Representative from beautiful Alamogordo in Otero County. Great to be here.
Good morning, Madam Chair, everybody. My name is Nicole Chavez. I represent District 31, which is the far northeast heights of Albuquerque.
Good morning, Madam Chair. Alan Martinez, representative for District 23, Sandoval County, the northern part of Rio Rancho and the western edge of the town of Bernalillo.
Representative Lindstrom. And welcome.
Well, thank you, Madam Chair, and I'd like to welcome all of you to House District 9. This is my district. I represent the west side of Gallup and 9 Navajo chapters here in McKinley County. So I've always tried to, when we have our interim meetings in Gallup, I try to attend because there's always something new you can learn, and I appreciate having that opportunity. Thank you.
All right. Good morning, Madam Chair, committee members, and everybody out there. Good morning. I'm Representative Mariana Anaya, House District 18. That is the middle of Albuquerque. I've got Nob Hill, UNM, CNM area. Thanks so much.
Good morning, everybody. Eleanor Chavez. I represent House District 26 in Albuquerque. My district is on the west side and also includes the Pajarito Mesa and the South Valley.
Good morning. I'm Representative Joanne Ferrari from House District 37 in Las Cruces, and I'm kind of in the east side of Las Cruces and the far north, so the far northeast heights of Albuquerque. I'm in Las Cruces. I've been in Albuquerque too much lately.
Representative Gonzalez, can you introduce yourself, please?
Thank you, Madam Chair. My name is Anita Gonzalez. I am a state representative for House District 70. I live in Las Vegas, but my districts cover San Miguel and Torrance counties. Thank you.
And Xander, can you introduce the team?
Thanks, Madam Chair. So I'm Xander Dawson, lead staff for the committee, and I work for the Legislative Council Service. Also joining us from the Legislative Council Service is Andrea Lazarou, who just stepped out, and Grace Balderramos. We also have Robert Chavez. He's the guy making sure everybody can see us online. And then we have Ruby Ann Esquivel from the LFC.
Thank you. And I'm Representative Liz Thompson. I am House District 24, which is the northeast heights of Albuquerque. I have Winrock and Uptown, but Gallup is kind of second home. I grew up in Crown Point, did one of my clinical rotations at Gallup Indian Medical Center, and when I hit the Red Rocks, I just got this feeling of I'm home. So it's wonderful to be here. I want to thank UNM. UNM always treats us so well, Linnea, and your staff. We can always count on you, and it's a beautiful view. And so with that, we will start with Sabrina Izell and Jonathan Lumabau. Thank you. So go ahead.
Good morning, Madam Chair, members of the committee. I'm Sabrina Izell. I'm the Chancellor here at the branch, and with me today is Mr. Jonathan Lumabau, and we're happy to have you on our campus this week. We appreciate the opportunity to share how we are serving the needs of health in our community. In addition to our nursing and human services programs, our allied health programs are doing well. Our dental assisting and medical laboratory technician programs are both nationally accredited, with advisory committees made up of representatives from local hospitals and dental clinics. They help us stay current on our curriculum, and that also helps us support employment upon graduation. Our Human Services program, which has concentrations in family studies and substance abuse, has a new director starting this fall. We're very happy to have Mr. Bernie Montano joining us. I wish he could be here with us today, but as you probably noticed, it's getting kind of crowded out in the parking lot because today is the first day of class. So he has hit the ground running. He's from Gallup. He has worked in the community as a substance abuse counselor for several years, and so he has a very clear understanding of local behavioral health needs and is already thinking of new ways to partner with local agencies. He's committed to growing the Human Services program and meeting the needs of our community. We are also addressing growth of our health and human services programs through our collaboration with the school district. These efforts include the Health Pathways program, our Center for Career and Technical Education program, also called CCTE, and the start of our LPN program for high school students. We're in our second year of Health Pathways. This year, there are 57 seniors enrolled in dual credit courses that expose them to options in health careers and health-related content. The CCTE program starts the junior year and includes up to 4 college-level courses that prepare students for the healthcare sciences. There are 160 CCTE students this fall. Before Mr. Lumabao provides an update on the nursing program, I'd like to thank all of you as legislators for your financial support over the years with the nursing expansion funds and the nursing faculty endowment. Our program would not be what it is today without your financial support. When we initially received the endowment money in FY23, we had unanticipated faculty vacancies in our RN program that took us 2 years to fill. We are finally in a place where we could hire the new LPN program instructor who is starting this semester. The endowment is funding this position and will lead to expansion of the nursing program as the endowment was intended. So again, thank you very much for your support. Madam Chair, I'm happy to take questions before we move to Mr. Lumabao, or we can go ahead.
We usually wait till the end.
Okay, thank you. Now, Mr. Lumabao.
Good morning, Madam Chair, members of the committee. My name is Jonathan Lumabao, and I am the Director for the UNM Gallup Nursing Program, and I'm here to share some program updates with you. The UNM Nursing Gallup Nursing Program continues to achieve strong student success outcomes while helping to strengthen New Mexico's nursing workforce pipeline. Currently, the program demonstrates sustained student success, and it's supported by steady enrollment and comprehensive wraparound services, including our IBEST instructional support and on-campus childcare. The nursing expansion funds have been crucial in enhancing the program's mission and capacity, and addressing these key needs. These funds have ensured that our students, faculty, and our staff are well equipped to meet their goals and succeed in their endeavors. So far in the past academic year, we've been admitting 24 students each spring and 24 in fall, so we've been admitting at least 48 per year, and that's ensuring a consistent pipeline of entry-level nurses for our regional employers. We've had the highest consistent number of nursing students in the history of the program, and currently we have 86 students in the pipeline. Our overall retention from last academic year, we've had 85.6% retention rate, so which is good. Our NCLEX RN pass rate performance has also been pretty great, and we've been preparing students for the professional licensure. Currently, we are, last year, we were currently 92.31% pass rate for our NCLEX RN, and that reflects all of the effectiveness of our curriculum, faculty dedication, and also student support systems. We've been trying to do a lot of comprehensive student support, such as IBEST integrated instruction. So this is actually a co-teaching and embedded support within the foundational nursing courses. It's also helping to do targeted tutoring for specific nursing themes, such as dosage calculations, pharmacology course, and also clinical reasoning. It's also helping with study skills coaching and early alerts. We've been trying to grow our simulation skills lab, And the scenario-based learning, pre-brief and debrief, and standardized patient encounters in simulations have been really great in preparing our students for clinical readiness and also NCLEX competencies. We've been doing pretty good with advising and mentorship. We've been having proactive advising through degree maps and progression planning, along with student workshops with on-time management, note-taking, and also test-taking skills, as well as nursing resource guides, promoting persistence, student persistence from term to term. Academic support such as office hours for faculty, structured review sessions, writing and math labs, and NCLEX-style preparations have also been key in our success lately. And our wraparound services such as financial aid navigation referrals, scholarship opportunities, and the UNM Gallup daycare have been helping parenting students overcome non-academic barriers. Some of our newest initiatives is our high school LPN program, and we plan to launch an LPN program for the high school students in the fall 2026. This initiative will create an entry level or early entry pathway into nursing for a lot of the students, helping to address workforce shortages and offering career opportunities for local youth. And we also anticipate that this program will also help increase enrollment in our RN program when students return to our program to pursue their RN credentials down the line. With the significant successes that we've had, we've also still continued to face challenges that really need our attention. One of them is still faculty recruitment. We've had some recent successes, however, it's still been challenging to fill full-time faculty positions due to a limited pool of qualified candidates. We've been always having one person per pool for every job posting that we have. So it's been quite challenging on that part. It's also quite challenging to get part-time faculty due to nursing shortages. Trying to recruit qualified temporary faculty has been a challenge. A lot of the nurses out in the community hold an associate's degree in nursing, which do not meet our teaching requirements. A lot of the students, or a lot of the nurses that have a Bachelor of Science in Nursing or a Master's of Science in Nursing have been quite limited in availability just because of staffing shortages in their primary healthcare roles. And with these faculty shortages, it limits or it kind of restricts our enrollment growth and limit clinical placement supervision, directly impacting the number of students that we can graduate every year to serve New Mexico's workforce. However, looking forward, we're dedicated to attracting and retaining qualified educators. We're still looking forward to launch our LPN high school in fall 2026 and still continue to enhance our student support services for high retention and graduate rates. So with these supports, we can address these challenges and ensure a strong nursing workforce in New Mexico. So with that, I'm able to entertain any questions if you guys have anything.
Great, thank you. Who has questions? Okay, we'll start with Representative Jones, then Minority Whip Martinez, and then we'll just go down the line over here. So go ahead, Representative Jones.
Thank you, Madam Chair, and thank you all very much for hosting us and for your presentation. So I'm interested in your LPN program, absolutely, and your initiative on the high school level to help them. I'm assuming that you're wanting to help them enter into further LPN, to further their LPN, or would they graduate with their LPN from high school?
Madam Chair, members of the committee, so we're actually planning to have the students complete their LPN program while in their high school, and that means they would be able to sit for the LPN boards after they complete the program. So this is after high school.
So they would leave high school, Madam Chair, they would leave high school with their LPN, correct?
Yes, ma'am.
And they could move right into a bachelor's program here?
with a certificate, yes, and then they would be able to cycle back into our program to get their RN associate level.
So, Madam Chair and presenters, would you say that the main barrier for enrollment growth is faculty, is not being able to get faculty that could teach these students? Correct?
Madam Chair, members of the committee, this is correct. Clinical faculty have been one of our limiting factors to get more students into the program.
I need a little bit more background on that. I understood you said that you couldn't find qualified candidates, so you're not able to even get people to interview. Is that correct?
Madam Chair, members of the committee, so it's very limited, yes. So we would only have, for a lot of our full-time positions, we would only have one person in the pool to kind of interview and hire.
Thank you. I know historically in nursing, the pay for being faculty is so much less than the clinical world that usually prevents people from wanting to teach. And so I think that's probably, I've always, for many years, I've thought that was a barrier to graduating more nurses, and it seems like that's still true. So how can we help with that?
Madam Chair, members of the committee, I think that's a good question. That right now I don't have all the answers top of my head. A lot of it is multifactorial concerns or issues, is what I can kind of say.
Thank you, and thank you, Madam Chair. Just one more question. So if we were able to double your faculty, for instance, could you double your graduation rate? And how soon would that happen?
Madam Chair, members of the committee, from my calculations, I think we would be able to kind of do that with double faculty.
Interesting. When you can't get the faculty you need to think about doubling, but it should be a goal of ours, I think. So I appreciate that information. Thank you. Thank you, Madam Chair.
Thank you. Just a reminder, especially for, it hasn't happened yet, but if we have two mics on, we frequently get feedback. So if you're not speaking, please turn your mic off. And Minority Whip Martinez.
Thank you, Madam Chair. You said earlier that you have 48 nurse students per cycle. Are they staying in the area? Are they going to Albuquerque? Do you track that?
Madam Chair, members of the committee, yes, we do track all of our students that graduate in our program, and I would definitely say 95% of them do stay in the area.
Thank you, Madam Chair.
Representative Lundstrom.
Thank you, Madam Chair, and thank you for allowing me to participate. I'm just a visitor for this committee.
We welcome guests.
I had a couple questions, though, Madam Chair. I'd like to understand what credentials do you need to run a nursing program? And I'm curious, are you a nurse yourself? Okay, so what kind of credentials do you have to run a nursing program?
Madam Chair, members of the committee, so I would like to clarify what credentials. Well, basically, what we wanted for faculty to teach at the very entry level is a bachelor's level of nursing.
What I'm trying to get at, Madam Chair, is it a practitioner person, or is it somebody that is a faculty type? And what I mean by that is someone that can actually teach the material, provide oversight for clinical work, that kind of thing. To me, they're different. It's just like the kind of work that I do. It's one thing to learn it from the textbook, and it's another thing to be out there. So I'm just curious.
Madam Chair, members of the committee, ma'am, that's a really good question, and what we would like preferably is for a faculty to have a master's in nursing with a nursing education background.
Okay.
But currently, because it's really hard to get a nurse that's master's prepared with a nursing education, we would be happy to take anyone with a master's degree. We would just have to train them in nursing education while they're in the program.
Because, Madam Chair, what I think I'm hearing is I don't know that adding more faculty resolves the problem if you don't have a clinical space for them. If you don't have a place for them to actually go out and do their work, which I'm not sure if we do in rural New Mexico. I mean, we do have a hospital, we've got clinics, we've got schools that have school nurses, that kind of thing. But I'm just wondering if that's really the issue. I know we're tied on teachers and on faculty, but isn't it just as important to have some place to put them so they can learn their trade?
Madam Chair, members of the committee, so ma'am, this is also true. However, I believe from my perspective, this is both a limitation for clinical instructor and also faculty, because if we couldn't get faculty, even if we have enough clinical sites, we still won't be able to graduate as much. And if we even have more faculty but less clinical sites, it would still limit us.
So, Madam Chair, if you had the clinical sites with a licensed nurse that's providing oversight to one of your students, can that person be designated as staff for faculty?
Madam Chair, yes.
So why aren't we doing that? I guess my question, and it's because I don't know anything about healthcare, so I come across like a dummy, and I am. But here's the thing, is that if you are placing, we'll use RMCH, a nurse, nursing student at RMCH, and you have a licensed doctor or nurse or physical therapist or whatever that's providing oversight, because you can't just send them out there, can that person be considered or designated as part of, I guess, the licensing process? I know they're not certified faculty, but they know what to do on the ground. You know, for me personally, I'd rather be working side by side with an emergency doctor who can teach me versus reading it out of a book.
And I'm just going to jump in here. So clinical instructors are volunteers, essentially. They don't become staff. I was a clinical instructor, and so you don't need anything specific to be a clinical instructor except to be a nurse, correct? Yeah. So and there are many. I mean, there are things like home health care. You mentioned a few things: clinics, public health, all those. So there is more than just the hospitals. Although having these two hospitals, do you place students at GIMC? Okay. So having two hospitals in a town this size is pretty unusual. But yeah, so just a practitioner in the field can be a clinical instructor without being staff, without getting paid.
So let me ask you then, Madam Chair, are they calculated as some way where they're calculated that this student has received this many clinical hours under this practitioner, so we're ready to roll them out on, as an employee someplace? What I'm trying to get at is that are we making sure that we're calculating every touch point for these students where they're actually learning something?
I believe there's a graduation requirement for a certain number of clinical hours in a real life setting.
Is that correct?
Madam Chair, members committee, so yes, this is correct. We do track each student's clinical hours while they're in the different facilities. And just to give an additional information, we can only pair a student with a registered nurse. We couldn't use any doctors or physical therapists for them to complete those hours. It has to be a nurse. But we do track them to make sure that they have the enough clinical hours for them to complete the program.
Not even, Madam Chair, not even for basic stuff? You have to have a registered licensed nurse.
Madam Chair, members committee, yes, this is correct. And because we have to follow the New Mexico border nursing rules on who can teach the nurses or teach our nursing students.
That's interesting. Thank you.
Representative Naya.
Excuse me, Madam Chair,
Yes.
just real quick, for those of us that are not from here, what's RHMC and GIMC?
Rehoboth Hospital and Gallup Indian Medical Center. Sorry. Speaking in lingo, yeah. Go ahead, Representative Naya.
Thank you, Madam Chair. Thanks to the presenters. Actually, I'm going to build off of what Representative Lundstrom was talking about. My understanding is that these preceptors are also volunteer. I know when it comes to other medical professions, we're having a really hard time getting people to say, sure, I'll take on an extra student. That kind of takes up a lot of time. And so as Rep. Lundstrom was talking about preceptors generally, one, I know this is not necessarily built into the budgets, which I think is a really important piece. I know Representative Gonzalez carried a bill to pay our preceptors. So I just wanted to bring that up as perhaps a priority for the committee as we're moving forward. But I had a question about UNM's expansion. I know UNM is getting a big expansion to the School of Medicine, and I'm imagining that doesn't translate to the satellites. And I just want to ask about that. Is that correct?
Madam Chair, Representative Anaya, actually, the Dean of the College of Medicine is coming out to Gallup on September 16th, I believe. And she's also going to Zuni and Farmington, and I can't remember, there was one more spot that she was going to make a visit. And I think that something that I'm going to suggest to her and as a request is to have UNM Gallup be part of the BA-MD option.
That's awesome.
So that students from here could get their undergraduate, their lower division courses completed before they move to Albuquerque, and also give them clinical opportunities here before they leave. That way they will come back here and work. So anyway, that's just my little
That's a great suggestion.
pitch.
I love it. Very cool.
Thank you.
God, thank you. And I have one last question, Madam Chair. I know we hear a lot about what's going wrong in healthcare, but I know one of the things that is going right here is we're really outpacing the number of nurses that we expected. And I just want to know from your perspective, I know you listed a bunch of initiatives that you all have here, but I'm wondering if there are any that stick out as kind of game changers, either for keeping or retaining students here, or for the program itself. Like, was there anything pivotal that you all did that you can kind of say, like, I think this attributed to our ability to graduate more students?
Madam Chair and members of the committee, Representative Naya, and I probably say it's combination of the success and things that we've had done in the past, or some of the pivotal stuff that allowed us to retain and graduate students. I couldn't pick out any one thing that was successful, but it's more of the combination of the different things that we've done so far.
Madam Chair, if I could just add on to that. So just so you're aware, I was the director of nursing here for 3 years, starting back in 2015. And Mr. Lumabao and I have worked together for about 12 years in our nursing capacity. So one thing that was implemented was the IBEST instructor in the classroom, and that's the Integrated Basic Education and Skills Training Instructor. And that person helps support basic English and math in the classroom, supporting the expert instructor. So now we have this combined support for students. They have their expert instructor in the classroom, and they have the IBEST instructor who supports the expert. And then they help tutor. They're sitting in the classroom listening to what the expert instructor is sharing with the students. Then they can help support the student even further when they're tutoring them outside of the classroom and supporting math and English, and helping them with their math skills and their writing skills. So we did see an increase in retention, adding that extra support in the classroom. We also have additional tutoring support for the nursing students. So to me, that is something that I saw as an improvement. There was something else that I thought recently?
Madam Chair and members of the committee, yes, that is one of the things that added to our retention rate as well. But for me, looking at the whole, I'm just looking at the whole picture that added to it was also having a lot of this, the other support systems that we've had. The IBES was one of the key things, I believe, but the other items also played a role with the whole retention of the students.
Madam Chair, if I could add one more thing, sorry. I also, what I think is increasing the number of qualified applicants to the nursing program is strengthening the science courses that the students take before they apply to the nursing program. So they have to take an admittance test called the TEAS. What does that stand for?
Madam Chair, members of the committee, it's called the Test for Essential Academic Skills exam.
So the nursing students have to score a certain number on that test or they can't get into the nursing program. And I think that we're seeing an increase in the number of applicants because of the stronger biology and chemistry instructors that we've hired here at the branch and the extra student support that they have received. So just wanted to give a good shout out to our science instructors. Thank you.
Thank you, Madam Chair. I appreciate that.
Representative E. Chavez, I'll have to get back in the swing of the E in the end.
Yeah, thank you, Madam Chair. And so I have a couple of questions. A lot of my questions have already been asked, but you said that you track where people go to work after they're done with the RN program. Do you do that for the other healthcare-related programs, behavioral health programs? Do you have that information as well?
Madam Chair, members of the committee, and Representative Chavez, since I'm the nursing program director, I can only track the nursing students. I couldn't track the other ones. I'm uncertain if they would be tracking them. I'm assuming they would be as required for their accreditation, but for me, I'm only tracking the nursing students.
Okay, thank you. So then my next question is, do you also track demographics of the students? And one of the things I'm particularly interested in is how many of them are bilingual? Because as we all know in healthcare, it's better to have somebody who speaks the language of the patient as opposed to, calling on the phone to get an interpreter or calling an interpreter in. So do you also track that?
Madam Chair and members of the committee and Representative Chavez, we do track the student demographics. However, we don't track bilingualism as part of them. We do track their race and ethnicity. However, I'm unsure about their linguistic capabilities.
And Madam Chair, I'm wondering if you would be able to give us that information. I'd be particularly interested in those two pieces, where the students go to work after they've graduated, and then the demographics of the students. So if you have that information, it would be great if you could, Madam Chair, give it to the committee.
Madam Chair and members of the committee, yes, I would be happy to share that information with you all.
And please send it to Xander.
And then my other question has to do, it sounds like you're doing a really good job in terms of attracting high school students, for example, into the LPN program. Do you have, or are you thinking about doing any work in the middle schools or even the elementary schools to get students early on interested in becoming nurses or even becoming doctors, those kinds of professional occupations?
Madam Chair, members of the committee, and Representative Chavez, we haven't thought of it that way, ma'am, but I think that's a good idea. And currently we are working with some of the high school students, because McKinley Academy has some sort of they have some sort of a mini clinic in their schools that we do send our clinical instructor and all of our students, and they teach the students on how to perform basic vital skills signs. So in a way, it also helps some of those students get interested in the program, and it also helps our students interact with the population that they'll be working with.
And then, Madam Chair, just one last question. So your program here is a 2-year program for the RN, is that correct?
Madam Chair, Representative Chavez, so we do have a 2-year program for the associates, but we also have a bachelor's dual degree program that we have partnered with College of Nursing, so our students are also able to get their bachelor's in nursing while in this area.
Okay, great. Thank you, Madam Chair.
Representative Ferrari.
Thank you, Madam Chair, and thank you for the great information. My colleagues have covered the questions, but I just wanted to mention that I do support the commensurate pay for faculty as if they were out, practicing on their own. And then also, if we can find out, the information about how many graduates stay in the area, that would be really interesting. So thank you, Madam Chair.
Representative Gonzalez, and while you have the mic, introduce yourself, and then I'll ask my questions, and then we'll come back to the other folks who came in.
Thank you, Madam Chair. I think I got here a little later, but I did introduce Anita Gonzalez with, yes. It's okay, I'll say it again. District 70, Las Vegas, but I know you've alluded to it, and you've talked a little bit about your high school graduates and your students that are coming out of your program. In my day job, I do work with the STEM program, and in particular, we have programs here all throughout Gallup, McKinley County schools, and maybe elaborate a little bit more. I think just to highlight here within GMCS, you guys have a great CTE medical careers pathway that I do believe many schools across the state have come here to model, as evidenced by the numbers that you're talking about, graduating, being able to graduate high school with a near completed nursing certification, also with the location of Middle College here on your campus. So maybe elaborate a little bit onto the partnership between UNM Gallup and these high schools, which has allowed that program to grow as good as it has. Just I think that integration when you're talking about instructors and really, for lack of a better words, pumping out these health professionals in these rural communities. Thank you, Madam Chair.
Okay, so I do have a few questions along the lines of let's pay our faculty so that they want to be faculty. I mean, I know there's people who want to do it, but when you can make twice as much working as a nurse as you can working as an educator, makes it a tough choice. So no promises, but we will work on that. Things are up in the air right now in terms of New Mexico, well, the whole country, but New Mexico in terms of Medicaid and all that. So the timing may be off, but I think that's something that we really need to research and do at some point. Just curious, and you may not know this, you said you only have basically one qualified applicant per position. Do you know, or do you get the sense that it is a pay thing, or are there other issues that get in the way?
Madam Chair, yes, Madam Chair, I believe Representative Gonzalez asked about me. Were you asking me to go into a little more detail about the high school programs?
Well, maybe, yeah. Excuse me, like the partnership between the university and CTE, but maybe that kind of lays into that about just the way that you guys have been successful with integrating your college into your high school programming to be able to do that work and create those numbers. But that also, I guess, leads into into Chair Thompson's statement also. So okay. Yes, if you're able to elaborate also, but also please.
I didn't want
to Chair Thompson.
Not answer your question.
That was my fault. So just go ahead.
Okay. So we have 3 high school programs on our campus. We have the Middle College Early College program. We have the McKinley Academy Early College High School, and we have our CCTE high school program. So Middle College is a charter school. The McKinley Academy is run by the school district, and the CCTE program is a mill levy funded program. And it has been in existence for about 25 to 30 years, really long time. The early college programs really support college preparedness, as you know, as the name implies. Those students graduate from high school with an associate's degree quite often. I'm not sure what the percentage is, but it's very high. If you come to one of our graduations in the spring, you will see many high school students graduating with their high school diploma and an associate's degree, and sometimes more than one. So they really excel in the classroom, and they are more than prepared to move on to a 4-year degree if they so choose. Would you like more information?
No, thank you for that. Just, I've had the privilege of seeing some of the transcripts of some of your students graduating from these medical pathways, and it's just phenomenal, the number of sciences, as you were mentioning, the number of health career options. And I think that's just really key if you're trying to create these health professionals as to where you're starting them and the courses that you're able to offer. Just wanted to share that with others that may not be privy to good high school transcripts. But thank you for that, and thank you, Madam Chair.
Thank you.
So in terms of who can attend the high schools, do you have busing programs like from the Crown Points and the Tohatchis, or are they pretty much on their own if they want to come in from one of the more rural
From the early,
areas?
Madam Chair, for the early college programs, I'm not sure about the busing. And for the CCTE program, they are bused here from the entire area for the school district.
Great. Okay, that's good news. And then which school, do you have LPN programs in the existing high schools, or are they just on this campus?
Madam Chair, I'm not aware of any other LPN programs in the other schools but us.
Thank you. And then iBest is really intriguing. Which students can qualify for that?
Madam Chair, so it's all of our nursing students that can qualify for it, that do need the support.
Are there, in other areas of major, is it available to other students, or is this a specific nursing program?
Currently, it's available in the EMS program and in the nursing program because we were able to request for a grant to support the IBEST instructors.
Oh, that's great. And so who is the grant through?
It's W.K. Kellogg.
Okay. So the state is not invested in the IBEST program here?
Not currently, I would say.
Okay. And how long does your grant run?
We still have a good year, and then the grant will be done.
And do you have plans for continuation?
Madam Chair, so we're hoping that we would be able to hopefully continue.
So would that be through the same grant? Can you reapply for the grant, or would you have to go elsewhere?
We can, right now we can have a conversation with them and see if they would be willing to do another year or two.
Okay, and I think I can speak for the committee that we would be happy to write a letter of support for that. And so, again, talk to Xander. Okay, thank you so much for your presentation. And now I will go to the folks who have arrived. I'll start with my sister, Representative Johnson.
Good morning, Madam Chair. I couldn't tell if this was on. Good morning, Madam Chair, colleagues, and audience. I'm Representative Wanda Johnson, and I represent House District 5, which includes East Gallup in McKinley County and 15 Navajo chapters in McKinley and San Juan counties. I'm glad to be here. Thank you.
Senator Pope.
Thank you, Madam Chair. Senator Harold Pope Jr., District 23, Northwest Albuquerque, Bernalillo County. Happy to be here.
Senator Charlie.
Thank you, Madam Chair. Good morning. I'm Senator Charlie Angel. I represent Senate District 30, which spans from Bernalillo all the way down here. I have a piece of McKinley County that's in Zuni Pueblo, so glad to be here.
Okay, thank you so much for your presentation and for your hospitality, as always. And
Thank you,
next,
Madam Chair.
yes.
Sorry, I just said thank you.
Oh, I thought, I was like, oh, did I miss someone? I'm like, oh, it's Monday morning, I could have missed the whole group. So thank you. We will next go to a medication-assisted treatment program evaluation, John Valdez and Maggie Klug from the LFC. And we also have Secretary Gina de Blasi from Department of Health who will answer questions, et cetera, maybe make a few statements after the presentation by LFC.
Good morning. My name is Dr. John Valdez, and I am a program evaluator at LFC. Today, my colleague Maggie Klug and I will present our evaluation on the Department of Health's provision of medication-assisted treatment, or MAT, in public health offices. You can find it, looks like this. This evaluation builds on years of LFC research into substance use, including work on public health offices, and most recently, a 2023 progress report on addressing substance use disorders. This evaluation is the first on the subject since the Department of Health began offering MAT to address both opioid and alcohol use disorder in most public health offices across the state in the spring of 2024. Before we discuss our research findings and recommendations, I want to thank our colleagues at the Department of Health for their cooperation throughout this evaluation. They facilitated visits to 7 public health offices around the state, as well as 2 inpatient recovery facilities. They were also patient and professional in responding to our numerous questions and data requests. To begin with, Ms. Klug will discuss the background, including the scale of the problem of substance use, the basics of MAT, and the state's investment. She will also discuss our first finding regarding the low number of MAT patients so far treated in public health offices, as well as some of the barriers encountered since implementation. Next, I will discuss inconsistent outreach and marketing of MAT in public health offices, as well as avenues to reach more New Mexicans in need of MAT, including potential low-cost coordination strategies and providing MAT through public health mobile health units. We will also conclude with a summary of our key recommendations. And with that, I will turn it over to Ms. Klug for our background and first finding.
All right. Good morning. Thank you, Dr. Valdez. Chair and members, if you could turn with me to page 4 of the report, I'll start with some background information on the state of substance use in New Mexico to speak to the scale of the problem. Looking to Table 1 on page 4, as you can see, New Mexico has a higher rate of substance use disorder than the national average, with 23.6% of New Mexicans estimated to have a substance use disorder, according to the most recent data from 2022. This report will focus specifically on opioid use disorder and alcohol use disorder, as these are treatable with medication-assisted treatment, or MAT, which I'll discuss momentarily. Again, in Table 1, as you can see, alcohol use disorder is more prevalent in New Mexico than opioid use disorder, with 12.2% suffering from alcohol use disorder in 2022 compared to 2.5% with opioid use disorder. While New Mexico has a higher rate of individuals with a substance use disorder receiving treatment than the national rate, Only 6% of people with a substance use disorder in New Mexico are estimated to have received treatment, and as we'll discuss in depth in the first chapter, approximately 9,000 people in New Mexico need MAT but are not receiving it, according to the Healthcare Authority's estimates. Moving to page 5, looking to chart 2. While you may have seen in the news that opioid overdose deaths have gone down in recent years, both nationally and in New Mexico, this is likely due to successful harm reduction efforts, such as the wide availability and distribution of naloxone, also known as Narcan, a medication that can reverse an opioid overdose, as well as test strips. But while fewer people may be dying from opioid use, this does not mean that opioid usage is going down, and could in fact mean that there are more people needing treatment. Turning to page 6, Figures 1 and 2 highlight the regionality of opioid overdose deaths and alcohol-related deaths in New Mexico, with rural counties like Rio Arriba, Socorro, and McKinley hit the hardest. So what do we do about this? How are we helping people? Turning to page 7, one of the most effective means to treat substance use disorder is medication-assisted treatment, or MAT. This is the use of medications that relieve physical symptoms and withdrawal, normalize one's brain chemistry, and block the euphoric effects of illicit opioids or alcohol to treat either opioid or alcohol use disorder. Now, I want to spend just a brief moment on the terminology because you may have heard this treatment referenced in different ways. The name medication-assisted treatment originally stems from the use of medications in conjunction with psychosocial therapy, like cognitive behavioral therapy. However, research has increasingly shown that medications are effective in treating substance use disorder on their own. Therefore, some organizations and practitioners have begun to use the term medications for opioid use disorder, MOUD, or medications for alcohol use disorder, MAUD, to center the effectiveness of the medications on their own without suggesting that those treated with only medications are receiving an effective or incomplete treatment. In practice, however, MAT, MOUD, and MAUD are often used interchangeably, and we'll use MAT in this report as an umbrella term referencing treatment with medications for both opioid and alcohol use disorder with or without therapy or counseling. Now looking to figure 4 on page 8, you can see the list of medications used for opioid and alcohol use disorder treatment. Public health offices in New Mexico primarily prescribe the pill form of buprenorphine, the main ingredient in Suboxone, that works by diminishing the effects of physical dependency to opioids, such as withdrawal symptoms and cravings, without getting the patient high. MAT has been offered in the Las Cruces Public Health Office since 2007, but in May of last year, the New Mexico Department of Health, or DOH, expanded this offering to more than 30 of its 54 public health offices, highlighted in red in figure 5 on page 9. In general, public health offices offer family planning services, immunizations, harm reduction, and more. Because of their disbursement across the state, expanding the provision of MAT in public health offices was a strategic way to leverage DOH's existing infrastructure to try and reach more people needing substance use disorder treatment and provide a safety net for people who may not have providers in their area they could turn to. As you can see in figure 6 on page 9, DOH divides the state into 4 public health regions. This helps balance state administration and oversight with the need for tailored public health responses for the diverse communities across the state. To support the provision of MAT, as shown in table 4 on page 10, DOH has received $7.28 million each year since fiscal year 24, a mixture of both general fund and opioid settlement revenues. While not the focus of this evaluation, I do want to note that this is not the only mechanism through which the state provides MAT, as you can see on page 11, figure 7. It's important to add, however, that most people receiving MAT in New Mexico do so through private providers, but the state's efforts are key in expanding access to treatment and reaching the most vulnerable populations. To this end, DOH also operates 2 inpatient facilities, the Turquoise Lodge Hospital in Albuquerque and the New Mexico Rehabilitation Center in Roswell, that offer detox services and medication-assisted treatment. The Healthcare Authority also certified 7 community behavioral health clinics earlier this year as part of a 4-year federal Medicaid demonstration that aims to expand mental health and substance use disorder treatment, including MAT. And the state's correctional facilities have also begun offering MAT, though the program is still yet to be fully implemented. This takes us to our first major finding on page 13. That while the Healthcare Authority, or HCA, estimates that over 9,000 individuals need MAT in New Mexico, DOH has treated just 324 individuals in public health offices. If I could draw your attention to figure 8 on page 13, As you can see, the HCA estimates that 9,130 individuals in New Mexico need MAT but are not receiving treatment, with the highest need found in Bernalillo, Santa Fe, Rio Arriba, and Sandoval County. While MAT in public health offices has the potential to treat many of those in need, DOH, HCA, and private providers will all need to work together to get care to those not currently receiving it. Further, if you turn to page 14, looking to figure 9, you can see that while not only do a large number of people need MAT, many are traveling to other counties to receive services. This highlights the need that public health offices are trying to meet as local providers of MAT in communities across the state, while also indicating that people may not be aware of the treatment available in their local public health office, contributing to the low utilization. In the first year of expanded implementation, beginning in May of 2024, public health offices treated just 324 people, 321 of which were for opioid use disorder, and only 3 of which were for alcohol use disorder. In 2024, around 10,500 people submitted a claim through Medicaid for MAT, meaning public health offices are estimated to only be treating around 2 to 3% of this population. As you can see in figure 11 on page 15, treatment has been concentrated in 2 offices in the southern region of the state, with the Las Cruces and Otero County public health offices treating 75% of the total number of people treated in public health offices, likely in part due to the long-standing MAT program operating at the Las Cruces office since 2007. The remaining 25% of people treated were seen in public health offices across the state, with most offices treating less than 10 people, and some offices did not treat any patients. Most of the people receiving MAT in public health offices are covered by Medicaid, with around 60% of visits billed to Medicaid, with the remainder primarily covered by private insurance. For those who are uninsured and cannot afford treatment, DOH covers the cost of their treatment and medications with their uninsured MOUD access program that has helped 27 people since the program began in October of last year. If you can now turn with me to page 16, I want to now discuss the staffing and oversight of medication-assisted treatment in public health offices to speak to how it actually works. In most cases, the staff supporting the provision of MAT includes only an existing clerk and nurse who were trained on the provision of MAT. The Las Cruces Public Health Office is the only office with dedicated nurse and clerk for providing MAT. Telemedicine is also crucial to the state's offering of MAT in public health offices, with more than half of public health offices that have provided MAT doing so exclusively through telemedicine. This is in which clerks and nurses complete the intake and urinalysis and then can set up patients in a room to meet virtually with a physician. Overall, almost a quarter of MAT visits in public health offices were telehealth visits with clinicians. Currently, only a few public health offices have someone in-house who can provide therapy to MAT patients, but those that don't generally try to refer MAT patients to a therapist in the community. Medications are effective on their own. However, therapy can have an additive effect and help engage individuals with long-term treatment by focusing treatment on the individual's particular needs and barriers to success. Therefore, we recommend that DOH work with HCA to develop provider lists of substance use disorder therapists to whom public health offices can refer MAT patients. Looking now to the bottom of page 17, in terms of the leadership of the provision of MAT in public health offices, there's currently no central state coordinator providing oversight. The oversight responsibilities are divided among multiple positions under both the Center for Access and Linkage to Healthcare and the Center for Healthy and Safe Communities within the Public Health Division of DOH. Given this fragmented oversight and separation from the Director of Marketing, who works under the separate Policy and Communications Division, DOH should centralize the management of the program to increase coordination. LFC analysis suggests that DOH has funded but unfilled positions that would give the department the capacity to create a new coordinator position to specifically focus on leading and coordinating MAT implementation. Turning now to page 18. Centralized leadership and coordination could also help with the fact that DOH is not currently collecting any outcome data on providing MAT in public health offices, preventing the evaluation of the success of the program. As it stands, DOH has performance measures around MAT provided on an inpatient basis at the Turquoise Lodge Hospital, the education of MAT for patients already receiving detox services, and measures of harm reduction. However, at the time of this report, DOH did not have any measures addressing the provision of MAT in public health offices, and only was collecting output data on the number of unique visits for MAT and number of unique patients. After this evaluation, DOH has since worked with LFC and DFA to develop performance measures for fiscal year 27 for the provision of MAT in public health offices. DOH does also collect data on outcomes for patients treated at Turquoise Lodge hospitals in patient programs and surveys patients a few months after their treatment on metrics such as the effectiveness of their discharge plan, emotional well-being, physical health, and more. This effort, as well as the academic literature, can inform the collection of outcome data on MAT patients treated in public health offices. To this end, looking now to page 20, to ensure that the funding is having the intended outcomes and that public health offices are reaching as many people as possible, we recommend that DOH work with LFC and the Department of Finance Administration to set specific performance targets for fiscal year 27 and develop and submit an implementation plan as part of their fiscal year 27 budget submission. I'll now turn it back over to Dr. Valdez to present our next major finding.
Thank you, Ms. Klug. If you turn with me to page 21, I will discuss our last major finding. The provision of MAT in public health offices lacks dedicated, coordinated outreach efforts. The Department of Health's marketing of MAT in public health offices is limited, with neither local public health offices nor the New Mexico Pathways website effectively reaching the communities in need of treatment. This is due in part to the regional administrative structure, which has benefits in terms of tailoring public health responses to different regions of the state, but fragments leadership and may undermine accountability in the case of providing MAT in public health offices. That said, some local practices around the state have the potential to improve outreach. If you turn with me to page 22, I will discuss DOH's Golden Opportunity, a coalition of public health and safety organizations across the Albuquerque metro area. Golden Opportunity connects first responders with local service providers so that when they encounter and revive people with substance use disorders who have overdosed, they can seamlessly connect them with MAT services and provide transportation to treatment facilities. Officials note that immediately following an overdose, people with substance use disorders are often most receptive to treatment. Table 8 on page 22 lists the community partners involved with Golden Opportunity. This is a new collaboration as of October 2024, so only a few people have been treated, and program officials noted that the need for housing support in addition to MAT is necessary to be able to treat more patients. On page 23, we discuss a Las Cruces area group of providers, nonprofits, as well as city, county, and state officials that meet monthly in a group called Opioid Plus 360. This group brings together local stakeholders from prevention, harm reduction, treatment, including MAT, and recovery sectors to coordinate opioid response efforts. Such a forum includes officials from the Department of Health's health promotion teams and helps local groups optimize their collective resources by reducing duplicative efforts and promoting ongoing and deep collaboration across entities. Opioid Plus 360 provides an excellent example of a low-cost method of improving the delivery of MAT through careful coordination of the existing resources of a community. In addition to providing MAT in public health offices, the Public Health Division of DOH can also explore providing MAT through its newly purchased mobile health units, which we discuss on pages 24 and 25. Public Health has outfitted these specialized vehicles for vaccinations, STD testing, harm reduction, and other services, but not for MAT. It is worth noting that most public health offices do not stock MAT medications. When they initiate treatment, they write a prescription for the patient, which can then be filled at a typical pharmacy. This process can be a barrier for vulnerable patients and for those in rural areas. Carrying MAT drugs, such as Suboxone, on these mobile health units could help reach patients in need of MAT in rural and remote areas of the state, which may be far from any public health office. However, to do so, public health would need to acquire a Class E clinic license from the New Mexico Board of Pharmacy and register with the National Drug Enforcement Agency, or DEA, as a narcotic treatment program. In addition, the vehicles would need to offload all of the controlled substances, such as Suboxone, every night at a home brick-and-mortar office, which itself would need to stock the medications at a level such that the vehicle would carry no more than 5% of the total stock. Some security measures would also be required to mitigate the risks associated with stocking opiates on a mobile unit, though MAT drugs tend to carry a lower risk of theft. If you look with me at the bottom and sidebar of page 25, we discuss the New Season Mobile Health Unit providing MAT in Oregon, with plans to add units in North Carolina and Maine in the coming months. Notably, New Season, a private provider, collaborated with the DEA to license and equip their mobile unit, which now physically delivers MAT drugs to patients, thus eliminating the barrier presented by having to obtain a prescription and then take it to a third-party pharmacy. Another pathway to connect patients in need of MAT to public health offices is through effective screening. The state collects data on Medicaid-funded screening, brief intervention, and referral to treatment, or SBIRT. SBIRT typically takes place in primary care settings, emergency departments, and potentially public health settings. However, if you refer to Chart 5 on page 26, you will see that this type of screening is at its lowest level since 2020. This means that even as the state has invested in MAT and expanded the number of entities providing MAT and locations where patients can be served, referrals from SBIRT, some of which could be served by public health offices, have declined. The 2024 GAA appropriated $15 million to the Healthcare Authority for fiscal years 2025 through 2027 for evidence-based behavioral health services, which include SBIRT. These investments should increase SBIRT, which should provide more referrals into public health offices, as well as referrals to private providers across the state. Next, if you will turn back with me to page 2, I will go over our key recommendations. First, the legislature should consider reevaluating the effectiveness of MAT provided in public health offices after Department of Health, LFC, and the Department of Finance and Administration establish specific performance targets for FY27. If targets are not met, the legislature should consider diverting the funding toward other effective MAT treatment options. The Department of Health should centralize the management of outreach and marketing efforts of the provision of MAT in public health offices to help focus the department's efforts and clearly define the relationships with and the roles of regional staff. The DOH should also work with LFC and DFA to set specific performance targets for FY27 through the Accountability in Government Act to evaluate the volume, efficacy, and impact of MAT provided in public health offices. The DOH should also develop and submit to the LFC an implementation plan that includes performance targets and plans for marketing, outreach, and program leadership, including filling a state coordinator position with vacancy savings as part of the department's FY27 budget submission. Lastly, the DOH should expand outreach and marketing efforts of the provision of MAT in public health offices, targeting New Mexicans with substance use disorders with direct marketing and advertising to vulnerable populations. And thank you. I will now turn it over to the Secretary of DOH for a brief response.
Thank you. Madam Chair, members of the committee, I'm Gina de Blasi, Cabinet Secretary for the New Mexico Department of Health. I have a brief presentation that I'll go over quickly. I won't take too much time on this, but very high level. We coordinated very closely with the staff, and we agree with the recommendations. So there's really no pushback here, but however, I do want to say that I think it's important to note that the Department of Health is really the safety net provider within its communities. If you look at MOUD and service delivery across the state, many are coming through other community providers and a lot of the federally qualified health centers as well. What we're looking at is that we've got 40 of our 42 offices that provide clinical services now provide MOUD that create that critical safety net that I just spoke about. One of the things that I think is really important as I've come into the Department of Health is I don't believe that communities really understand what services are provided in public health offices. So one of the things that we're working on within the agency is really trying to get the word out. Here's your public health office. Here are the services that are provided, because there's a lot of great work that's being done there, and I just don't believe the community truly understands what all can be provided within our public health offices. So we're working on that as well. What we've done is we've expanded telehealth capacity to allow for MOUD services at each and every of our clinical public health offices. We've created the Uninsured Access Program to broaden the access to MOUD. We're working with corrections, probation and parole, and we've trained them on the Department of Health referral system. This program is in its infancy, so the teams are continuing to meet to refine those referrals and how many people that will come into the public health offices for treatment. We're utilizing the Department of Health hotline as an access point where a lot of calls come in for individuals looking for services for any type of healthcare services, and we did see an increase in requesting services for medication-assisted treatment. So we've been staffing our Department of Health hotline with those individuals to help support that. We're working on a pilot project to actually dispense and deliver MOUD through our public health offices. That would be in, it's Doña Ana County, Rio Arriba County, and I believe Curry. And we hosted a statewide training for nurses, providers, and other support staff to just educate on the referral system for MOUD. Our response to LFC recommendations that you can find on page 4, the centralizing the program management and marketing, we agree. We're looking at hiring an expansion coordinator, but I was just notified last week, and it was identified in the report that we received some opioid settlement dollars to help support our MOUD program. And for this fiscal year, for fiscal year 26, we're usually getting about $3.5 million. It's just under $900,000. So we're really trying to figure out how we're going to help support this, but we'll make it happen. But we're really going to rely on those dollars was to purchase the injectables for buprenorphine. We're working on strengthening our collaboration with New Mexico Corrections Department, as I mentioned earlier. And we actually just completed the training for our health promotions teams that are in the communities, should be out working in rural New Mexico or even in the urban areas, informing people of service availability and supports through public health. And we're working on developing a more comprehensive marketing plan that I think will be very community-based on what the needs are versus just this big, huge. We could do an overarching marketing plan, I think, on public health as a whole and touch on MOUD, but I think it's really the roots on the ground, working with communities, working with community providers, using our health promotion teams, getting out to our local providers, letting them know that we're there as the safety net. We're developing an evaluation plan. In the Southwest region, we had surveys designed to measure clinical outcomes. Those are currently underway. And we're including additional performance targets as suggested within the report. Looking at expanding alcohol use disorder through public health, we're going to build on our current MOUD infrastructure to integrate alcohol use disorder treatment. We'll assess the protocols, training needs, and public awareness strategies to support alcohol use disorder treatment expansion. And then, as I stated earlier, we'll develop and submit an implementation plan, looking through community engagement, the mobile health unit plan, strengthening counseling service options through our offices, the dispensing medication pilot, enhanced expert training, and also maximizing the revenue. For the mobile health units, we have 5 of those. It's really not the DEA licensure that's the problem. It's really more the State Board of Pharmacy, so we're working with them on what that looks like. And we're thinking that it could potentially be, the unit would be a clinic expansion license, like a satellite through the public health office. So we're looking at that and having those levels of conversations. We're looking at the feasibility of providing the long-acting injectables via the mobile units. However, I did say that, we're probably a little challenged as it relates to the funding for that currently. And with that, Madam Chair, I will stand for questions.
Thank you, Madam Secretary. I'm going to just call on everybody. So at this time, we'll start at this end. Representative Johnson, and I'll give you 4 minutes. Well, let me look at the agenda. 4 minutes.
Thank you, Madam Chair. Thank you for your presentation. I understand we have an office here in Gallup. So with that being said, do you know if we work with the surrounding chapters? We have many local Navajo government chapters surrounding the Gallup area within reach, and I think a great place for presentation, information sharing, even spending the day providing a booth and whatnot. Thank you.
Madam Chair, Representative Johnson, we agree. As a matter of fact, we just hired a tribal opioid response coordinator, and we're working on contracts specifically for that. And we've got 4 deliverables specifically within those contracts, and it's to deliver MAT to tribal members, who most are already in the development of their programs. We're providing overdose prevention education, including naloxone distribution. We're conducting community events to help support that, and we're looking at developing some community workshops as well.
Thank you. Thank you, Madam Chair. Thank you. Please keep me in the loop. Thank you.
Thank you. Senator Pope.
Thank you, Madam Chair, but I'm going to go ahead and pass.
Representative Lundstrom.
Thank you, Madam Chair. Can I have his time? Okay, I got to say, Madam Chair, I'm shocked. I'm blown away and trying to keep my blood pressure down. When I think about what I just heard from this LFC evaluation, when I think about that these people that have major alcohol disorder in my community have not had access to this MAT treatment in a public office that's right across the street. That's completely unacceptable to me. And I'm chairing the committee that is supposed to be defending now why we don't want to lose Medicaid. And if this is Medicaid money, I want to know why this stuff isn't out there in the communities where we need it. The public health office is literally right across the street. And when I hear that we only had 3 MAT patients for alcohol assistance, that's ridiculous. I can find you 3 in this building. I just need to tell you, Madam Chair, this is alarming. It's nonsense, and it's a damn good thing I'm not a voting member on this committee. Thank you, Madam Chair.
Thank you, Representative Lundstrom. Representative Anaya.
Thank you, Madam Chair. I was looking at the SBIRT utilization in particular, and I had a couple of questions about this. If we knew that this was, if we knew that the utilization was a problem, I'm just wondering why we didn't get some of the training to use this screening tool into place a little bit earlier. That's the first piece. But the second piece, if I'm recalling some conversations that I had, I can't remember if it was you, Madam Secretary, or if it was within this committee, but there was the idea to have the public health offices essentially become primary care sites. And I'm wondering what those plans look like now, especially in relation to MET. So if you could just speak to those 2 things, that would be great.
Sure. Madam Chair, Representative Anaya, I'll start on the latter first. Yes, we're looking at expansion of primary care out of our public health offices. It's really the availability of the providers and our ability to attract providers within our public health office. Most of them are nurse practitioners doing a great job. And so that is in its works. We did we're working with the Mescalero in Ruidoso because there were some challenges with access there. So we entered into agreement. We're staffing with the nurse practitioner. We're pulling the community in and providing primary care services. We're doing that at our Midtown in Bernalillo County and a few of our other public health offices in the state, but that is the goal, to expand primary care out of public health office, so absolutely. As it relates to ESPERT training, the ESPERT training is typically provided through a contractor out of the Healthcare Authority and the Behavioral Health Service Division. So I just think it really needs, been working with the Healthcare Authority on really reinvigorating what needs to be done there with getting more of those trainings and those screenings completed.
Thank you, Madam Chair. I would ask about juvenile MET, but I am imagining that my colleague will be asking about that, so thank you.
Representative Chavez.
Thank you, Madam Chair. And yes, I was going to ask about juvenile MAP because I don't see, Madam Chair, any reference to what kinds of services are provided to juveniles, especially those juveniles who are in correctional facilities, juvenile correction facilities, and juveniles who might be in CYFD custody.
Madam Chair, Representative Chavez. So after the LFC committee hearing, I did a little bit of research on that, and what I'm finding is that it's mixed. So depending on where those referrals are going, for example, I met with the Adobe program in Bernalillo County last week, and they're receiving those referrals from the Juvenile Detention Center and providing the provision of MOUD for youth. Our own Sequoia is currently not, and that will be changing. So I'm working with Dr. Miranda Durham, who is our Deputy Cabinet Secretary and also our Chief Medical Officer, to look at working with that medical director within that facility to start providing that level of service. So it's mixed on whether they're receiving those services or not, and it's depending on where those youth are being referred.
Madam Chair, yeah, I don't think that that's necessarily how we should be approaching it, because basically what I think is happening is that we are allowing the facility or the provider to really make the decision, and the decision needs to be made by the kids who are experiencing substance abuse disorder or alcohol abuse disorder. So I think we need to change that. These kids need to have the services available to them. We have the money available, and I think that we need to make it a requirement of the facilities that we are referring kids to, so that they are able to receive MAT. The other questions that I have are related to community partners. On page 22 of the LFC report, it talks about the Albuquerque community partners. And there's one that I have in mind, and you know, I don't know why they're not on the list, Madam Chair. Albuquerque Healthcare for the Homeless. They do a lot of street outreach, and they're probably one of the biggest providers of healthcare to unhoused. So why aren't they on this list?
Madam Chair, Representative Chavez, these were the partners that signed up initially, and I would add that this program has only been in place since October, and so they're still recruiting community partners. I think the idea was to bring together as many partners who are already working in this space as possible to make it so that they could provide as many services, wraparound services, to these vulnerable populations at the time right after they overdosed, when they're most likely to be receptive to those kinds of services. And so I think that Golden Opportunity would welcome additional partners that could provide the services that they are looking to provide to those folks. And I think in the limited time that they've been operating, their main gripe is that they don't have enough partners. Like that they are able to connect people with services that they need, but that they did note that being able to provide more wraparound services would make it possible for them to serve more people. And so getting Golden Opportunity in touch with additional organizations would enable them to provide more services to more people.
Yeah. And Madam Chair, just going back to services being provided to juveniles, I would think that crap. Can I finish? Thank you. That places like Amistad in Albuquerque, New Day, and I'm sure there's other facilities around the state that provide services to unhoused youth might also be good places for outreach, because I don't think that necessarily locating MAT services inside of the public health office where you expect people to go is necessarily the only approach that we should have. Thank you, Madam Chair.
Representative Ferrari.
Thank you, Madam Chair, and thank you. This is great information. And I'm glad to see how Department of Health, you are responding to a lot of these things already. It's just a matter of how quickly we can get the support and the funding. I'm not sure where to start. I'm appreciative of the youth treatment that we need in our detention centers. They, I believe, are getting some of the telehealth, but if they need more than just telehealth and more in person, is that available?
Madam Chair, Representative Ferrari. So for additional counseling and supports, I'm without knowing all the details here, I'm going to say for the most part, yes. However, it's going to be dependent again on where those referrals are going. So whichever community provider is receiving those youth and what the service provisions are. I know that the Presbyterian Health Plan is the single MCO for children in state custody, and it's definitely something that they've got a robust network to provide those services for individuals or for youth that are in the children in state custody.
Madam Chair, Representative, if I may, I'd also like to highlight that one of our analysts at the LFC will also be doing a follow-up report specifically on MAT for juveniles involved in the justice system as well. So you'll hear that later this fall.
Great. I appreciate that. Just to be reassured there's more than just, what can be done by telehealth. Also, Madam Secretary, as you mentioned, opioid money is going down to like $900,000, I believe. Are things like and other Medicaid cuts going to impact, what is available through the Department of Health?
Madam Chair, Representative Ferrari, so the opioid settlement money and the distribution of those opioid settlement dollars, the legislature in past years has appropriated additional funding through a distribution to other agencies. However, this last session that didn't happen, so right now it's just that 5% distribution that's in statute, is what I understand. And as it relates to the Medicaid dollars, I know that's a lot of, it's a big topic, a lot of conversation that's really sits with the Healthcare Authority. We do get some supports and funding, but if you think about the provision of individuals that will no longer be Medicaid eligible in the future, and what we do within our public health office and we bill for Medicaid, what's going to happen is more of the uninsured will probably come in, and that will probably increase the funding necessary to provide those supports.
Representative Ferrari, I'm going to pause your time. So was there a request for more funding that the legislature didn't pass, or was there no request?
Madam Chair, there was no request. I think it was just, without being in the details of it previously, I think there was an assumption that distribution, there would be money within that distribution, but that didn't happen this last session. And my assumption may be because of Senate Bill 3 and all the work that's being done there as well.
Not to be on you, but we can't fund if you don't ask. Go ahead.
Thank you. And also, I'd just like to note that as you're working Department of Health and HCA with communities for some of these different programs to be expanded, that the alcohol harms alleviation funding could be used for a lot of these different programs and also for the prevention. But also, we need to get the word out to people, because I didn't realize Las Cruces or Doña Ana County was using the MOUD so well, I guess because of long-term, but there isn't much advertisement. And I know social media and TikTok that kids would be able to see a lot of different things, but we also need to include the El Paso media for helping to get more of that word out. So thank you.
Thank you. Representative Jones. Surprise.
Thank you, Madam Chair. Thank you all for your presentation. A lot of information. I'm just to follow up on what Representative Chavez said about street outreach in Albuquerque. I know that that is staffed, maybe medically led by UNM nurse practitioners. Seems like that connection would be easy. They do really great work. My concern is with the mobile units. I think mobile units, especially in our rural areas, are so important for all sorts of healthcare access. But, you know, MAT is a combination of necessary drugs and counseling. And so how are we making sure that we're treating people as individuals with goals and hopefully a goal and then assessment along the way that allows wherever possible for people to become drug-free rather than drug-dependent for life on a mobile unit that just brings them drugs? That's my question.
Madam Chair, Representative Jones, yes, that's one of our, we'll be working with that within our plan to look at how we improve those counseling and supports, whether it's through the public health office or through our mobile outreach.
Thank you, Madam Chair. So it seems like it would be really important to work with the local DOH then with a mobile unit that have that connection to really treat people as individuals, like I said, rather than just by a plan that says give this drug. A lot of times the conversation about juveniles especially, they don't always know what they need. They might need help, but even adults don't know necessarily until they've had counseling how to get better. So I think that's very important. Thank you very much.
Thank you. Representative Block.
Thank you, Madam Chair. Thank you all, Dr. Valdez, Ms. Klug, Secretary de Blasi. So just making sure I'm understanding, I'm in Otero County, so we have the Otero County Health Center. And so we have had a lot of visits according to your data on your little cool pie chart. By the way, thank you for that. It's very easy to read. So I'm just wondering, why is it that we have such a high concentration in Otero County when places like Bernalillo County, where I believe there's 3,000 plus people in need, are not getting that? Why is it that we're doing such a, I wouldn't say great job, we don't want more people to visit these clinics, but I just want to make sure that I understand why we are kind of in that target zone, Madam Chair.
Madam Chair, Representative Block, the reason is that historically, Doña Ana County has been a leader in providing MAT through public health offices and has been doing it since 2007, I believe. And as a result, there's been more targeted outreach. They've worked with more community organizations and they have more community partners and have been able to kind of more effectively leverage those relationships to bring awareness to the communities that are most vulnerable and most likely to need those services. And that has been kind of true regionally. So if you see, you know, the utilization rates across the southern part of the state reflect that kind of longer time frame. And those are the kinds of goals that we have for the rest of the state, to bring those same kind of awareness and partnerships, to bring more of those vulnerable populations in need of the services, to know that they can go down the street to their local public health office and get those services. And so the answer to your question is that they've just had more time to implement these kinds of awareness strategies and have been effective at that end.
Okay, thank you, Madam Chair. Thank you for that, Dr. Valdez. So I'm just wondering, when it comes to the Otero County facility, can you just tell me what we're doing when it comes to getting information out. You may not know specifically every single county, and I understand that, but I'm just kind of wondering what it is maybe the department is doing or what we're doing in our community to get these services to people. And 105 people is actually not very high, but if you look at the state, which is what, 370 something, it's a big portion of that. And I'm just kind of wondering how it is that we are the ones that are kind of the center of that. And I know it's kind of a rehashing of that question, but maybe this is a question for the secretary.
Yes. Madam Chair, Representative Block, absolutely, and that's one of the things that I've been looking at and working with a team in Doña Ana County and Otero County is how can we utilize what's been done there, understanding that that's been in place since 2007, so it's been a long time. So there are a lot of relationships and community connections within that community that helps drive that volume. And what do those relationships look like, and how can we build upon that and take that to the other regions in the state?
Thank you, Madam Chair. Thank you for that. And I know I'm running out of time, but real quick question about, I believe you said the pharmacies. We're sending folks to pharmacies to get these prescriptions filled. I know we have a lot of pharmacies in my area, so I'm just wondering what that utilization looks like, because I know places like Las Cruces and even where I am in Alamogordo, we have a lot of pharmacies. So is that something that's driving these people? Is that something that you consider a factor versus a different county, let's just say, that's extremely rural that only has one pharmacy? Madam Chair.
Madam Chair, Representative Block, we do see that places where there's very few pharmacies, that does present a major barrier for some people to get the medications they need. If there's only a single pharmacy, we heard stories about people might not be allowed at that pharmacy, or it might be difficult for them to get to the one pharmacy. Some of our counties in New Mexico are very large, and having one pharmacy might be an hour or 2 hours away from them, which for somebody who is in a vulnerable position and has a substance use disorder, that can be prohibitive, which is part of what drives our recommendation to have mobile health units to kind of bridge the gap in some of those places, and then just to raise awareness so that people can plan and realize that they can drive an hour and get the medications that they need, and they need to plan for these kinds of things. And I think with better outreach and better education, those communities will be more aware of what's available to them and kind of the barriers that are out there. And we can also work with the Department of Health to knock down some of those barriers and enhance accessibility.
Thank you, Madam Chair. And I hope we get all those informative stuff out to people, because that's how we know how we can get these people in these programs. I hate to see millions of dollars just sitting there and not being utilized. So thank you all. Thank you, Madam Chair. And I think that would be something that would be a low-cost thing to do, but also a very high-reward thing. So thank you.
Thank you. And Representative Jones had a follow-up, and she did have time left.
Yes, thank you so much, Madam Chair. Yeah, I just wanted to point out that the access to detox drugs and, MAT treatment drugs has been an issue. Just this last session, Chair Thompson and I passed a bill, HB 171, that, well, let me back up and just say what the problem was at some of the rehab facilities that were considered custodial care facilities. They were unable to admit patients during certain times of the day because they were dependent on local pharmacies. And as kind of a side note, but this is so important, even in Santa Fe, I don't believe you have a 24-hour pharmacy. And even if you do, they may not have those drugs available. So when you're looking at having Pharmacy Act changes that apply to mobile units, you can look back at what we've done. They're in the process of changing the custodial care rules so that they can actually have, they can keep on site the detox drugs that they need. So they can admit patients at any time of day, which I think was a huge victory for us in treatment across the state. We were really in the dark ages, but they're changing pharmacy rules already to have those drugs available. So somehow maybe that will make it easier for us to make mobile units available, drugs in mobile units available. Thank you. Thank you, Madam Chair.
Representative Jones. Representative Chavez.
Thank you, Madam Chair. Thank you for that presentation. I think a lot of my colleagues have asked a lot of the questions, but I can't help but echo what Representative Lundstrom stated. I mean, we are in ultimate crisis, and it frustrates me that we have had funds available that are going unspent, And I really can't believe that we're going to wait 2 more years to evaluate and move forward. So that to me says, I think we need to do something as a committee. I would like to hear strategies in the upcoming session for your outreach, because if we're not going to change anything for 2 years, we need to know what your strategy is and how you're going to move forward and do outreach to these community partners. As Representative Chavez said, I was just at Healthcare for the Homeless visiting with them last week, and they do so much, and it is wraparound services. People come in, and so my question for you is, especially with the DOH facilities and the small facilities that we have available, how does that work? Because you said there's a clerk and then there's a nurse, and then they set them up from telemed. So does that mean that walk-ins are unavailable, or they can't just walk in? Because that is a majority of the time with the crisis we're seeing what those individuals need.
Madam Chair, Representative Chavez, the one thing that public health offices all will do is if you walk in, they will treat anybody that comes in. They'll, whether they have private insurance, Medicaid, or they're not sure. The public health offices, one of their baselines that we heard around the state was that anybody who walks in, they will treat. And that's part of their mission as like a safety net, like safety net organizations. You heard the secretary talk about that they are like kind of the backstop that anybody can be treated there. So with regard to Matt, if somebody walks in without an appointment, without any reservation or anything else, they will be treated.
Thank you, Madam Chair, and thank you for those answers. How does it work regarding somebody, say, that goes into, for my county, UNM, because this is what happens a lot of times. They go in, they go out. They go on detox, they get out, because they don't have anybody available to help them with these addiction issues. So do you work well with UNM, and do they know that they can go to DOH for assistance, for treatment, instead of waiting weeks on end, and then they get back into this vicious cycle instead of addiction?
Madam Chair, Representative Chavez, we've got a very close relationship with UNM. As a matter of fact, over the last 2 weeks, last week I met with the Adobe program. 2 weeks prior to that, we met with Milagro and the Focus Clinic. UNM has a pretty robust delivery system as it relates to addiction services and supports. The one thing that I asked of the university is that we need to have improved communication and collaboration. And I think we can always build upon that, and that's definitely the goal between the Department of Health and the university. There are some things that we may not know about that might be happening that we could probably do some better follow-up on, but if we only knew. So we're trying to figure out what those, potentially maybe data sharing agreements or establishing a cadence of case reviews amongst the Department of Health and the university clinics in order to improve that.
Thank you, Madam Chair. Thank you for that. Data sharing, we need to do that. If you need to set that up, absolutely is a need, because we need this information. So I'll just close. I had many other questions, but I'm sure maybe he'll ask. But I'll just close with, I hope in this coming session that we ask for your outreach strategy and we see what that is instead of waiting 2 years to see if it works out. Thank you.
Minority Whip Martinez.
Thank you, Madam Chair, and thank you, presenters. Just a couple of quick questions. Did I understand correctly that you're just now working on performance standards for this?
Madam Chair, Representative Martinez, additional enhanced performance standards. We are currently, as Dr. Valdez said, just tracking really the number of individuals that we were providing services to. So we really want to look at more outcomes-based data in order to provide that level of understanding of the program and whether or not we're having impact.
Thank you for that. On page 13 of the LFC presentation, it struck me that the Healthcare Authority estimates 9,130 individuals need MAT. DOH has only treated 324. Is this because there's no outreach program and you're just waiting for them to come to you?
Madam Chair, Representative Martinez, again, we're the safety net, so I don't see Department of Health treating 9,000 individuals who need those services. I do see Department of Health working with community providers to provide that level of referral and support so the community providers are receiving those referrals, whether it's through us or other community organizations. The other thing that I will state in not an excuse because highly accountable here. This is a new program for the expansion of MOUD at the Department of Health outside of what the department had been doing for a long time in southern New Mexico. So this program really, I would say, got off the ground. While it may have started last spring, it really didn't start pushing things through until late summer, early fall of last year. So it's relatively new.
So it sounds like DOH is not, you're saying DOH is not responsible for treating these people. Is that correct?
Madam Chair and Representative Martinez, DOH is responsible to ensuring that anyone who needs services, and we have that level of outreach and supports and referrals. If they can't get it within the community, we should be providing that within our public health office. So I wouldn't want to say that I'm saying that we're not responsible. We are highly responsible.
So, Madam Chair, Secretary, who is ultimately responsible for this? Is it DOH? Is it HCA? AOC? Who is ultimately responsible for this?
Madam Chair and Representative Martinez, I think it's everyone. It's the healthcare authority ensuring that whether they've got Medicaid, that the provision of the behavioral health service network, we have enough providers in order to provide that level of service. Healthcare authority just is expanding their certified community behavioral health clinics, which is wonderful. We're starting to see those starting to open up across the state. It's with the MCO providers and ensuring that the MCO care coordinators are making those connections for the individuals who need those services. And it's with Department of Health. When we recognize a need within the community, that we are addressing that need to the point of Representative Lundstrom related to alcohol use disorder. What are we doing? How are we providing those supports and ensuring that people are receiving those services? And it's on the community providers as well through their outreach. So it's all of us involved. And that's why those stakeholder and community regional meetings are so important, because it takes everybody to ensure that we're trying to figure out this fragmented system of healthcare delivery.
Thank you, Madam Chair. Just one quick last comment. I think that's the problem. Everybody's responsible. We need one agency to take the lead. If one agency steps up and says, we're ultimately responsible, we're going to work with all the other agencies, I think we see that number rise, and the money that we're budgeting for this program, I think we then see real returns on that investment. So I would suggest we find one agency, make them ultimately responsible, and work with the other agencies. Thank you, Madam Chair.
Thank you, Representative. Representative Gonzalez.
Thank you, Madam Chair. I just had a question looking at the dots and the maps. What determines what health offices provide the MOUD or the MAT services? In particular, I'm in San Miguel County, looking at Torrance County, where they don't have any services. Yet in that county, 71% of the population, relatively receive Medicaid services as a percentage of the county population. And I know Torrance County, it's notorious for them expecting them to come into Albuquerque, coming into Bernalillo County for services. And Mora, although they're not in my physical district, still one of those underserved, underpopulated areas. What determines whether you do offer MAT services or MOUD services through a public health office?
Madam Chair and Representative Gonzalez, really, as it relates to Torrance County or what that determination is, it's the availability of a provider within that community. So our ability to attract a provider at the Department of Health to work out of that public health office in order to deliver those services.
Thank you, Madam Chair, and thank you for that. And along with that, is there a listing somewhere in existence, again, new to this committee, that does list other entities that do offer, say, these MAT services outside of the public health offices? Is there just a general listing of who does provide these services in these counties, if not getting it from the public health office? Thank you, Madam Chair.
Madam Chair and Representative Gonzalez, we can get that delivered to the committee if needed. And typically what you'll see within the rural communities, it's mainly a lot of the federally qualified health centers that are providing that service.
Thank you for that. I guess as a follow-up to that is, the San Miguel Treatment Center is upcoming, and I'm assuming that will take some of the brunt of this load, particularly from some of these nearby counties. So that is hopefully, future services to be able to be offered. And I also want to echo, I'm a big proponent of mobile units. I've long thought dealing with transportation, school transportation, but just transportation is such an issue in the counties that I serve and counties that I work with on other areas. And this mobile unit model, I've thought for veteran services, possibly for this, that it could be utilized in a lot of these smaller areas. But I do also want to echo Representative Jones' sentiment about the wraparound services that do come with this, not being like a one-stop, versus providing a checkup versus you're now providing treatment services that do need that follow-up. But if we can find a way to make that happen, hopefully for some of these counties, that would be a way to utilize some of those services. So thank you, Madam Chair.
Thank you, Senator Charlie. And excuse me, senators, if I say representative, that's my norm, so just excuse me.
Thank you, Madam Chair. I am going to ask all of my questions because I want them all on the record. So if you just want to keep up with me and then we can answer. I like making rules work for myself, so I'm going to do it this way. When it comes to outcomes and accountability, from what I can tell in the report, it shows that we're only counting visits, not outcomes. And so I'm curious when DOH is going to start reporting on patient outcomes like retention, relapse, recovery milestones, and overdose reductions. In terms of equity and community partnerships, Madam Chair, how is DOH ensuring that MAT delivery in public health offices is culturally relevant? I do appreciate the answer to Representative Johnson's question, but I'm thinking about tribal and rural communities, Hispanic communities, where there is so much stigma about going in and engaging with these systems, and that remains a barrier to treatment. My third question is around jails and corrections. Given the high rates of substance use disorders for incarcerated populations, what steps are being taken to expand and ensure that MAT is being implemented within the detention centers? And then I really am interested in how DOH is coordinating with corrections, jails, sheriffs, to ensure that when a person is released, that there's a continuum of care. And then finally, I am, Madam Chair, concerned about alignment and duplication of services with this behavioral health package that was passed. How is the rollout of MAT and public health offices aligning with this behavioral health package that was just passed in 2025? Are outcome measures aligned with those within SB1 in particular? And what cross-agency structures are in place to ensure that health offices under MAT services are not being duplicated and that we're not recreating silos? I worry about parallel systems without coordination, Madam Chair. Thank you.
Madam Chair and Senator Charlie, thank you for that. So outcomes and accountability. We are doing exactly that. We're working with Department of Finance and Administration, and we're establishing some new measures for the level of accountability and outcome that we will be reporting on. We're not going to wait to fiscal year 27, not even for the strategy and plan that Representative Chavez spoke about earlier. We're working on that currently now. So absolutely, we're going to look at how many people maintain within their treatment, where were they referred. There's a lot of different provisions that we are working on, and that's going to build upon our plan. So happy to get those to you once they're finally developed, and that should be actually pretty shortly. So happy to do that. We're doing a lot with the tribes, also working a lot with communities, and utilizing health councils and our health promotion team to help provide that level of support to ensure that we are appropriately and culturally engaging within our communities in order to provide education and supports and other services within those communities. So that will be part of the plan as well. Jails and corrections, it is my understanding, and this would have to go to the Corrections Department to completely answer the question. However, the Department of Health is currently working with the Corrections Department. Corrections is still building their program, so we're going to anticipate more referrals as the program moves along. We, at the August 8th meeting, Corrections reported they have 121 patients maintained on Suboxone within NMCD, and that pilot program started in January of this year. They don't do new starts, but what they do is they'll maintain people on Suboxone, so that's something that we're talking to the Corrections Department about. During this time, only 2 individuals have been referred to us that have been released to the community. As I stated, this is new for them, so we anticipate that number is going to increase over time. And we've built a centralized referral system for probation and parole. So we're going to start to see those numbers increase. And then all they have to do is just call the Department of Health, and we're ready to receive and provide those services and supports. Let's see. Department of Health and the coordination with the continuity and the continuum of care, that's exactly the reason for our relationship with the Corrections Department. So as individuals get released, we want to make sure that those services don't drop and we're able to provide that level of continuity. And whether or not those individuals want to maintain that service within the public health office, or they'd rather to go to a community provider, we can be the bridge and that support to do it. Alignment and duplication of services. And so we work very closely with the sister agencies that provide these levels of support. The Healthcare Authority and Department of Health work extremely close, as do Children, Youth, and Families for the youth who are needing services, corrections, and also now that the housing office is over at the Department of Workforce Solutions. So the duplication of services is something that we don't want to see either. As I stated, the Department of Health is the safety net for the provision of services. There are community providers that don't want us to be their competition, and we get that, right? And so they're doing the billing for those services. We are the safety net. We will be that bridge. And if individuals want to have their services provided at the Department of Health, we will do that. It's a little more challenging in some of the smaller communities when you have an FQHC that's providing most of those services there. We want to make sure that we are coordinating and communicating and making those appropriate levels of referrals to the FQHC if it makes sense and if that's what the patient wants.
And just a reminder, it's 4 minutes for questions and answers. But you're new, so and you got your questions in. So I have a bit. So for LFC on chart 3, many of us are older. These colors are next to impossible to discriminate. I like red, yellow, green, and blue, or orange something, because it's like, ooh, which is this, which is that? And I have good eyes compared to some folks I hear. And table 5, I don't know what page that is, but are those individual patients or visits, the numbers that are there? Page 15. Yeah, the second part of table 5, are those are unique patients?
Madam Chair, with regard to Table 5 on page 15, the bottom are the number of individual enrolled patients. The top are just number of claims. So an individual patient could make multiple claims.
Okay, so we have 20, at this point, we have 27 enrolled patients and 17 that are actively using the program for meds. When you did your evaluation, I don't mean currently per se.
Yes, at the time of evaluation,
Okay.
that's accurate.
Okay, and Madam Secretary, I know you're new, and I am not happy about this at all, and it's not personal by any stretch of the imagination, but, and then just another question on table 8. I should have written the pages down. It says one of the partners is Bernalillo Fire and Rescue. Is that Bernalillo County or Bernalillo Town?
As far as I recall, Madam Chair, that is Bernalillo, the town.
Okay, thank you for that. Just a hint that Bernalillo County Fire and Rescue should also be involved because they cover a lot of Albuquerque. Let's see. And just in terms of the partners for that program, the list is disappointing. The healthcare for the homeless just jumps out. That should obviously be there. And so I'm wondering if there has been exclusion or if it has just been a lack of awareness from the providers that DOH has not yet done the outreach to those. I know one phone call and they would be interested. So I'm wondering why that list isn't longer.
Madam Chair, we don't have information on how those groups were put together. All I can say is that they have only been working together since October, and that there was a lot of enthusiasm among the groups that were working together. And so I think that if they were able to connect with more agencies that wanted to help, that they would be eager to do so.
And that's my point. Thank you. So Madam Secretary, what is your budget for outreach for this program? What is it currently, and what do you anticipate, and what will you ask for?
Madam Chair, we currently don't have a budget for the program for outreach, other than utilizing our health promotion team. What I will be asking for is probably in the nature of close to $1 million in order to do that outreach. I've seen that with, we're doing that currently now. If hopefully you've seen it with our Safe Sleep campaign. Seems to be pretty effective. We're getting a lot of response to that. But in addition to that, it's really going to take more, in my opinion, boots on the ground, community involvement, pushing with our health promotion teams, working with the health councils, working with the local community providers, in addition to an overall marketing plan.
Thank you for that. And again, going back to Table 8 on page 22, how did DOH reach? How did you get the partners you've got? What was the outreach, or what? Just tell me how these partners were recruited, chosen.
Madam Chair, as you stated, I'm not going to sit here and pretend to know I don't know. I'm new to the department, but I will definitely get a response to that. And sitting here and listening about healthcare for the homeless and how they're not involved, that's actually, in my opinion, pretty surprising. And I'm going to sit here and say that I'm thinking that they are involved. So I will do that follow-up and get back to the committee no later than tomorrow.
Okay, thank you for that. And then just a few statements. So handing someone gets to the point where they're ready for help, and they go and you hand them a prescription. You may as well not in probably 90% of the cases. Things are going to change on the way to the pharmacy. It's really disappointing that we don't offer immediate treatment. And I know there's restrictions, and I hope that the department is working their butts off to try and get with the Department of Pharmacy, whatever, with the LFC, whoever needs to do that, because it's everything we hear on the news can be directly or indirectly brought back to this: crime, problems with CYFD, healthcare costs, domestic violence. All those things have substance abuse plays a large role, and we're saying here, well, we'll get around to it, and I'm really disappointed that that Doña County has had this for 18 years, and DOH has never attempted to replicate it. And again, Madam Secretary, none of this is directed at you. It's just frustration. And I texted the former chair, Senator Ortiz-Pino, to find out when we passed medication-assisted treatment in the prisons. It's been at least 5 or 6 years. The pyramids were built in less time than it's taken our corrections department to get MAT up and running. 2 patients? We were thrilled with 1 last year because it had been years of 0. I'm throwing it out there. This is unacceptable. And we will have the Department of Corrections Secretary here today. And this is ridiculous. Overdose death when people get out of prison are incredibly high. We have so many ways that we could interrupt the cycle, and we haven't bothered to do it. And I'm very frustrated, and I'm very angry, and I'm cranky. So with that, I think that's the end of my rant for the moment. And then I will allow our Vice Chair to introduce herself.
Thank you, Madam Chair. Linda Lopez, Senator District 11, the Southwest Quadrant of Bernalillo County. And I wasn't here for most of the presentation, but I say ditto for many of the questions that were asked today as I've read through the presentation. Thank you.
Thank you so much for your presentations. Okay, we will move to juvenile justice overview from Carly Malone from LFC. Whenever you're ready. I'm sorry, but I could be a waitress. Get your mouth full and say, how is everything?
There we go. Good morning, Madam Chair and members of the committee. My name is Carly Malone, and as of a couple of weeks ago, I am the new analyst for CYFD and workforce at the Legislative Finance Committee. I was with the Legislative Finance Committee about 10 years ago and just returned to the state and returned to Legislative Finance Committee. So I just wanted to introduce myself since I'm a new face. I'm going to provide kind of a broad overview of juvenile justice this morning and provide kind of some of the history, some of the process, some of the trends that we're seeing, and then discuss some of the best practices recommendations that the LFC has made in the past. I will note at the start that the LFC is working on a new evaluation of juvenile justice, both secure facilities and informal kind of community services, that is slated for this fall. So there will be some additional information kind of coming on the trends and recommendations front. So just kind of the overarching purpose of the New Mexico Delinquency Act, and to quote kind of the primary language, is that consistent with the protection of the public interest, to remove from children committing delinquent acts the adult consequences of criminal behavior, but to still hold children committing delinquent acts accountable for their actions to the extent of the child's age, education, mental and physical condition, background, and all other relevant factors, and to provide a program of supervision, care, and rehabilitation, including rehabilitative restitution by the child to the victims of the child's delinquent act, to the extent that the child is reasonably able to do so. And so the overarching purpose of the system is to recognize children and youth's diminished culpability and capacity, but also to hold them responsible and then to recognize their greater capacity for rehabilitation and try to ensure that they do not become repeat offenders or end up in contact with the adult criminal justice system. In New Mexico in the early 2000s, we broadly expanded the statutory purpose of the New Mexico Delinquency Act. And we included a number of additional purposes, such as strengthening families, successfully reintegrating children into homes, encouraging collaboration across government agencies and communities, developing juvenile justice policies and procedures that are supported by data, encouraging efficient processing of cases, reducing disparities based on gender and race, improving conditions of confinement for those youth that are committed, and in achieving a reduction in juvenile justice referrals and warrants. So the process kind of generally plays out such that a juvenile is referred to juvenile justice services, either for a delinquent act or a non-delinquent act, and a juvenile probation officer is assigned that referral and reviews the allegations, gathers relevant information in discussion with the individual and family and others involved during a preliminary inquiry, and then the JPO makes the decision about whether or not to refer that case to the system for formal adjudication or refer the youth out for informal services or dismiss entirely. Looking a little bit more closely at the ways that those referrals come into the system, there are both delinquent and non-delinquent referrals. The overwhelming majority of referrals are delinquent referrals, which are acts based on acts committed by a child that would be designated a crime if committed by an adult. There are relatively few non-delinquent referrals or status offenses, which are specific to children and would not be a crime if an adult had the same action, largely truancy or runaways. And then the other large chunk of referrals, or somewhat meaningful chunk of referrals, come through probation violations. So a youth who is on probation violates a term of the conditions of supervised release. After those referrals come in, as I mentioned, there's a preliminary inquiry conducted by the JPO where the youth and the family members discuss the case and the allegations, and the JPO decides whether to refer for formal proceedings or for informal services. Most referrals result in informal services, but if it results in a formal service, the JPO refers the case to a children's court attorney, and that attorney determines whether or not to file a petition in court and proceed with adjudicating the offense. The children's court attorney, there's another kind of diversion point here, has the option to refer the youth for informal services rather than proceeding with adjudication. When a case is, the two ways cases are handled, as I mentioned, informal and formal. In an informal, which is the majority of referrals, in an informal circumstance, the youth is referred to supervision or services, and in the formal proceeding, the youth will proceed in children's court, much like a trial in adult court, though with different kind of rights and responsibilities. The informal processes that are kind of referred out to include diversion programs, counseling, community service, victim restitution, or informal supervision, and that keeps a youth in the community. And in a formal process, the youth appears, enters a plea, a detention decision, or conditions of release are determined. The proceeding is adjudicated in the trial phase, and then the disposition can either be conditions for probation or commitment in a secured facility, and the terms of commitment are 1 year, 2 year, or up until 21. Now, in the 2000s, I mentioned New Mexico had kind of a broader purpose in the statute and was seeing high levels of referrals and youth offenses, and was a national leader in using data beginning in 2008, working with the Annie E. Casey Foundation to kind of reform the justice system, and saw really impactful results. And the big ways in which that reform manifested was, on the one hand, trying to reduce commitment and the use of secured facilities for juveniles, leaning into community services as an alternative. And the other part of that, and they worked with Annie Casey on the juvenile JDAI alternatives, Juvenile Detention Alternatives Initiative. And the second part of that kind of evolution in the beginning in 2008 and in the system was to change the types of conditions of confinement towards a much more rehabilitative model. And that was the COMBIAR model, looking into following the Missouri model and reducing kind of the ways in which juvenile commitment looks much like adult detention, and making it much more facilitative towards rehabilitation. So going to school, having more kind of comfortable spaces. And you can see that in the remaining detention centers in New Mexico. Now, turning to some of the trends that we've been seeing, I will note that in the last year or so, some of CYFD's public-facing reporting has declined. So some of these trends aren't through 2025. As I mentioned, we will have those updated in the evaluation that LFC is conducting at the moment. But looking first to referrals, there's been a marked decrease in the number of referrals since the kind of 2009 period, and there were about 20,000 referrals to the juvenile justice system. That declined and kind of bottomed out around 2021, kind of in the COVID era, and then has slightly upticked since then. When it was at its lowest point, it was kind of in the range of 5,000 referrals. And as of 24, there were about 7,000 referrals. And it would appear that for fiscal year 25, there will be a similar kind of number of referrals. So there's been an uptick, but not nearly to the kind of pre-system reform period. Notably, the delinquent referrals that have declined most dramatically are misdemeanor referrals. The number of felony referrals has been rather consistent over time. You will see that there's been, again, that uptick in felony referrals, but a much larger increase in misdemeanor referrals since 2020. And just as a kind of overview, the top charges for juvenile delinquent referrals for misdemeanors are battery, use or possession of drugs, shoplifting, battery of a household member, and kind of public fighting and creating violence in public. And for the felony charges, the top 5 are aggravated assault with a deadly weapon, unlawful carrying of a deadly weapon, and criminal damage to property, burglary, and battery on a peace officer. So kind of all in all, we are seeing this uptick in referrals, but it's not nearly back to kind of pre-juvenile justice system reform levels. Similarly, since the kind of 2008 reforms, we've seen a significant reduction in the secured youth population at secured facilities in the state. In kind of the 08-09 era, there were greater capacity, but also more juveniles committed in secured facilities. There were kind of 200 plus on average in a given year, leading up to kind of 2016. And then we've seen that number come down. Several of the secured facilities in the state have closed. There are now only 2, one in Doñana and one in Bernalillo. And the capacity of those facilities is about 150 total, and the average population in fiscal year 25 was 114. So there is still capacity in the system, despite the reduction, and that's a success story for the state that we've reduced our reliance on that type of secured facility and kind of shifted towards more community alternatives. Looking at recidivism, we have also seen those numbers kind of stay relatively low and actually decline in recent years. The CYFD reports both recidivism within 2 years after commitment and recidivism within 2 years after field supervision. And between 2023 and 2025, we've seen the number of recidivists, the percent of recidivism decline, in particular for individuals after commitment. One thing I want to point out is that we have been very successfully as a state using risk assessments and making risk-informed decisions, both for detention decisions and for individuals during commitment and after commitment. And those validated risk instruments, there's both a risk assessment instrument and a secured structured decision-making instrument. And both are validated and perform very well. So when a youth is identified as low risk and not detained, they only commit another offense about 8% of the time. And we've very successfully relied on that tool to just decrease disparities in the system and make data-informed decisions about detention. Our understanding at LFC is that CYFD has made some changes to that risk assessment tool, and that may be resulting in more overrides and more detention in a pre-adjudication capacity. That tool was last revalidated in 2022. So we know that the tool was working well, and we don't quite understand why those changes may be have been made. The last kind of trend data that I wanted to mention is pretty dated, but also very important, which is dually involved youth. And from national research, we know that between 7 and 29% of youth with a history in the child welfare system also have contact with the juvenile justice system. And remarkably, nationally, we know that 45 to 83% of youth who are involved in the juvenile justice system also have a history within the child welfare systems. There's a significant crossover between individuals who are touching the protective services side of CYFD and the juvenile justices side of CYFD. In New Mexico specifically, a 2015 study found that 23% of juvenile justice service clients in New Mexico also had involvement with protective services, and 34% had some interaction with protective services. So we know that this population exists, and we would love to know what that type of crossover is currently, an updated number. Our understanding is that CYFD has the ability to track that and to observe that in the data, and we would love to see that type of information updated. Now just to go into some of the previous LFC recommendations and a couple of specific recommendations. The last time that LFC reviewed the juvenile justice system was in 2023, where, but it was a kind of more limited look at juvenile justice facilities. And the recommendations that came out of that were to continue to evaluate the juvenile justice services budget to identify opportunities to achieve staffing efficiencies. And that's largely driven by the decreasing caseloads. Over the period of time where referrals and committed youth have declined, the CYFD, the juvenile justice's budget has continued to grow, and the cost per individual involved has gone up. So identifying efficiencies there. We've also recommended that CYFD update its facilities master plan to account for the reduced juvenile justice population that's committed. And kind of similarly, in line with that, recommended that juvenile justice funding be moved upstream towards services. So whether those are the informal services or other behavioral health services for at-risk youth, kind of shuffling that funding to account for the reduced population. Another recommendation is to continue steps to improve monitoring and service outcomes amongst external providers who receive funding. And one of the things that the evaluation plans to look at is kind of what the array of service providers are around the state that are receiving funding. But we also want to make sure that they're providing high-value services. And then lastly, CYFD itself could provide some direct services, particularly in the behavioral health space, and particularly in geographic areas where those services aren't available. And two of those services that are evidence-based and have strong returns on investment, one is multisystemic therapy, which is an intensive therapy treatment focusing on youth with very serious antisocial behaviors. And it involves stakeholders, family, peers, school. It's been shown, this evidence-based treatment has been shown to reduce youth's criminal behavior, out-of-home placements, and behavioral health issues, and to also improve family functioning. Currently, our understanding is that multisystemic therapy is only available in the Bernalillo area, and increasing provision outside of that area could be something that CYFD does directly through direct service provision. Similarly, functional family therapy is another evidence-based program that's based on the family system as a whole and views youth behavioral issues as and substance use issues within the context of the family unit. And it's particularly effective in treating conduct or behavior problems such as oppositional defiant disorder and substance use disorder. Again, has a strong return on investment, but is also only available currently in kind of the central part of the state. So another opportunity to use an evidence-based alternative to commitment or confinement for youth. So that was just kind of a broad overview. I'm happy to take questions. I am quite new to this position, so anything that I'm not prepared to answer, I'm happy to get back to you all with.
Thank you so much. So we will start with Senator Charlie, go to that end, and then come around, just so you don't get used to any pattern. Full of surprises. Go ahead, Senator Charlie, and let's say 3 minutes this time. Okay. Representative Gonzalez.
Thank you, Madam Chair. Thank you for the presentation. And again, I've been attending a few presentations specifically on, juvenile justice over, and I just maybe have a question. I was trying to find data kind of correlating the two. One of the concerns in some other presentations, workshop I've gone to, is the capacity of the juvenile facilities to be able to hold whether there is somebody that maybe has been charged with a serious crime, waiting, or, the capacity. And particularly the question came up, myself as a rural legislator, is, for those that do not have juvenile facilities, like where would, what's the process, or where would they go? But according to your stats here, we are under capacity, that we are not quite reaching, and making sure I'm reading that chart right. Your trend is showing that you actually have a much higher capacity than where we are at with individuals that are in those facilities. Can you maybe elaborate on that a little bit? Thank you, Madam Chair.
Madam Chair, Representative Gonzalez, I should clarify between two different types of detention. What this chart that you're looking at is showing is secure detention for individuals who are committed after adjudication. And that is run by the state and CYFD. So there are two facilities, YDDC in Albuquerque and J. Paul Taylor in Doñana. And those two facilities have a combined capacity of 156 beds. The pre-adjudication of youth is a separate system of facilities that are actually run by counties. And it sounds like maybe that's what you are referencing capacity concerns about. There are a couple in the state, several have closed because of insufficient not capacity for youth, but there were not very many youth in the pre-adjudication county detention centers. I don't know off the top of my head the total capacity of the existing county detention centers, but I do know that counties have intergovernmental agreements to house youth who need to be detained pre-adjudication with, for example, YSC in Albuquerque. And the capacity of that facility, I believe, is 76, with 12 beds for girls and the remainder for boys. Sometimes you'll see that they're under capacity, but they may be at capacity for a given gender. But that is something that the LFC evaluation is looking into.
Thank you. Thank you for that clarification on some of the data. Thank you, Madam Chair.
And just a reminder to members that you can always reach out to LFC staff if you don't get your question, or if something pops up on your drive home. Oh, I should have asked. Representative Chavez.
Thank you, Madam Chair. Thank you for this presentation. It is very interesting looking at your data and what you're presenting versus what we see in the community. My first is, I know, and we talked about the Missouri model again in CCJ last month, so it's interesting, and we did note that we are using some of those tools that apparently we're looking at to use, but we're already using currently. So my question is, one, I know you stated that we are looking at really some of the juveniles here being reintegrated into the homes. Is that our goal? And if it is our goal, are we looking at maybe the family, and are they learning generational crime in some of those families? Is it still the goal to reintegrate into those homes if that is the case? That's one question. And then my second question is informal services. What is the definition for informal versus formal, other than being facilitated post capacity? And then my last question is regarding recidivism. It shows that you're following them for 2 years, but are you following them through once they're adults? Or are you only following this through, and is the data only showing until they're 18 years old?
Madam Chair, Representative Chavez, I'll take those in order. First, on the question of reintegration, I think that's probably a question better directed towards the agency, but I will note that the statutory purpose emphasizes reintegration. And one of the ways that that could be facilitated is through provision of wraparound services to the family, perhaps. On the second, the distinction between informal services and formal is actually more about the processing of the case. So whether a case is referred to a children's court attorney takes it into kind of the formal process. Some of the services that our youth are referred to, both in the informal process and perhaps because the children's court attorney refers them to them, or because after adjudication the court refers them to the services, would be similar. So community service, counseling, behavioral health. So those types of services have a lot of overlap. And then on the recidivism question, I am not aware of data that's following the youth into adulthood, but I'm happy to look into that further and get back to you.
Thank you so much. And then one last question. I know YDDC is at capacity a majority of the time pre-adjudication, but you're saying that usually we are not at capacity and there is still capacity. So is that post-adjudication is what you're looking at?
Madam Chair, Representative Chavez. So there are 2 facilities in the Albuquerque area. One, at YDDC, as you mentioned, that is for youth after adjudication when they're secured commitment, and then YSC, which is run by the county, which is the pre-adjudication facility. The pre-adjudication facility run by the county, I think, has been the one that has been discussed recently as having a capacity issue. YDDC, I will, one additional note, just finished some renovations to increase capacity as well.
Just a clarification, YSC Youth Services Center?
Yes.
Okay, just making sure.
Yes, Madam Chair, I apologize.
Okay, no, that's okay. We all speak in acronyms, and I'm trying to make sure folks know what we're talking about. Representative Block.
Thank you, Madam Chair. I do not have any questions.
Hey, Representative Jones.
Thank you, Madam Chair. I'm going to pass, but thank you for the presentation.
I could get used to this. Representative Johnson.
Thank you, Madam Chair, and thank you for your presentation. I just have a really quick question on page 5. You have fostering and encouraging collaboration between government agencies and communities regarding juvenile justice policies and procedures. That sounds really beautiful and nice and simple, but what is that? Can you provide an example, and can you define communities for this purpose? And then specifically what government agencies other than public safety and the judicial? Thank you.
Madam Chair, Representative Johnson. So what's on that bullet point there is the statutory language of the purpose. I don't know how community is defined in statute or if it is, but I do think one of the ways in which there is collaboration between the state and local governments is through continuum funding for local governments to provide services for youth that are justice involved.
Okay, thank you. Thank you, Madam Chair. That's all I have.
Senator Pope.
And I'm going to pass, Madam Chair. You don't have to worry. I'm not accumulating all the minutes for later.
Representative Torres Velasquez, and if you could introduce yourself with your district.
Thank you, Madam Chair. I'm Diane Torres Velasquez, representative for House District 30 in Bernalillo County, and that's the area in the Northeast Heights that surrounds the Aurora del Oso Golf Course. My question, and I also am new to this committee, and so I do have lots of questions, but on this particular presentation, and I was listening in on the way, great information this morning, thank you all. On this particular presentation, I'm curious about the connection between the Delinquency Act, which the dates, I think, the dates on the expanded statutory purpose was 2003 and 2007, when we were in a different space data-wise and with the internet. And I'm wondering if that is the reason for the lack or the not yet happening connection between the data for the dually involved youth, or if there are other reasons, and what would it take to make those connections?
Madam Chair, Representative Torres Velasquez. I believe that the existing data systems that CYFD has have the ability to track the dually involved youth currently.
Thank you, Madam Chair. So I'm seeing that it has the ability to track and examine, but it seemed like, as you were presenting, that maybe there was additional information, or maybe I just made that assumption, that there was additional information that you all might think would be helpful. Madam Chair?
Madam Chair, Representative, the last time that we have seen that information studied was 2015, and did see that there was a high percentage of dually involved youth. We at LFC think that that would be an important and informative metric, and would like to see it updated, but CYFD has not, to the best of our knowledge, done that.
Thank you, Madam Chair.
Representative Lundstrom.
Thank you, Madam Chair. I do have a couple of questions. Welcome back. I'm looking on page 14 regarding referrals to the juvenile justice system by referral type. And I see FY 21, 22, and so forth. Have you all done some correlation regarding that low participation level to felony crime stats?
Madam Chair, Representative Lundstrom, I am not aware of that, but that is a very interesting idea.
Yeah, I think we would need to see that, Madam Chair. It doesn't make sense to me that we wouldn't have higher participation in 21 and 22, 23. Also wanted to ask, is there anybody from CYFD here that, are they here? Do you want me to hold off, or?
You're here for a presentation later, correct?
No, ma'am.
No.
I'm the Deputy Director for Juvenile Justice Field Services.
Okay, go ahead.
Go ahead and ask.
Yeah.
Okay, I
Go ahead and
want to
ask
ask you that question.
Okay, well.
I'm sorry, sir, I don't know your name.
My name is Corey Adams. I'm the Deputy Director for Juvenile Justice Field Services for CYFD.
Okay.
So I oversee probation and transition services statewide.
Okay. So, Madam Chair, were you on TV on Sunday?
Madam Chair, Representative, yes, I was.
Okay. I watched that series. I learned a lot in that. But, Madam Chair, I'm looking at this and why we have on that first chart on page 14, why you have such a major drop for FY 21, 22, and 23 when it comes to delinquent referrals and status referrals. Give them a minute to think about that. Excuse me? And
Page 14.
14, the first chart on page 14. The other question that I have is when we're looking at these progress reports, Madam Chair, this is the last year that I was chair of LFC. I would be very disappointed if this hadn't been done, if they hadn't followed up on these things. So I'll give you a chance to look at that also on page 19. You know, I'm just surprised. I mean, the New Mexico legislature has been trying to get their arms around a lot of this stuff for a couple of years now, and we get a LFC presentation that gives us a general overview, Madam Chair and presenters. But at the end of the day, it just seems to me that once this is presented, this young man and his colleague should be responding.
Thank you. Thank you, Madam Chair, Representative Lundstrom. To speak to the decline in the referrals that happened during that time, it's very important that you recognize that during that time, and I know everybody doesn't like to talk about COVID, but that was a tremendous impact on the state. And you have to realize that for JJS, the referrals that we receive, probably anywhere between 60 and 80% of our referrals come from incidents that take place at the schools. So you have a 2-year period where kids were not in school. So you had law enforcement not making contact with, people weren't out. They weren't out and about. So that is why we had such a dramatic dip. There's other factors that went into the trending decline over a period of time that we could get into, but such a drastic drop, you have to factor in what COVID did to everything with that. So, and then speaking to the recommendations, if I can find them here. Again, I'm the deputy director for field, so I can't speak to facilities master plan. I know they have a new deputy director for facilities. They are working on a tremendous amount of stuff. They've just done some remodel there. But when we talk capacity, it's important to understand there's capacity in what you have space available for beds, but there's also capacity that you have availability with staff, because there are very strict federal guidelines in regards to staffing facilities and watching over these youth. And so to meet those staffing standards sometimes is difficult. We struggle with the same issues that the detention centers, adult and juveniles, have statewide in finding staff willing to do this work on a regular basis.
One last question, Madam Chair, and that's on page 6. Where we look at...
Just a reminder, you're over time, so I'm asked for a brief question and a brief answer.
Okay, it's case referral to DAs. We don't have a functional DA office. What's the plan for McKinley County?
Thank you, Madam Chair. Representative Lundstrom, that's a great question for the attorney's office here, the administrative office of the courts, on how they navigate it. Our process does not change. We receive the referrals. If it's inappropriate to send to the district attorney's office, we send it that way. I know there is the district attorney from Farmington that's stepping in and doing some things. We've been in very close contact over referrals coming, and so I'm certain that will resolve itself from our end and making sure that our referrals are processed, but probably need to get more in depth with the courts and DA's office here. Thank you.
Representative Naya.
Pass, Madam Chair.
Representative Chavez.
Thank you, Madam Chair. There's a couple of things that I wanted. Well, let me ask the first question that I have. In terms of the data that we haven't received since 2015, Madam Chair, can you tell me why CYFD hasn't updated that data?
Thank you, Madam Chair. Representative Chavez. And again, when we talk data, I spend a majority of my day mining through data, so I'm not sure what exactly data that we're referring to as far as not receiving. I can tell you, and it was touched on briefly, the computer system that my staff has to operate with on a daily basis is decades old. And so we get data requests at times for information that it's not charted the way that it gets asked. And so to come up with some of that data, I literally have to have staff go through every individual case and read case notes to determine whether that fits into that category or not. And when we start talking numbers in, when you're getting 1,500 active cases, it can be quite a task. Now, I'm very confident. I've seen renderings of our new computer system. We've worked very closely with them on some of the data that's going to be able to be pulled from that. I think this will be a very different experience moving forward once that comes up and running. But right now, it's very difficult to pull data.
So let me it's the data on dually involved youth.
Yes.
That's the data that I'm talking about. Then the other piece is in terms of the risk assessment tool. I'm very interested in that. And basically the presentation, Madam Chair, talked about that it may be resulting in more detentions. So how can I would be very interested in comparing the two, the risk assessment tool that was used before and the one that's currently used, and getting some rationale in terms of why it changed. So, that's probably a question, unless you know the answer now, that's probably a question an answer for later. And I would appreciate having that information. And then, Madam Chair, the other piece is, I think there was a comment, you made a comment during your presentation, Carly, about reducing disparities. Can you talk about that a little bit more?
Sure. Madam Chair, Representative Chavez, one of the big benefits of using data-informed processes and things like validated risk assessment instruments is that they can help reduce any type of biases. And so that's one of the goals of the New Mexico Delinquency Act, is to reduce and eliminate gender and race disparities, and one of the ways to do that successfully is using validated risk assessment tools.
Can I just ask a follow-up question, Madam Chair, please? Is there a way to get the data that you've got that sort of has that information? Maybe you can send it to the committee?
Madam Chair, Representative Chavez, absolutely.
Thank you.
Madam Chair, Representative Chavez, to answer the other two comments that you had, we do track dual involved cases. It's a report that comes through to me on a weekly basis. It's a very huge part of coming out of Kevin S. stuff and everything else with that. The department needed to make some changes to better communicate amongst themselves. And so it's one of the things that my staff does when we receive a referral. The first thing we do is look the case up in protective services. And if there's a protective services involvement, if there's an open case, we reach out to that worker. And so that worker then is a part of our pre-I process. They're a part of our teaming process and triage process. And when we've got a dual involved youth like that, there are weekly meetings that are taking place at the associate deputy level just to ensure that the cases are moving the way that they should be moving. So that is taking place. I'm sorry, the second question you have, I know I could answer it.
It was about disparities.
Thank you, Madam Chair. Representative Chavez. It was in relation to the changes in the RAE. Changes in the RAE prior to the change that we made was to add that any youth in possession of a firearm during the commission of the Delinquent Act would automatically score to detain. That's an automatic 12. The other change that was made was that any battery against a CYFD worker would result in an automatic change. Those changes were made as we were looking at, we had an increase with, as everybody knows, office stay youth and things like that. We had some serious incidents taking place. While an officer responding might only see that as a battery, there's much more involved with that case. And so while a battery might not typically score to detain, given the other circumstances around it, it would be in that youth's best interest to be placed in detention.
Thank you.
So that's why the change was made.
Brief, please. While I have the mic, I am concerned that we moved from a validated version with fidelity to a even if it's a better thing on paper, it looks like we went from something that, that is validated to something that is not, and that's just a red flag as far as I'm concerned. Representative Ferrari.
Thank you, Madam Chair, and thank you, Carly and Corey. We have kind of a subgroup of both Senate and House members who are looking into the Missouri model, and I think that's what was referred to, that we started out in 2007, and we deviated from that as different administrations came on board, and behavioral health became decimated, and other things happened too. But as we look at what's going on in New Mexico and people having to send their kids out of state for treatment, maybe to avoid going into incarceration, but then also what we're doing in New Mexico. I visited our J. Paul Taylor in Doña Ana County, and one of the things that came up was not enough judges know about referring young people for this type of incarceration and treatment where they get education and a home-like situation, like the Missouri model. And coming back from NCSL, I was able to visit one of the Missouri facilities. And it was encouraging to know that their evaluation was done right away, and they also had a very full evaluation that was validated. And I think that's something we need to, and they said they would assist New Mexico like they did back then to follow their model. And I think the staffing is important to keep the groups small, because if you get too many students, then they kind of take over the, essence of the pod or the group. And so there's a lot of things we need to look at, especially our county facilities, so that the counties can work with the more secure facilities where some people might need to go. And another thing that J. Paul Taylor's staff was recommending was that judges to have a better understanding of what's available, so that they don't refer people for just 1 year, and that limits the type of enhancement or continuation that a young person might need. But if they do go directly to the 2-year, then that can be shortened if needed, but they rely on the evaluation and what's happening with that student within that period of time of getting the treatment and being in the facility that's available. But we are seeing an increase in female juvenile needs and their facilities. So I think our state needs to take seriously how many treatment centers, that we are supporting in our counties, so that students can be by their families, and their families can also be within reach of getting the same kinds of services and understanding and changes that are needed for that young person to be reintegrated into the communities. So I look forward to working with you both more if you would be willing to. Thank you, Madam Chair.
Thank you. Vice Chair Lopez.
Thank you, Madam Chair. I appreciate the presentation today. This is just one piece of the puzzle as we talk about what happens with our juveniles, our children. It's a name, but if you're under the age of 18, you're still a child. And Madam Chair, there's a whole bunch of other factors that go into this, and of course it is the family or what other influences they have, brain development and trauma, and all of the other factors also, Madam Chair, and I know this committee knows it very well. I've been around a while, and we did try back in the day under Governor Richardson to do the implementation of a factor of the Missouri model, and I think we dropped the ball as a state. And that was another administration that came in and nixed quite a bit of what we were moving forward with. We did have a lot of detention centers across the state where children were placed, but we closed them. And that was part of the initiative and the drive, was to make sure that we had services for the children and their families, which we don't have much of anymore, Madam Chair. And you cannot try and work with the child, brain development, and any family member or guardian, if it may be, unless we have services to provide. So when a previous administration cut anything, and we had entities around the state, in Albuquerque, it was Hogares, and a few other entities that were actually providing services, it dropped. We dropped the ball as a state. So, Madam Chair, when we talk about, you mentioned, Madam Chair, about fidelity on information, it sounds good because it's an emotional issue, and I understand that. But when we're working with children, I still believe and have hope in our children that we can't give up on them. I was recently gave a statement in court for 2 who shot up my home. And the father, Demetrio Trujillo, is 42. He was, you can subtract the numbers of how old he was, about 13, 14 years old when I first came in office. And the charges, the changes that we were trying to make, well, he was engaged within the system. Well, the ball dropped and look what happened. No services and no background. His son, who was 19 when the shooting happened at my home, again, we still don't have services to offer, right? He has an intellectual disability. I don't see any information in here to talk about anything with regards to learning disabilities on a lot of these young people. And if you go back and talk to the Madam Chair, you'll see the numbers that shows that they have a learning disability. That's another part of the system that ain't working. So, Madam Chair, it's not just about throwing them in jail, in prison. It's about what we do as a commitment, because I still believe that many, maybe not 100%, but many of our children just need support and tools. Because these 2 men, when I sat and listened to their story and their involvement with CYFD back in the day, it's sad. And that's upon me because I've been around so damn long, right? The state didn't do our job, and we're still not doing the job, Madam Chair. Thank you.
Thank you. Senator Charlie.
Thank you, Madam Chair. I feel like I'm going to pick up right where Senator Lopez set that down. I appreciate the report, and thank you for this. I think in New Mexico, our news outlets focus on the most violent cases, and we have to take those seriously. But within this data, what I want to focus in on, and I'm really curious about, are the silent success stories that are in here, right? I believe very strongly in storytelling. I believe in narrative change. I believe that politics is downstream from culture, and we have lost our ability to tell those stories of what's happening and well in our agencies, particularly in CYFD. And if we don't own those stories being told, we are also complicit in the perception of CYFD and its failures, especially in the news, and those of about juvenile crime. So anyhow, I am curious how we're socializing the success stories, Madam Chair, of what's working.
Thank you, Madam Chair. Senator Charlie, I can't tell you how much I appreciate you making that comment. And it's something that is incredibly difficult to work with these youth every day. And again, it's not always going to turn out the way that we want it to. But there are tremendous success stories. I told one at the last committee meeting of staff that I had that drove from Las Cruces to Farmington to be with the kid who was graduating from a program up there. And the tears in that young man's eyes, just that we were there to support him, it means everything. We are doing our best to publicize it. We've got a new communications department trying to do things to publicize some of the good stories and the good work that's being done. But as you stated, that doesn't always make the front page. And so we just continue. I know myself as a leader within the department, I just continue to keep pushing my staff. Hey, do what's in the best interest of that youth and family sitting in front of you. And then, tell me about it when we've got the successes so that we can figure out what worked so that we can repeat it. And those that don't work, I need to know those too so that we don't repeat that. I mean, that's what we're doing on a daily basis. So I appreciate you making those comments, and we're making attempts to publicize the positives.
Senator Lopez.
And Madam Chair, I apologize. On my list, I should write these things down. My brain doesn't remember, on a linear way. The county detention centers for youth, I know there's not every county has one, but CYFD still has oversight of approval of what I believe they're supposed to be following. Is that correct?
Thank you, Chair. Senator Lopez, we have oversight of federal guidelines in regards to juvenile detention facilities. So we oversee making sure that the federal guidelines are met within those facilities. Those examples, those guidelines would be like Prison Rape Elimination Act, things that go along with that, and we're making sure that those are met. Staffing numbers, the training amongst the staff, and that those things that they're doing those logs, that they're documenting the cases appropriately. As far as the day-to-day interactions and the stuff that goes on there, that's primarily up to the county as far as how they run it.
And Madam Chair, I ask this question because I think what is being done, what interventions are being provided at the county level, namely Bernalillo is one of them, J. Paul Taylor, and I do believe Farmington has a facility also, because I think that's another area that we need to look at. It's not just CYFD, it's also the counties and the oversight and who they hire. Because in Bernalillo County, they used to have cameras in the showers, right? And who would watch those movies, right? Males. Excuse me, there are girls who are in those facilities also. So I think there's some things that we really need to figure out, Madam Chair, what we do, because that, and when you talk about really doing a strip search on the children, we're adding more trauma to these children. I mean, for me to be strip searched, oh my God, right? And you ask these children to be strip searched, and when you go back and look at the data, there hasn't been anything that's been found that would cause, a stabbing or something. Let's put it, speaking very plainly. So I think that's another area, Madam Chair, that we also have to look at, because that was happening. They say it has stopped, but when you have that until my eyes saw what was happening, talk about our children being subjugated to more trauma. Thank you.
And I have a few questions. So on page 14, it would be great if repeat individuals could somehow be expressed in that. I mean, particularly the one on the far left, the referrals, if we could have the numbers of how many of those are repeat involvement. And then on page 19, talking about the federal program on that sidebar, what is happening federally? Do we have a sense if it's going to affect this?
Madam Chair, I do not know that off the top of my head, but I'm happy to do
that'd be great.
some research into
and then as Representative Ferrari said, this committee met at YDDC 3 years ago, maybe sometime, and we got a tour, and I asked how many of the juveniles who were there had IEPs, and it was upwards of 60%. I believe it was around 80, but I'm not 100%. So I think that's really important as a piece of data, that we need to see how many of these kids have IEPs, and just more proof that we're dropping the ball on our kids with disabilities. They're vulnerable. They may not have the best judgment. Social pressures, all those kind of things. So I would really request that IEP be part of the data that we get. And with that, thank you so much for your presentations, and we will take a lunch break until 1:15, and we will start at 1:15. And I want to thank UNM and our own former Linnea Montoya, who's done a lot of good work getting things arranged there. They provided our breakfast. They will provide our lunch. So thank you, Linnea. Thank you, UNM. Okay, we will be on break. Okay, welcome, Secretaries 3, whenever you're ready.
Thank you, Madam Chair, members of the committee. It's really great to be here, so thank you for the invitation to come talk today. I'm Carrie Armijo. I'm the Cabinet Secretary of the Healthcare Authority, joined by Teresa Casados, the Secretary of the Children, Youth, and Families Department, and Gina de Blasi, the Secretary of the Department of Health. And together, we've been working really hard across agencies to reform, to make some early reforms to the CARA program, which is the Comprehensive Addiction and Recovery Act. We refer to it as CARA. Some changes that, there's been longstanding bill at the federal level for CARA, but also some changes that happened at the state level last legislative session. So we're going to talk a little bit about progress, where we are with that, as well as some intermediate changes that have been made to address some
Madam
concerns.
Secretary, I hate to interrupt you. Sure. These two handouts are from what was presented to us by Legislative Finance Committee in June. So these are not specifically for this presentation, but it's supporting data, because we couldn't get the three secretaries to come. They weren't available in June.
Thank you, Madam
Sorry
Chair.
to interrupt.
No problem. So on slide 2, and you do have a presentation from us, slide 2, we're going to talk a little bit about both the current and future state of both the federal CARA program as well as 2025 Senate Bill 42. The unified strategy that we're really deploying across the different agencies, including the Healthcare Authority, the Department of Health, CYFD, and the Early Childhood Education and Care Department. We're going to discuss the enhanced system of support and safety that we've implemented for substance-exposed newborns. We'll clarify for everyone who might be confused about the agency roles and responsibilities, who's doing what is in each person's lane, and then we'll talk about future milestones and deliverables. So on slide 3, just a bit of an overview in terms of the CARA program. Right now on the Medicaid program, we have 454 Medicaid members. That's as of July. 297,329 children. Medicaid pays for 55% of all births in New Mexico and covers 72% of all infants under age 1. So Medicaid is the primary payer for most babies and children here in New Mexico. And we have about a little bit more than 1,000 infants currently enrolled in the CARA program. Almost 98% of those infants are covered by the Medicaid program. Again, just some context. We want to recognize that nationally, 19 million children in the United States, that's 1 in 4 children in the U.S., live with at least one parent or a primary caregiver who has a substance use disorder. And that is pretty staggering data. So alcohol use disorder is the most prevalent, but we know parents are struggling and we know kids are struggling. And so nationally, this is a big problem. In New Mexico, we rank 42nd out of states in terms of the rate of neonatal abstinence syndrome per 1,000 hospitalizations at birth. On slide 4, I'm going to talk a little bit about the current state of the New Mexico CARA program and where we are headed in the future as we implement Senate Bill 42. Today, the regulatory oversight of the CARA program is with the CYFD. So that is the sort of regulatory entity. In the future, the Healthcare Authority will be the regulator. And per the statute that was passed during the last session, the regulations have to be promulgated fully by July 1st of 2026. So there was about a year and a half between the time that the bill was passed and the time that the regulations are due. Currently, there is no screening for prenatal substance abuse required. It is voluntary. Substance exposure can be identified through toxicology or voluntary disclosure, but not required. In the future, we are headed toward universal screening program. We will be providing what we call SBIRT, that's screening, brief intervention, and referral to treatment, not only at hospitals, but at every prenatal visit. It's required under the statute. And there will be an evidence-based evaluation tool for newborns to make sure that we are sort of adequately checking for withdrawal symptoms. Today, the plan of safe care is voluntary. Participation in the plan of safe care is not required by families, and families are allowed to refuse referrals, care coordination, navigation, and treatment. So a fully voluntary program today. We are moving toward a mandatory approach. Participation in the plan of safe care will be required as of next July. And there are mandatory elements that will be required in the plan of safe care that will include home visiting and substance use disorder treatment. Today, the plan of safe care starts at birth. In the future, that plan of safe care can be set up during the prenatal visits. So that's really exciting. It's better to intervene earlier. I think we all know that. Today, notification to CYFD is not required for non-compliance with the plan of safe care. It is voluntary, and a family assessment may be completed. However, in the future, the plan of safe care non-compliance will be reported. It is a mandatory reporting requirement to CYFD. Today, we have minimal training requirements for our providers, our hospitals, not much out there, not a lot of curricula. So we are hearing about this now from hospitals. They really want more training. It is also unclear under today's structure which agency is responsible for training providers. So in the future, what we are headed toward is more rigorous training for our hospitals and our providers. That will include the SBIRT piece, the plan of safe care requirements, and other needs in terms of those evidence-based screening requirements. And it's very clear that the healthcare authority will be responsible for those requirements. And then lastly, in terms of care coordination and care navigation, today we have our MCOs, our Medicaid Managed Care Organizations, that are providing in-person care coordination at the hospital. They're at the 5 highest birth hospitals. Today, that is happening. And then we have DOH care navigators and MCO care coordinators trying to interact with families and do home visits. In the future, our vision is to really build and leverage the care navigator program at the Department of Health. And with that, I'll hand it over to Secretary de Blasi.
Thank you. So as Secretary Armijo mentioned earlier, this is really a unified cross-agency strategy with the goal of really assessing risk and keeping newborns safe. And we're going to do that through enhancing our interventions prior to discharge. We are performing more frequent in-person visits of high-priority cases that have been identified, and at the same time connecting families with treatment and resources. On page 6, this gives you a graphic of our enhanced system of support for what we're calling Priority 1 babies. Those Priority 1 babies are those that have a substance exposure to fentanyl, meth, other polysubstance, or have a fetal alcohol spectrum disorder. We are working with the hospitals and for the Priority 1 substance exposed inverts until the baby is in safe custody. And what does that mean? What that means is that we are assessing the risk of the baby, whether or not the home environment is appropriate, whether or not the supports that are in the home and with the parents, the birth parents, are in place. And we're doing that in coordination with CYFD. Department of Health and CYFD are doing that prior to discharge. If we find that there is a concern, CYFD is taking the 72-hour hold and then is petitioning family court. The hospitals, this still remains in place. Nothing has changed for the hospitals. The hospitals are currently required to submit a plan of safe care, and that has always been the place, and that requirement still stands. We're working with the healthcare authority, MCO care coordinators on connecting the family to treatment. We are completing safety monitoring within 24 to 48 hours of the infant's return to the home environment, and at least twice a month thereafter. And then we're also working on a post-CARA for Priority 1 cases. Currently, right now, CARA is for 1 year, and we know that things don't change after just you turn 1 year old and everything's great. So we want to make sure that we have that continuum, and we're working with ECECD to do that through home visiting programs. On page 7, this gives the CARA substance categories and response levels that we've developed. As I discussed earlier, Priority 1 cases, those are the highest priority. Priority 2 are those that have substance exposure to cocaine, ketamine, benzodiazepines. Those would require an immediate visit in the home and then at least monthly. These, again, are minimal. So depending on an assessment and the need, we might have more frequent visits in the home. And then Priority 3 are those newborns that have been exposed to alcohol, nicotine, and cannabis. Again, depending on the assessed need, minimally they would have quarterly in-person visits. And then down below on this graphic, it speaks to the support for ages 1 to 3. As I stated earlier, not everything just gets better after you turn 1 year old. There might need some additional monitoring and support services.
So on slide 8, we really have tried to break down for you and clarify which agency is responsible for which function here, because this is a cross-agency effort. So I'll start with the Healthcare Authority. Really, the Healthcare Authority is the rule regulatory entity. We are charged with the rule promulgation and the regulatory oversight of CARA. We are responsible for the training, the SBIRT, the screening tools, the plan of safe care development, and the criteria and the reporting requirements, what we expect from our providers. We are also responsible for the collecting and reporting of data. So if you, in the future, kind of are looking for data on CARA, we will be that entity that's taking responsibility for that. We'll be overseeing the hospitals. We are the licensing entity for hospitals. Sometimes folks forget that. In addition to being the payer, we're also the oversight entity. So we'll be making sure that they fulfill their responsibilities. The Healthcare Authority is also taking the lead on building and maintaining a portal for reporting and cross-agency provider notification. So that is also a piece of Senate Bill 42, making sure that there is a way for all of these entities who are involved to communicate with each other. So we will be charged with making sure that that happens. It's also our responsibility to ensure and facilitate access to behavioral health and substance use disorder treatment and other services for families. So we are the entity that will really be connecting folks with the services they need. Currently, we are that in-hospital presence, although we are looking to shift that. And then our agency is also responsible for making sure our MCOs perform health risk assessments and comprehensive need assessments for families.
As of February 1st of this year, CARA is at the Department of Health. The Department of Health has the CARA navigators and the case managers for all of the CARA families. The CARA navigators are required to check the portal daily for the plan of safe care. That gives us notification of which newborns come onto the caseload. We are required to notify CYFD for noncompliance or suspected abuse and neglect of the plan of safe care. In the future, we're talking with the Healthcare Authority about having in-person hospital presence. What we find is that there are a lot of players in the mix, whether it's the MCO coordinator, or it's the CARA navigator, if there's a CYFD investigator or family services, we've got home visiting with ECCD. So it seems like, having the CARA navigator in the hospital, having that presence with the warm handoffs, and that case immediately comes onto the CARA caseload seems to make a lot of sense and seems to streamline that process. We are responsible for safety assessment of caregivers in the home prior to discharge, and we do this in coordination, in collaboration with CYFD. And also we connect families with resources and supports.
So CYFD's role in this, in taking it from a different public health perspective and having DOH involved remains similar to what we've currently done. The role for hospitals with reporting to CYFD remains the same. So in looking at priority 1 cases that they identified earlier, CYFD will go in and investigate those hospital referrals of reported substance exposure. We'll then do an immediate safety assessment if in fact they're a priority 1 case of the home in collaboration with DOH. And we want to ensure that DOH is doing that home visit with us because of 2 reasons. The care navigator will be involved with that child and that family upon discharge. And if that child does end up going home, we want to ensure that the environment that it's going home to is appropriate for them, that we've looked at risk assessment, that we've determined if they need cribettes or anything that DOH would be supplying to them. And so they are part of that first initial investigation that we do in that home and working closely with us. We would initiate that 72-hour hold prior to discharge. So that gives us an opportunity to go and look at those before the baby is released to a home environment, so that we can really do that assessment prior to them going home. We'll conduct the investigation, and if necessary, we'll petition for custody if the homes or the environment is determined to be unsafe. We'll receive notifications for non-compliance, referrals for investigations if that child does go home and they're involved with the care navigation program at DOH, and they determine that there's non-compliance, or if at some other reason they determine that there's other concerns, then they'll be making those referrals back to CYFD, and we will go back out and do another investigation. And if necessary, have our Family Services Bureau get involved with that family to ensure that we can provide services needed for that family.
And as stated previously, ECECD also has a very important role here, and that's with the maternal home visiting program, the Family Infant and Toddler program, otherwise known as FIT, and early intervention services, and also the connection of these newborns to child care services as well. On slide 9, we looked at 149 priority cases and how they became priority, or these were substance-exposed newborns after January 1st, 2025, that had an exposure to the illicit drugs that we had discussed earlier. And through that, we had a cross-agency approach of making some home visits, because these were cases where there was no engagement, unable to connect, really haven't been able to coordinate with families, ensure that the newborn is in a safe environment. So roughly over about a 2.5-week period, we did a cross-agency visits in the home, and it was a DOH care navigators, some individuals from the Healthcare Authority, through the Division of Health Improvement, help provide support for that. We had CYFD investigators, and we also had New Mexico State Police, because some of these were some challenging situations. So we just wanted to make sure that everybody remained safe, not only the team that was making the visit, but also the families as well. Of those, we had 148 successful visits. From those visits, 7 children were removed. It was 3 newborns that were on the CARA program, plus an additional 4 children that were in the home. All families were provided with safe sleep education. We were providing other services like cribettes when we determined that there wasn't a safe sleep environment, and other resources that were needed or identified, whether it was diapers or formula. We would find homes that might have some unsecured guns. We provided gun locks because there were other older children in the home as well. And then we also did connections to early intervention and home visiting programs through ECECD. In addition to those 149 visits, following those infants being identified, we looked at any born after the date of the directive that was issued, and that was thus far an additional 57 individuals that meet that priority 1 criteria. So we have filed petitions on 29 of those infants. We've had success in court on 15 of those, meaning that we determined that the environment was unsafe for that individual child, and we petitioned the court for custody. We have had 3 unsuccessful on those court petitions, which did rule that the babies could be returned to home, which is really why it's important for us to have DOH involved with us from the onset, so they can pick up and ensure that those infants are supported once they do return home. We have 11 still pending with the court. 6 of those we've established guardianship with other relatives. And we've had other interventions in 17. So some of those are in process of guardianship. Some we have a parent in treatment with the child. Some we've had tribal interventions.
And right now, we still have 5 of those infants remaining in the hospital, which, as long as they're safe in the hospital, we're monitoring those situations and not filing a petition until we can determine, next steps and what needs to be done.
So on slide 10, just a couple of highlights here around hospital and health system engagement in the CARA program. And a reminder that in fiscal year 25, the Healthcare Authority began requiring our managed care organizations to have that in-person hospital presence. So that began just last year. That's been an interesting process. They're trying to really build relationships with women right after they've given birth. We've worked it out with the hospitals. It was hard to set this up, hard to let them in at the beginning, but that's working pretty well now. The Healthcare Authority also issued a hospital and birth center directive on June 27th, and that requires basically that the hospital must report to CYFD's statewide central intake any newborn that's exposed to fentanyl, meth, or born with fetal alcohol spectrum disorder, or exposed to multiple substances, really one of which would be an illicit substance. So we want to make sure that we are tracking all of these babies born with those exposures and that we're intervening. All patients in New Mexico hospitals are assured a safe discharge plan. That includes every newborn, and we want to make sure that newborns are going home to safe households. And so that really enables that to happen before that discharge occurs. We did hold a cross-agency hospital Q&A meeting in July also, and we've answered 41 hospital questions in writing. So we're working really closely with hospitals, and we have also been working on setting up biweekly meetings with our hospitals to make sure that we are in a constant dialogue about how this is working. On the right, you have a table that just kind of really shows how we're tracking some of this data. MOB means mothers of babies. So you can kind of see we've got different cohorts identified of moms of babies who were born under the CARA program, and we're really tracking their behavioral health claims, their substance use claims, even any physical health intervention, any follow-up care at all. One of the takeaways from here, and you can spend time with it later, but one of the takeaways is that there's very low engagement. This is something that we've seen nationally. The CARA program nationally has resulted in low engagement after women go home from the hospital with their infants. It's a voluntary program. By virtue of that, most of the people enrolled in CARA are not seeking follow-up care.
Thanks. I also just wanted to add that in addition to the biweekly meetings with the Hospital Association that we're doing, we are also, as Secretary, scheduled this Thursday to go and present at the APCG meeting so that we can ensure that we're addressing any concerns or questions that the tribes and nations may have as well.
Thank you. Okay, on slide 11, just wanted to kind of give you highlights around where we are headed in the future, what our deliverables are, because a lot of folks are wondering, where are we with this CARA rollout, because the deadlines are next July. And so as we kind of talked about, we're going to keep doing these priority 1 visits and this enhanced engagement prior to discharge, and we're going to continue doing that communication with our provider network, especially our hospitals, and providing technical assistance. We are also in the process of convening a robust stakeholder process regarding the rule promulgation, so you'll expect to hear more about that. That's happening now. Senate Bill 42 will be reflected in the Healthcare Authority's executive FY27 budget request. There are some needs that the agency has in terms of staffing and a more robust navigation. So that will also be reflected in our budget submission. We are in the process of working on that RFP for that CARA portal. We expect to begin our rule promulgation between October and December, making sure that we've got that, so that's a fully public process and very transparent. We are also in the process of selecting our evidence-based universal screening tool and our expert strategy. So all of that work is happening now. And then as we move into 2026, we are going to be focused on our training program for our hospitals on the new requirements, finalizing all of our data sharing and reporting requirements, and finalizing our new regulations by July, so that will be fully complete. And we'll have a new checklist for our hospitals and making sure that our hospitals are trained. So we do anticipate full implementation in accordance with Senate Bill 42 by July of 2026. And with that, I think, Madam Chair, we're prepared to stand for your questions. Thank you.
Okay, thank you. Is there anyone who doesn't have questions? Okay, that's what I figured. So we will start with Representative Ferrari and go around this way. And let's see, 3 minutes.
Thank you, Madam Chair, and thank you, esteemed secretaries. One of my questions is on the in-person visits that are, I forget which slide it was, for those who are at risk, the priority cases in many levels. Who is in charge, well, who are doing these kinds of visits? And what kind of background do they have?
Madam Chair, Representative Ferrari, that's a Department of Health Care and Navigation team. They're doing that. When we started the program at Department of Health in February, we moved some of the CYFD team over to Department of Health. We're currently in the process of relooking at the requirements, and we're putting in a preferred requirement for master's prepared social work. I know that there is a shortage of those, but we've also pulled down the number of MSWs that have left state government. We've got a list of that, so we're going to have some targeted outreach. So we'd like to build that program to roughly 25 to 30 navigators.
Okay, thank you. And also, I guess there was one situation that we heard about, a tragedy of a baby that the grandmother was assigned to go and check. Is that not true?
Madam Chair, Representative Ferrari, yes, that was a situation that CYFD dealt with earlier this year.
And that's been changed, Madam Chair, Secretary.
Madam Chair, Representative Ferrari, that is part of the change in what we're doing in ensuring that there is more follow-up, engaging DOH earlier and making sure that DOH and CYFD are communicating often. So in addition to this, we're doing weekly meetings with the staff that we still have in family services and their navigators to ensure that there's engagement with families and follow-through.
Okay, thank you. And when you have the 72-hour assessment period where you can hold the baby in the hospital, how does that, well, to me, that sounds like it would interfere. Does the mother get to stay there with the baby so that there's still that bonding, or if she's nursing, how is that situation?
Madam Chair, Representative Ferrari, there is no limitation of the mother's visitation in that hospital. So bonding with that child is still encouraged. They're allowed in the hospital. Oftentimes what we find is that the mother is not engaged in the hospital. If that's the case, we have a worker that's there, or if we've identified a foster home that they're going, the foster parent is doing those visits, especially for some of those that have longer time frames than just that 72 hours. But we don't prohibit the mother from visiting the infant in the hospital.
Okay, but she doesn't get to stay with the baby, or they probably wouldn't be in that situation if she was engaged. Is that?
Madam Chair, Representative, oftentimes many of those infants are in the NICU and it's restricted, and so no, they just are there for visitations.
Okay, thank you, Madam Chair. Thank you, Madam Secretary.
Representative Chavez.
Thank you, Madam Chair. I have a lot of questions, and I'm probably not going to have time to go through them all. But I want to follow up on one of the things that Representative Ferrari asked about, and that's bonding, parent-child bonding. And I think I asked the question last time when you all presented. I don't remember. Maybe it was at LFC where you made the presentation. And my question was about how do you ensure that bonding takes place and continues once a care baby is identified. The baby may be still in the hospital, the baby may be in custody already. And your response was, we'll make sure that the baby bonds with the foster parent, which I didn't find a very good response. And so to follow up on Representative Ferrari's question, how, Madam Chair, how is CYFD, because at this point in time, I'm assuming that CYFD has filed for custody. What are you doing basically to ensure that mom gets to the hospital, because we're assuming that it's easy for her to get there, that the bonding continues, and after the child, if the child is placed in custody, what are you doing to make sure that that child returns home and doesn't remain in foster care? For example, what kinds of parent-child therapies are you doing? Just sort of walk me through that.
Madam Chair, Representative Chavez. So CYFD does not prohibit, we do bonding even when kids are in custody with CYFD. We do parental visits, we continue, and that will continue. We want to make sure that the mother is getting the services that she needs. In many of these cases, we anticipate that taking that child into custody will allow for her to go to treatment or get that treatment or, work closely with the navigators and care coordinators who are setting that treatment up. Unfortunately, we don't have many treatment facilities in the state of New Mexico that will allow the mother and the child to go together. We do have one, and we're going to work everything we can to ensure that if that's the route that they want to take, that we will try to get them into a facility where the baby can remain with them through treatment. But we also want to ensure that that baby can be in a safe environment. So if the parent chooses that, and it's not available to take the child, that we have somebody who can step in and take care of that child while the mother is in treatment, conducting whatever visitation would then be allowed through the treatment facility to ensure that that bonding could continue. I think what I said is that we also want to make sure that if that child is removed from the mother and is placed in a foster home, that that bonding continues with that foster parent, because the bonding for an infant at that age is so critically important.
3 minutes goes fast, and I'm sorry. Representative Anaya.
Thank you, Madam Chair. I think I'm going to take the Angel Charlie approach here. Thank you, Senator Charlie. Thank you, Secretary de Blasio, for answering some of my questions earlier. I appreciate that. First question is, how do you handle parents who are in MAT? Are they also subject to the 72-hour hold? Second is, if a child is subject to a 72-hour hold, how is it that you are going to navigate IFPA if they're an Indigenous child? And then third, there is a lot of fear. I've had a lot of healthcare providers in my district reach out to me. One, folks are very confused about the new directive. They are very much so requesting more specific guidance. I'm sure you've heard that before. But they also have a lot of fear that this new directive may actually steer families away from getting treatment. And so I'm wondering if you all have any sort of public education built into your plan.
Madam Chair, I'll take the first question, and then I'll hand it over, and then we can kind of try to do the third question. So the first question is around parents in MAT. So folks who are in recovery, who are really working hard, and their doctors would have advised them to stay on those MAT services. They are not included in this directive. So unless there was a combination of, for example, methadone plus fentanyl or methadone plus methamphetamine, that would be the only time that it would be triggered, which would be an indication that potentially there's a relapse going on. So women who are in recovery, we really want to support their recovery. That is the clinically best thing to do for that family. And so they are definitely not under this directive. And I don't know if Secretary wants to address IFPA.
Yes, so on that 72-hour hold, one of the questions asked when they do the plan of care in the hospital is if there's reason to believe that that child may be of Native American heritage. And so that question is asked up front there, or if a report is called into SCI at a later date, or there's reason to believe. That is also asked in the SCI intake, and that triggers us then to make sure that we're following IFPA and ICWA that we're working with the tribes and pueblos. I think when we went out and did the 149 visits and that was done, differently, it wasn't called into Sky, we just looked at those cases. I think in some of those areas we may not have been paying as close attention to whether or not that applied. It's one of the things that we're looking at now and ensuring that we're working that into the response and how we handle those specific cases.
Madam Chair, Representative Anaya, yes, more education is needed. I've specifically met with Focus Clinic, Milagro program, the Adobe program, who also works with teens and pregnancy who have some challenges with substance use. And I heard the same thing from them. We've been hearing that there's concern within the provider community about fear of individuals wanting to seek care and prenatal care because they're worried that we're going to step in and remove children. I think I was able to reassure the clinics that that's not the case, but I do think that more robust training, more communication, and getting the word out about really what this directive means is the priority on trying to keep newborns safe. We want to work with the families. We want to give the families the supports and services that they need so that they can maintain the child in their home. But, it's going to take us some time over the course of standing up Senate Bill 42 and with the training that's happening at the Healthcare Authority through with all the providers in the community to make sure that we get that message out. At the same time, it's really to establish the trust with those community providers and with the mothers as well.
Thank you.
Thank you, Madam Chair.
Representative Torres Velasquez.
Thank you, Madam Chair. I kind of want to build on those same questions. I believe I've got two questions. They may be related. They may be a little different. I'm not sure. Looking at page 8 and looking at the agency roles and responsibilities, my question, the first thing that hit me is why are we not being proactive and culturally and linguistically sustaining with all our families? And I'm not sure why that was the question that came to me. I don't see punitive language here, but it feels very punitive as we go along and look at the slides. And of course, we're dealing with serious subject matter here in terms of criminalization, in terms of mental health. And so I just was wondering why we are not being proactive. That's question one. And then the other was where do we provide treatment for the parents? Comprehensive Addiction and Recovery Act, it would seem to me, and maybe I just don't know enough about Senate Bill 42, but it would seem to me that if you've got a child in this situation, then the parents obviously need some help as well. So where do we provide that treatment? And so again, those issues of mental health and disability sometimes come into this. And also coming into play in my mind is, what if the parents we're dealing with are part of that population we just looked at in the last presentation that was dually involved? Thank you, Madam Chair.
Madam Chair, Representative Torres Velasquez, well, thank you for the question. I think I run the state's mental health agency, and we definitely don't want to be punitive at all. We want to encourage everyone to get treatment who needs it. And that's absolutely our goal, is to make sure that we connect families with the treatment they need. There is capacity. We can serve a lot more people. Most people who are interacting with the healthcare, the behavioral health system, really think they don't need help or that they can solve their problems on their own. Unfortunately, that's really not the case sometimes with these really, really serious substance use issues. And so really part of that goal is to really intervene at the hospital. But Senate Bill 42 also takes that into the prenatal environment. So really trying to do that intervention at those prenatal visits. And that's a really proactive approach that hasn't existed under the CARA program or the framework at all, or in New Mexico. And so I'm really excited to be able to roll that out because I think the prenatal intervention is the most important point of intervention, really before things kind of become really serious health problems for the baby, for the mom. So that's really the goal here. I do think it's a proactive approach in terms of the safety of the families and really making sure. I think we've all seen these articles in which babies have been discharged to unsafe environments. And there are 15 babies who have now been sort of placed in an alternative setting with the entire goal of getting families the treatment they need so they can get those kiddos back. And we want to support everything about that. But I think this is a little bit of a switch in terms of the proactive approach around the safety of families while we connect them to treatment. And I don't know if anyone wants to add anything.
Thank you. That's time. Representative Johnson.
Madam Chair, I reserve my time.
You're trying to throw in things here that don't go. Representative Jones.
Thank you, Madam Chair. You've done a lot. I think we need a whole day to talk about this at the very least, because I have a million questions, and I won't even go into them because I'll just give you an example of why, Madam Chair. I think it's been 2 years ago when I asked about navigators, because navigators are part of the CARA plan prior to what we did this last session at SB 42. And we were in the process of hiring navigators, and it was promised to me that we were going to have that number completed by December, which is going on I think this December, by January 1st, we were going to have 40 navigators or whatever the number was. I don't remember, but it was, it was something that gave me a great relief to know, because we need navigators in the hospital, just like you said, as part of the plan. We need navigators in the home, just like you said. But to get back to the bottom line, right now, we're having this meeting, there are babies dying. And I want to know how many babies have died since the session ended, or actually this year. How many babies have died who should have been in custody rather than at home with a mom who exposed them to drugs or alcohol when she was pregnant? I need a number.
Madam Chair, Representative Jones, I believe that of infants that were in an environment where there was substance exposure at birth with CARA, with fatalities in the year, I believe that number is 3, but I just want to get confirmation and get back to you with that information.
Thank you. Thank you, Madam Chair.
Representative Block.
Thank you, Madam Chair. Thank you all for being here. I have 3 minutes. There are 3 secretaries, so I don't know how quickly I can get through this. But first of all, I just want to address some kind of narrative that's being pushed out there that we're trying to be punitive with these women, because I believe as a state, we're trying to be as careful as we can be to protect the safety of that baby, which I believe is the priority. So my question then would be, when it comes to this rollout, we keep on using the word mandatory, and so I'm just trying to figure out which portions of this CARA platform that we've created are mandatory and which are not. And I'm wondering if you could just go into that a little bit for me, Madam Chair.
Madam Chair, Representative Block, so we're moving, I sort of described where we are on this sort of spectrum of getting from when the bill passed to next July, when things really, the mandatory plan of care, compliance, all of those things. Today, what is mandatory, or what really changed with this directive, was the visits. We wanted to check on every household. And then the second part is the mandatory reporting by the hospitals. We want to know about those substance exposures. And so we have made that mandatory, where before it was really more at the hospital's discretion. They could report it, maybe, maybe not. We weren't seeing a lot of consistency. So that's really what's changed in the interim, is we've really required the hospitals to report those substance exposures, those 4 conditions, to CYFD. CYFD is doing the investigation with the Department of Health, making sure that that household is safe for discharge. If this household is safe for discharge, nothing is impeded. But that's really what's mandatory now.
Okay, thank you, Madam Chair, and thank you for that, Secretary Armijo. So I'm just wondering, when it comes to I know we're with the new changes, what if the state does not do the proper protocols to petition by 72 hours, would that mandate that the child would be released to that mother who may be addicted to who is addicted to fentanyl or something else, and that would directly impact whatever we do as a state? Is that correct? If the state does not petition in time?
So, Madam Chair, Representative Block, this is a good question. In theory, the way it should work is that once that's reported, there has to be an investigation. Actually, the hospital cannot discharge to anyone who's not a legal guardian, and at that point, the state will be sort of absorbing the custody agreement. So I think that the hospital cannot actually discharge once it's been determined unsafe. They've actually taken an action to report it to CYFD, but I would defer to the secretary here if I'm missing something.
Sure.
Madam Chair, Representative Block, so the 72 hours is not a time limit for CYFD to file. It is once we do file, we get 72 hours to go out and then look at the home environment to determine whether or not it's unsafe. And then at that point, at the end of the 72 hours is when we need to then petition the court for custody if we determine it to be unsafe.
Okay, thank you, Madam Chair. And just to piggyback on that, I just want to make very clear that a mom who is addicted to fentanyl in that first 72 hours, in my opinion, I do not believe it is safe to put that child back into custody of that mother to be nursing and continuing to enter poison into that child's body. So I heard a comment before about that, and that really triggered me, so to speak. So I just want to make sure that that's super clear that we're protecting those kids. And that's all I had, Madam Chair. So if you want to add something.
Well, just really quickly, Madam Chair, Representative, that is very true. The hospital will not let the baby nurse because babies can die of overdose. And so they would really kind of monitor that situation. It's really at the hospital's discretion, but that you are absolutely correct.
Representative Chavez.
Thank you, Madam Chair. Thank you for the presentation. I do have a question regarding this new mandate that was recently changed. My question is, do you have plans to go back to every substance-exposed infant since 2019 to evaluate, make welfare checks, check on that child, or drug checks? I think that the 15-month-old twins who almost died last week, we might have missed the date if we weren't going all the way back. So what is our dateline for that?
Madam Chair and Representative Chavez, so that is why we put in place here, after you turn just 1 year old, you graduate out of CARA. We're trying to provide that level of support from 1 to 3 years old through ECCD, through home visiting and in the FIT program. So we will continue to have those checks. And the priority one cases are those newborns that were substance exposed to those illicit drugs, but all substance exposed newborns are, the hospitals are required to submit a plan of safe care. And the care and navigation team follows all of those substance exposed newborns via the protocol that was on the graphic.
Okay, thank you. That makes me a little nervous, so I hope we get that straightened out pretty soon. My second question is just regarding healthcare and access issues. I know that the NICU and PICU units have been on divert status for quite a while. So have we talked to hospitals, and how are we going to work around that issue?
Madam Chair, Representative Chavez, right now, so you are absolutely right. We do have healthcare access issues. Right now, the average length of a stay for an infant in this situation is about 17 to 25 days. So it really kind of depends on what symptoms they're exhibiting. But we're really not impeding discharge. I want to be super clear that we're not holding on to babies who are medically eligible for discharge. All of this is happening while they're in the hospital. We are meeting with hospitals. We are really, as I kind of talked about, having those office hour type technical assistance phone calls with them. We want to make sure we know if there are any issues like that happening. But right now, that really hasn't happened as of right now. And as the Secretary mentioned, we only have 5 of those 57 babies in hospital. They would be in the hospital anyways. They're just not ready for discharge yet.
Okay, thank you so much. That was good to know, because I really just wanted that answer. And then I think my last question, where was it? The this little notepad, I've been deleting and writing new things here. So, oh, SKY. You keep referring to SKY. Can you explain to the committee what SKY is and how you operate that?
Yes, Madam Chairperson Tavis, I will be really brief. It is our statewide central intake, and so the hospitals use that to call in for any concerns that they have for abuse and neglect, and that's where those get called in and then screened for the department.
Minority Whip Martinez.
Thank you, Madam Chair. Going to page 8 of the slides. When CYFD petitions for custody, are they being taken to a foster home, or are they winding up at Pinon or at Pine Tree?
Madam Chair, Representative Martinez, it depends on where they are in that situation. So if we file for a 72-hour hold and we go and determine that the house is unsafe, then we file the petition with the court for custody. So during that time frame between the 72-hour hold and the custody hearing, CYFD does maintain custody of that youth. So if they're still in the hospital, we would, be the custodian as they were in the hospital. If they're ready for discharge, typically they would be placed with a foster home. So that foster parent would go to the hospital for any of the trainings, and they work with the hospital on learning specifically how to care for that child. If for some reason a foster home has not been identified and the child is ready for discharge, it would be discharged to the receiving center, to CYFD staff, and then CYFD staff would go to the hospital and learn the proper care of that child while they continue to find an appropriate foster home for the infant. We haven't had a situation where an infant has had to remain in the receiving center.
Thank you, Madam Chair and Secretary. The receiving center is at Pine Tree, or where is the receiving center?
Madam Chair, Representative, yes, it is.
So on your last visit to Pine Tree, there seems to be some serious security issues there. When you visited Pine Tree, are you working on a fix to that issue of kids just walking away?
Madam Chair, Minority Whip Martinez, the kids, yes, we are working on the issue of kids just walking away. So older youth that remain there, we have not had older youth in the Pine Tree office overnight for some time now. But younger youth in the receiving center, so the office days are separate from the receiving center. The receiving center is youth under the age of 12. That facility is fairly secure. We do sometimes have younger kids that will try to run. We have put alarms on the doors up high so that they can't reach them, so it alarms if the door is in fact opened, so staff can be alerted to that. But yes, we have been working on issues to address that.
Thank you very much. When was the last time you were at Pine Tree?
Madam Chair, Minority Whip Martinez, week before last.
Thank you, Madam Chair.
Representative Gonzalez, I'm not sure if you were here for the presentation. Okay, we're going to skip you. Okay, thank you. Senator Charlie.
Thank you, Madam Chair, and thank you all for being here. My phone is blowing up with advocates and social workers countering the information that's been shared. So as opposed to asking questions, I just would like to make a statement. It's that we all share the same goal, keeping newborns safe and supporting families in their most vulnerable moments. But families are telling us a different story. Those advocates, the social workers are telling us a different story. It's that the way that CARA is being implemented feels less like support and more like punishment. If we want these policies to proceed, we have to build trust with mothers, with tribes, and with relatives who step up to take care of their children. This means looking honestly at where the system is breaking down and committing together to do better. I want to be your ally in that and build a relationship with each of you to ensure that happens. Families are telling trusted social workers that care feels less like support and more like punishment. Instead of connecting mothers to treatment and resources, our policies are criminalizing women for substance use in pregnancy. We continue to hear about child removals without notice to tribes. An immediate removal is a direct violation of federal ICWA and state IFPA. Yet CYFD and state police have entered tribal lands without permission. It's happened in Isleta and San Felipe, undermining tribal sovereignty and authority. We are breaking the law. Kinship guardians are given fewer supports than licensed foster parents, forcing families to shoulder the burden alone. In fact, it has been a well-known strategy of CYFD to prioritize guardianship over licensing because it's a workaround to avoid subsidizing actual support. Without subsidies and sustained support, guardianship placements collapse and children cycle back into the crisis with CYFD. This is not family preservation, and it's cost shifting onto relatives. Prioritizing guardianship without subsidies, CYFD withholds resources while families absorb that risk. And because we don't even track how many guardianship placements fall back into the system, back into that cycle with CYFD, we are choosing to not know the full impact. That is state-sanctioned neglect, Madam Chair, and it demands accountability. Since the hospital directive took effect, petitions have been filed, removals have occurred, and placements have been made. But we are not seeing transparent real-time reporting. Of the home visits, petitions, removals, and guardianships established, we don't know of those. What are the culturally and responsive placements? And without that information, Madam Chair, the legislature cannot evaluate whether the program is protecting families or producing state-sanctioned trauma. At the heart of this is whether our policies keep families whole, honor tribal sovereignty, and build trust, or whether they create state-sanctioned trauma for our families. We owe our families, we owe the mothers, more than just numbers. We owe them real support and real accountability. Thank you, Madam Chair.
Great timing. Vice Chair Lopez.
Thank you, Madam Chair. I appreciate the presentation being given today. And mine is just a comment also, Madam Chair. You know, when the first directive came out, the initial response, my response was, well, we have the CARA law. So how does this counter what the CARA law does? I've had an opportunity to speak to a few families, a few hospitals, a few providers of health, and there are some concerns, even with whatever you have described for us today as to how you're moving forward. Madam Chair, I firmly do not believe that a mother really wants to hurt her child. There are those who do have some substance issues. And Madam Chair, if those mothers are not seeing a physician, some type of health professional during their pregnancy, then I think we're not doing the right thing to encourage that mother to actually get prenatal care. Those I have spoken with, who are actually other advocates in our community, the concern is that this may have a chilling effect for mothers who don't want to go get any type of health care because whether they have a substance issue or whatever it may be, but there's a chilling effect that may take place. And I think it may, from others that I've spoken to, Madam Chair, I think there already is having a chilling effect on some communities of persons. Madam Chair, I know you gave us numbers, you have all of this information of who, where, and what, but there's such a thing as postpartum depression that comes in from those of us who've given birth. I think some of us have gone through that at some point or time. But I think the system needs to be revamped and looked at, Madam Chair, as to how we provide services to these women, to these moms-to-be before they're separated from their child. And it's a directive, Madam Chair. It's not a law. It's not something that we've passed in the legislature that the governor signed. We have the CARA law. and I'm glad that we have improved it because it did need some improvements. And I hope, Secretary Mijo, that the MCOs are really responding nicely, really trying to get something done. But Madam Chair, I just, for different populations in our state, I really have some concerns as to what this is doing for prospective mothers. And I know it's easy to say, yes, the child is going to bond and whatever the other verbiage is that's used. But when you tell a mother that her child is being taken away, that has certain other effects on the mother's psyche. Child is a child, it's an infant, still bonding issues, yes, I know, but what are we doing to make sure that that mother has appropriate support? So, I mean, I have other comments and questions, Madam Chair, but it's just, I'm not happy that there was a directive done. I really am not. That's overstepping the bounds of what I think any governor's authority is. We have the CARA law. That is something that's actually standing. It was signed, legislation passed by this legislature and signed into law. Something done at the whim is not appropriate. It sets us up for some other things that could possibly take place. Remember, there's such a thing called precedent, Madam Chair. So I just err on the side that I'm not happy with what happened with the directive. Thank you.
So I do have a couple questions and a couple statements. So, okay, mom comes in, gives birth. Does baby have to show signs of withdrawal? Is every mom who's known to be a user, is baby tested? How does one become a CARA baby?
Madam Chair, it's really voluntary disclosure or baby born with symptoms of withdrawal. So, medically, sort of clinically observed symptoms, babies are often born with really debilitating symptoms, or a neurological issue such as fetal alcohol spectrum. So, there isn't universal screening yet. That is where we're headed, but it's not in place at this time.
Thank you. And I too share the concerns with bonding. And I don't have any data around this, but you hear anecdotes of women who saw their baby, fell in love, and decided to get treatment and to do the best they could. I think we are taking that opportunity away from some moms, which really, and I know that bonding in the NICU is, it's a whole different ballgame and all of that, but I'm just throwing that out there. And then, so if a baby doesn't have medical needs and you want to do a 72-hour hold, you take them from, they're born, there's no physical signs of anything. You hold them for 72 hours in Pine Tree?
Madam Chair, they would be placed with a foster home. We try not to place infants at Pine Tree. We would typically do a foster home.
Okay, and I was disappointed. I don't believe any of the three of you said anything about kinship. You keep talking about foster homes, and I think Senator Charlie really, we are backwards to be willing to pay strangers to take care of kids, but not be willing to support families to take care of those same kids. So I think we need to have kinship be, and it doesn't come across as that should be our number one priority. And I'd like to see that more involved in what we have in front of us, more discussion of kinship. And then on page 10, I look at the chart and it looks like, United Healthcare, doesn't have any of these moms. But without knowing how many lives are covered, you can't really make a comparison. So I would much prefer a percentage, or out of 10,000 covered lives, United has this many, just so we can see who's doing what. And then on page 8, there's discussion of an unsafe home. So let's say the reason, mom has a substance use disorder, but she's living in a crack house. So is part of, when you do the home visit and you say, if she had a better place to live, she'd have a better chance. Is that an option that you are undertaking to get mom to have a safe place?
Madam Chair, yes, part of that assessment would be, to do an assessment of the living environment, but also part of that assessment would be, mom's willingness to make those changes, to go to a new environment. And, we would work with the workforce development on housing or whatever other services are available. If it's treatment, our goal is to try to get mom to participate in treatment, hopefully with child attached with her during that treatment. It's really to support mom through whatever she needs to be able to maintain that family unit and ensure that that infant would be safe. I think that's really what we're looking at, is the safety of the infant in those situations.
So I'm guessing that she won't get housing tomorrow or the next day. So are there hotel voucher? Are there other ways that mom can stay with baby in a safe environment while working on a longer term solution?
Madam Chair, yes, I think there are a bunch of different options, particularly for women who are potentially addicted or struggling with substance use. We do have supportive housing. We have the supportive housing program. We cover that through Medicaid, and we can definitely connect people. There have been a couple of success stories. I mean, one of the great things about doing these 150 or so visits is the success that we've had. And there were some families that were either struggling with extreme poverty and the home just wasn't, it was, I think there were some challenges. We were able to move them to, a new housing situation. So there have been really successful sort of interventions that have happened, and we are able to connect women. There is treatment available with your babies as well. So I just want to make sure that it's really clear that we have those options.
And then just one final question. Last year, 2 years ago, we heard from Dr. Enrique, I can never say his last name, Enguendanos, and he let me know that his contract was not renewed. And that upset me a lot, because what they were doing was, and I don't want to go into a lot of detail, but he guaranteed us that if he didn't save the state the amount of money for his contract, he would not be paid. And I can't understand why we would throw away a good program that is guaranteed to not cost us money.
Madam Chair, we didn't see the same results from that program. I think, and it is somewhat duplicative of all the care navigation and care coordination that we're doing. So I think there was a sense of it was a little bit expensive and we weren't getting the results. That was the state's assessment of that particular relationship.
Interesting. It seems like we're not doing a great job now. And he had some wonderful success stories. And as I said, he promised us as a committee that if he didn't save the state the amount of his contract, he would not be paid. So I don't think it was expensive, but I'll leave it at that. I was very, very disappointed to hear that that contract had not been renewed. So with that, thank you all so much for being here. And I do have an announcement that our final presenter, McKinley County opioid settlement update, Anthony Demas, the county manager of McKinley County, had to cancel. So we will be doing public comment around 4. So if you are here for public comment, or if you are on Zoom for public comment, be prepared around 4-ish. So thank you all, Madam Secretaries.
Madam Chair, I think I'm here for a twofer, so I'm gonna just go get my
I can
other
only
deck.
go one at a time.
All right.
Oh, the good news, right, Madam Secretary? Whenever you're ready, Madam Secretary. And if I could ask you to please take your conversations out so that we can continue.
Okay. Hello again. You'll be really tired of me by the end of this afternoon. So Again, Carrie Armijo, I'm the Secretary of the Healthcare Authority, and this presentation is really to talk to you all about the federal reconciliation bill and the implications to the Healthcare Authority and the 40% of New Mexicans we serve through our program. So we're really going to talk through that today, and we'll just go ahead and dig right in. So just a reminder on slide 2 that the Healthcare Authority's mission is to ensure that New Mexicans can attain their highest level of health by providing whole person, cost-effective, accessible, and high-quality healthcare and safety net services. And our vision is that every New Mexican will have access to affordable healthcare coverage through a coordinated and seamless healthcare system, which we know does not exist today, but that is really what we are trying to build at the Healthcare Authority. On slide 3, a reminder that the Healthcare Authority serves 848,966 New Mexicans through our programs. We have the highest enrollment of any state, sort of by percentage, in the Medicaid program. We cover about 39% of New Mexicans through Medicaid. We also have extremely high SNAP enrollment, about 23% of New Mexicans enrolled in the SNAP program. And you can see how many customers we have by each county as a percentage of each county's population there in the map. So on slide 4, I just want to be really clear, and I think my top line message for all of you is that changes that Congress enacted through the reconciliation bill across the Healthcare Authority's programs, primarily SNAP and Medicaid, are going to affect every New Mexican. There are implications for all of us living in this state, as people who shop at grocery stores, as people who access healthcare, that I think it's really important for us to know. These are not just program cuts for people enrolled in our program. There are big financial impacts to New Mexico. And in fact, you can see on the right that New Mexico ranks highest in the United States in terms of estimated job losses that are going to be caused by reductions in Medicaid and SNAP funding, anticipating about a 1.7% decrease in jobs here in New Mexico. Medicaid serves New Mexico as the largest health payer, and the new regulations are going to impact access and cost across all provider types. Those costs will, in some way or another, be passed on to individuals with private health insurance. We're starting to already see the market start to react in terms of what's happening. Premium increases, things like that are going to start to happen. So that is really going to happen sooner rather than later. Also, our ability as an agency to really leverage purchasing power is going to be more limited as the power of our programs goes away or is reduced. We are looking at the potential closure of 6 to 8 rural hospitals here in New Mexico over the next 18 to 24 months, which would mean reduced access to care for all of us in communities, and anyone traveling through our communities who might need those services. And uninsured individuals are likely to forego preventive care, resulting in higher acuity, a sicker population, higher costs, and more crowded emergency rooms. Nearly $1.2 billion in SNAP revenue is at stake for 1,700 New Mexico grocery stores, farmers markets, gas stations, and convenience stores with these reductions. And just a reminder that New Mexico has the highest rate of child food insecurity in the United States at 23.3%, which is likely to worsen. And one of the things that we know about SNAP is that it does actually, children enrolled in the SNAP program actually have improved academic performance and school attendance. So it does impact the overall health and well-being of our families. And lastly, on this slide, investments in New Mexico's safety net have reduced child poverty from worst in the nation to 17th in the nation, and federal changes are likely to reverse that change. And we're actually anticipating new census numbers that kind of reflect some of these reductions starting to happen already, coming out soon. So on slide 5, I'm going to talk about Medicaid and what's happening in the Medicaid universe in terms of changing requirements. So first, we will have what's called community or work engagement requirements. Those will start on 12/31 of 2016. 2026. That's my last day of work. Really an interesting and auspicious date there. But those requirements will go into effect at that date. We also will have more frequent eligibility checks and additional documentation that's required for folks to stay enrolled. So today we do renewals every 12 months. We will be moving that to every 6 months for most adults in the program. So it's going to be harder to stay enrolled. And that also goes into effect on 12/31 of 2026. There are some reduced eligibility provisions. So the retroactive Medicaid period is reduced to 1 month. We currently can cover about 3 months of unpaid medical bills. That's going to be reduced to 1 month. That starts at 1/1 of 27, so also around the same time. And then starting next October, some legal immigration statuses, including many refugees, victims of human trafficking, they will also roll off of the program. So there's about 9,600 individuals who will roll off of Medicaid who have a legal immigration status here in the United States, but who will no longer be covered by the program. We're also looking at some reductions to provider payments down to 100% of Medicare upper threshold. So we will see what we call provider taxes, which is currently how we fund higher payments to our hospitals. We also have higher payments to our nursing facilities here in New Mexico through provider taxes, which are exempt from the phase out. But those provider taxes, those will start to phase out in FY28, as well as the payments that are tied to that. So those higher payments that we're paying out to hospitals will start to phase down in 2028. And one thing I think it's really important to be aware of is that we're starting to see a lot of pushback from our federal regulators at the Centers for Medicare and Medicaid Services around the higher payments to providers generally. So right now we're paying primary care, behavioral health, and maternal child health care at 150% of Medicare. We think that CMS might take administrative action to reduce those payments down to 100% of Medicare. So just something to be aware of. You all have invested very heavily in provider rates, and so that would affect our providers here in New Mexico pretty substantially. And you may be aware that Medicare rates are not equivalent from state to state. So New Mexico actually has relatively low Medicare rates, and those are set by the federal government. We are also looking at having co-payments for certain services and populations starting 10/1 of 28. So another sort of reduction for providers, ultimately probably coming out of provider payments. Just a reminder as we talk about work requirements that most Medicaid adults are working here in New Mexico. You've got only about 30% not working, and that's really doesn't factor in people with disabilities or people who really can't work because of a real issue or parents who are taking care of children. And I do want to remind you that a single person in New Mexico would have to work more than 39.78 hours a week in a minimum wage job in New Mexico to exceed the federal poverty limit to not qualify for Medicaid. So essentially, if you're working full-time in a minimum wage job in New Mexico, you still qualify for Medicaid. So the perception that people aren't working is really not an accurate one. On slide 6, just a review of impacts of the federal changes to New Mexico. We are currently funded at about almost $10 billion in federal funding for the Medicaid program. And under the reconciliation bill, more than $8.5 billion potentially lost to New Mexico's Medicaid program from changes to provider payments from 2028 to 2037. So over that decade, we're looking at a lot of reduced payments. We're anticipating that almost 89,000 New Mexicans will lose Medicaid coverage. An estimated 42,000 New Mexicans will have new copays. 254,000 New Mexicans will be subject to a new paperwork or administrative burden in order to stay enrolled, even though they still likely qualify for benefits. We're looking at safety net more than 50 safety net providers, including our hospitals, losing critical funding, and as I mentioned, some potential hospital closures. We are also one of the highest projected increase to uninsured rates projected across the country, probably most likely due to those roll-offs from Medicaid. On slide 7, some SNAP changes also on the horizon to be aware of. So there is a new requirement in the reconciliation bill that states will share a portion of the SNAP benefit. So we currently pay out about $1.2 billion in benefits across New Mexico. The new requirement is that, and I'll talk about this a little bit more, is that states will pay a share of the benefit based on their payment error rate. And I'll talk about that a little bit. But one thing to be aware of is that New Mexico does have a high payment error rate, and I'll also talk about why that is. So we are kind of in the last tranche of states. We may have up to 2 years to delay that sort of cost share for New Mexico. So that could be as late as FY30 or for our state. So I guess a potentially good news, although there's a lot of work to bring down that error rate going on. There's also a substantial reduction in federal funding to administer the SNAP program. We currently get a 50-50 administrative ratio. That is changing with 75% of the costs to administer the SNAP program now the state's responsibility and 25% at the federal level. This October, we are also expecting that the federal government will reset the formula for SNAP benefits. So that is going to result in reductions in the actual SNAP benefits. The maximum SNAP benefit today is about $292. We're expecting that to go down to about $231. So about $60 a month, a little bit more than that for anyone who's at that threshold. We are looking also at additional work requirements for the SNAP program and stricter enforcement of work requirements. Probably New Mexico has, because of its unemployment rate, we have a waiver right now for most of the state in terms of participation. That waiver expires 12/31 of 25, so expecting additional work requirements to take place this January. And there are also some eligibility reductions. So folks will no longer be eligible for utility deductions and other things. So some folks will roll off or see their benefits reduced. And then this October, there's also a narrowing of SNAP eligibility for non-citizens. And again, these are legal people who are lawfully present, but just they've reduced the number of statuses or the kinds of statuses that we will be able to cover. So on slide 8, just the impacts of these changes. We do have about 459,000 New Mexicans in SNAP today, 1,700 retailers who are at risk of losing revenue. The reconciliation bill cuts about $203 million, up to $203 million in federal funding from New Mexico over time. Some of that hit will start in FY27. We are anticipating an additional $5.5 million in federal funds lost due to the termination of federal SNAP education funding. And as I mentioned, we will be paying 75% of the cost to administer SNAP. That is a $47 million impact to the Healthcare Authority. That is going to be in our FY27 budget request. So that will be factored in. A very big change for the agency. We expect about 459,000 New Mexicans to see their monthly benefits reduced. 16,000 New Mexicans expected to lose SNAP benefits due to their immigration status, so that starting this October. 55,000 New Mexicans likely to be subject to new work requirements. 20,000 New Mexicans likely to lose SNAP benefits altogether. And 20,000 New Mexicans to see a reduction in SNAP benefits due to the way that eligibility is calculated. So on slide 9, just a brief overview of the SNAP payment error rate. I've been getting a lot of questions about this because it does have major fiscal implications for the Healthcare Authority, for the state of New Mexico. SNAP payment error rates really indicate how accurately states determine eligibility and benefits for their customers, but there's sort of two aspects. One is how often we overpay our customers. So in New Mexico, that is the big driver. We are mostly issuing, our errors are mostly due to overpayments, very few underpayments here in New Mexico. And so right now, the focus of our quality control has really been on ensuring that households receive the accurate benefit amount. And I'll talk a little bit about what's driving the payment error rate. But one thing to note is that it is not a measure of fraud. These are really unintentional mistakes by states and by customers who sort of fail sometimes to report a change that might have impacted their benefits. There are things like that, but really the payment error rate is not a reflection of fraud or any intentional mistake by either customers or states. So under the new federal provision, if the payment error rate is below 6%, the state will not have a cost share. If the payment error rate is over 10%, the state pays 15% of the SNAP benefit. So 15% of $1.2 billion, it's over $150 million. And then there's some in between there in terms of where our payment error rate falls. Currently, on slide 10, our payment error rate is almost 15%. New Mexico ranks 49th out of 53 states and territories. And I'm going to talk about the major contributors to the payment error rate. So there were some flexibilities that were allowed during the COVID-19 pandemic that the state took advantage of. And we did this because we knew that New Mexico has a very high food insecurity rate, and we chose to keep families fed. So we waived required interviews, and this was allowed by the federal government, but we waived those interviews. That contributed negatively to the payment error rate. We also waived 6-month interim reports. That contributed negatively to the payment error rate. We also have a longstanding policy of allowing for self-attestation of shelter costs, utilities, and dependent care. This is really designed to keep people on their benefits. So that is a policy we're going to have to take a look at changing. And then we also experienced major shifts in our workforce. You all know that probably frontline workers all over the United States were impacted. We are no different from any employer where we struggled with maintaining adequate staffing, making sure that we trained people accurately. These are complex benefit programs, and so it's really taken some time to clean that up, make sure that we have experienced caseworkers, and our funded vacancy rate is less than 1% now. So it was very high, probably closer to 40% coming out of the pandemic. And then you all are familiar with the Medicaid unwinding and the pressures on application processing timeliness. We had to choose to sort of get people their benefits, but that also kind of impacted our payment error rate. So we're in the process of really trying to correct our payment error rate, get things moving. And I won't talk in depth about that, but I do want to make sure that you understand we have a plan, that we are executing the plan. The focus has been on the payment error rate provision and trying to correct that, but New Mexico is in a little bit of an awkward situation because we're very close to triggering sort of that cost share, right? So it's really more to New Mexico's advantage to stay in a higher payment error rate status for a little bit longer because of the way the reconciliation bill was written. And we are very close to the edge. So I'm happy to explain that further, but it's a little bit of a strange timing issue. And I want to make sure you're aware that on slide 12, we really have demonstrated our ability to make big improvements at the Income Support Division. This is the staff that is going to be implementing the work requirements. They're going to be doing the biannual verifications. All of this other, these changes really impact directly our ISD workforce. You can kind of see that today we are 99% timely on SNAP and 97% timely on Medicaid. So this is a huge, remarkable thing for our agency. We worked really hard to clean this up. You might have heard about all of the delays in people getting their benefits. So really proud that we've achieved this success. But again, these pressures are going to affect this workforce. On slide 13, just another sort of shifting back to the healthcare side, I want to make the point that we also, through the Healthcare Authority, are helping to make coverage more affordable for people who are purchasing coverage through the marketplace. We have the Healthcare Affordability Fund, and through that, we are able to provide additional subsidies for New Mexicans so that they can afford their premiums. Without our programs, we project that between 23,000 and 38,000 New Mexicans would lose coverage through the exchange. That's pretty huge. The marketplace covers about 71,000 people, I think, right now. So you can see if they lost half, that really starts to alter how our coverage landscape looks and whether it's even solvent fiscally. So we are really focused on also trying to preserve coverage and mitigate coverage losses for New Mexicans who might be sort of subject to some of those provisions as well. we think we can sort of mitigate those losses to much fewer New Mexicans. And we do have in our budget money to sort of preserve federal tax credits are expiring. These enhanced federal tax credits are expiring for people below 400% of poverty. We will be preserving those through our programs, but also looking at some pretty big other changes. There are going to be folks who are, again, lawfully present who will not be able to purchase coverage, and there's going to be some shorter enrollment windows. So all of that's going to affect the private market. We are anticipating that we could see up to $1,800 in premium increases per person here in New Mexico. So my last slide really is what keeps me up at night these days, and it's really the pressures of trying to do all of these sort of historic changes for the Healthcare Authority and lead the agency. I know there are a lot of pressures to do these things quickly, to do them well, and to do them at the less amount of cost. But, when you kind of cut one of those, you're going to really sort of upset the apple cart. So really, we are really under a lot of pressure in terms of trying to manage all of this. We are talking about pretty historic changes in a pretty quick turnaround time. And I think a lot about whether we can do a good job for New Mexico, which is our neighbors and our children and our parents. And so I think a lot about that. I want to make sure that when we execute these changes, that we are able to do them in a customer-focused way, minimal abrasion to our healthcare market. And so that's really what we're thinking about at the Healthcare Authority. I know there's going to be a lot of conversation coming up over the next few weeks about what the agency's needs are and what we need to do here in New Mexico. So I look forward to that dialogue. And with that, I'll stand for your questions. Thank you, Madam Chair.
Okay, thank you for that, for the presentation. Not for what you told us, but for the presentation. And I know you have nothing to do with it. So we will start with Senator Pope. Do you have questions? Representative Torres Velasquez. Let me look at time here. 1 minute? Yeah, 30 seconds.
Okay.
No, I'm kidding. Let's stick with the 3.
Okay. I guess my concern has to do with the implications for how cuts in Medicaid might affect a person's ability to work if more referrals and more paperwork is needed to get health care taken care of. And did I say Medicare or Medicaid? I apologize if I said it wrong. I'm referring to Medicaid, of course. But I'm wondering what y'all have thought of ahead of time to keep that from happening, because then that would affect not only the person's livelihood, but their life. Thank you, Madam Chair.
Madam Chair, Representative Torres Velasquez, very good question. I think we are trying to make sure that when we implement it's work or community engagement or education, that when we implement these requirements, that we make it as easy as possible for New Mexicans to report the changes, and that wherever possible, we're setting up data interfaces. So I am meeting this week with the Secretary Nair from DWS to really talk about what data do we have, how can we work better, what kind of supports do they need to provide additional work supports for New Mexico, how many people are we looking at by county so that they are adequately staffed. And so I think there's going to be some really good conversations happening there. We're also looking at potential data interfaces with the educational side. Can we just verify that folks are enrolled in school so they don't even have to report it? If the more that we can do sort of ex parte and not really interfere with people's lives, the better. So we are really thinking about all of that. The caveat is that federal guidance has not come out yet, and so we don't know how that will be. I would anticipate that some of the changes may require people to report or require them to come in person or something like that. I'm not sure how much data will be accepted. And if they don't comply, it's possible that they'll have a lockout period, which would make things really difficult. But that's a very typical thing in insurance to avoid people kind of coming back when they're really sick or when they're in the hospital. And so that's what I'm really worried about. I think we may see a lot of that sort of uncompensated care increase because people, I do anticipate that the federal government might attach some of those provisions, making it very difficult for people to re-enroll. So I think those are all things that we're really looking at, but I'm very focused on our customers and trying to make it easy for them.
Representative Anaya.
Thank you, Madam Chair. Just a comment, one, this is sick and disgusting, and it's a total disgrace. And I also hope to move as a legislator with a lot of grace, as you all are also trying to figure this out. So you have my commitment to be helpful in any way and to move with that grace, because I see your three-legged stool. Thanks.
Representative Chavez.
Thank you, Madam Chair. So we've heard a lot about rural hospitals closing, and in your presentation, you said the prediction is between 6 and 8. So 2 questions. One, how did you arrive at that? Can you talk a little bit more about that? And then also, which ones? Which ones are we thinking are going to close?
Madam Chair, Representative Chavez, so that is a number that I got from the Hospital Association. So I really don't feel like I am the best person to speculate about the financial picture of each hospital. Our agency does review hospital cost reports. We work very closely with hospitals. When they are having financial problems, I typically get phone calls. But there's a lot that could change between now and FY28, and I'm a little bit reticent to say which hospitals. I could tell you sort of which ones seem to sort of have the most concerns. I would be looking at our rural hospitals where they have high fixed cost and not enough volume to sometimes, and I think that's why we implemented some new payment programs to really try to account for and give them some additional funding. But it's really hard to keep a rural hospital open. And that's not to say all of them are having financial problems. It's just a reality. So I think, we're going to be watching the situation very closely, kind of thinking of ways to mitigate those losses. We are fortunate that we can continue to invest in hospitals between now and fiscal year 28. So really kind of making sure that they're investing where they need to and making smart choices. But I feel like I might be a little bit over my skis if I were to say which hospitals specifically.
Madam Chair, did the Hospital Association give you any sense of why they're thinking that number of hospitals might close? I mean, I guess what I'm trying to do is trying to figure out, as opposed to, they throw out a number and then everybody keeps repeating it and we don't even know why.
Well, Madam Chair, Representative Chavez, I think it's probably a pretty accurate number. There's probably 6 to 8 hospitals that prior to implementation of the Healthcare Delivery and Access Act that I was working with pretty closely, including some that were wondering how they were going to keep the lights on. And so I would anticipate as those funds go away or phase out, that they're going to sort of be faced with the same struggles that they were before. So I think it's probably pretty accurate, but there's still a lot of time between now and FY28. I think it's just something for us to be aware of and really working proactively with the hospitals. And I'm sure Troy Clark at the Hospital Association would be happy to talk to you about sort of what he's seeing. No, you don't think so? But I'm happy to provide you with additional information as that becomes available. I just feel like I don't want to speak for other hospital CEOs about their situation.
Oops. Madam Chair, additional information would be great. Would love to see that. And I forgot what I was going to ask. Oh, is there a report in terms of the money that's already been drawn down from the hospitals? And if you could share that information with the committee as well. Thank you, Madam Chair.
Madam Chair, Representative, are you talking about the HDAA program, the amount of funding?
Yes.
Madam Chair, Representative, we'll be happy to get that out to you.
Great, thank you.
And Representative Chavez, some of us were on a Zoom with Troy and Julia last week. So, and they were very careful to not name any hospitals. And I'm of the opinion, how can we help you if we don't know who you are? And also another thing, we talked about the hospitals that were already in trouble. We know we have the most number of private equity hospitals in the country. And what are private equity hospitals after? Profit. So as we lose Medicaid, rates, as we have higher uninsured, there's no guarantee that those hospitals that are flush with cash aren't going to bail because they can't make the money that they thought they could make. So,
And I'm sure they will.
yeah, well, okay, Representative Ferrari.
Thank you, Madam Chair, and thank you, Madam Secretary. It's been in the news lately about the $168 million in overpayments to managed care. And I was wondering why we're forgiving them, and the $119 million that the feds want back, and then the $50 million that was overcharged. Couldn't we use that money to help pay and for, what we're losing, especially for SNAP, and also to shore up, Be Well members?
Madam Chair, Representative, I don't believe that was in the news. I think it was in a blog, and it isn't accurate. So I just want to really kind of be super clear. There was a Office of Inspector General audit of the agency's capitation payments and reconciliations that goes back to about 2014, and I think that's really what is being referred to there. Under that, the federal Office of Inspector General calculated that we owed about $119 million, I believe. However, we're very much still in negotiations about that with the federal government, and the federal CMS, which makes the final decision, has not made a final decision. So that is very much in flux. And of course, I don't think it's an overpayment. Our position is that we owe zero, and that's really an incorrect finding. And it's a very complicated financial issue. So I'd be happy to kind of talk offline. It probably would put half of you all to sleep. But it is really about reconciliations and recoupments related to our community benefit program. And it goes back more than a decade. So it's kind of a complicated finding. I don't really think it's an apples to oranges kind of comparison, and I think the information was a little bit inaccurate. Yeah.
Okay, well, thank you, Madam Chair and Madam Secretary, for that explanation, because I'm sure if there were funds that we could recoup, that we would put them to better use than just letting the MCOs have them.
Madam Chair, Representative, of course, I think a big part of that financial burden actually would be general fund. And so I don't think it's fair to say that it's overpayments. And like I said, our position is that there's zero. And many of those MCOs, some of them aren't even in the New Mexico market. We don't have relationships with them now. So it's, how you get money back from an exited MCO. It's kind of a complicated scenario. So we'll work through it. I'm happy to provide you all with updates and information, but our position really is to try and protect the state against a $119 million finding or hit. So that's really what we're coming from, and we don't think that it's an accurate finding. So
okay, thank you for that explanation. Thank you, Madam Chair.
So just on that issue, if it turns out that it is an overpayment, can't we take companies that we don't have a relationship with to court, or the ones we do, for that matter? I mean, it's not really a lost cause, is it?
Madam Chair, maybe not. I think we have actually been looking at the contract, and I mean, to be fair, we are preparing in case we have to pay this back. I mean, we do have a plan. We've been working with the LFC. It's been pretty transparent in terms of our budgets and our projection, because it is a risk to the budget. But I think we are trying to figure out, there's usually sort of a run out on financial liabilities. And so we're really kind of researching that. But you're not wrong, Madam Chair, that there could be some liabilities for old,
thank you,
if there was an overpayment.
Okay, thank you. Senator Charlie.
Thank you, Madam Chair. With the increase in paperwork anticipated, how is HCA going to help New Mexicans re-enroll?
Madam Chair, Senator Charlie, great question. We will be doing everything we can to try and make it as easy as possible to make sure that folks understand what's happening to them. And we are looking to really staff our frontline workforce to make sure that...
Madam Chair, additional FTEs?
Madam Chair, Senator, yes, we are requesting additional FTE. We don't want to put, I mean, as I mentioned, the pressure for this workforce is very substantial. They are very busy. And so we've calculated in our budget request the amount of tasks they as human beings can do, and how many we anticipate having. And so we've kind of calculated a need for additional FTE. So we are going to do that. We'll have robust communications campaign. Unfortunately.
Thank you, Secretary. I want to 4 minutes.
Okay, I'm sorry. I could talk about it all day, Madam Chair. Sorry.
The second question is, how much fraud is there? We got a report from the universities, and they had over 7,000 fake applicants who were trying to get scholarships. And I'm wondering, how are we monitoring AI in fraudulent claims within HCA?
Madam Chair, Senator Charlie, are you talking about provider claims or customers?
I'm talking about for benefits.
Madam Chair, Senator, we verify the identity of every person who applies for benefits. We also have an Office of Inspector General. They do investigations. We have some front-end analytics that we do. So we kind of try and hit it from all ends.
Thank you.
Yeah.
Madam Chair and Secretary, thank you. I'll just close this out by saying I cannot believe we are in this reality. The reality of the federal policies on our healthcare right now. I think there's a difference between intention and impact. The intention to save money is going to cost New Mexicans dearly. Thank you, Madam Chair.
Thank you. Representative Gonzalez.
Thank you, Madam Chair, and thank you for the presentation. Although there's a lot that can be digested within your presentation, one question I have is actually not necessarily what's in here, but an impact specific to this summer food service program. Although it is not directly tied to SNAP, it is right now you're automatically enrolled based on your SNAP eligibility. And so one concern in my mind that I've been meeting with my school districts currently is how do we go about making sure that those same schools programs are continued to be eligible, with the changes, although this bill does not change that eligibility, it's like the domino effect or whatnot, based upon changes to SNAP eligibility and those automatic enrollments, maybe that same similar thread of Senator Charlie about the re-enrollment procedures. So maybe what could you foresee? Some thoughts and just general brainstorming with my administrators, school administrators were talking about handling those administrative responsibilities to get students now enrolled to be eligible for the summer food science program, possibly like a statewide marketing campaign, letting parents and families know that it's no longer automatically eligible for some of these services, and also possible common enrollment forms. Have you had any thoughts to, again, trickle down effect from some of these to other programs that weren't mentioned? Thank you, Madam Chair.
Madam Chair, Representative, well, I'm really glad you're asking about the summer food program. It's been a very successful program, really exciting. I'm really happy to work with the schools. I don't know if I have the best answers for all of those. I think we are trying to think about how to do everything in the most customer-friendly way, the easiest way for New Mexicans and families. So that will be at the heart of our decision-making. And we have some strategies. We went through the Medicaid unwinding, which involved SNAP families and Medicaid. It was really a historic event. We learned a lot from that. But I will be really eager to work with our communities and stakeholders on ways that we could do it better, ways that they could help us. I'm sure folks are really eager to make that happen. So we are signed up to do the summer EBT program again, continue that program, and make that as automated as possible. So I know a lot of families just got the money and they were really surprised by it and excited, and keep that going. But I think we're sort of at the starting of trying to think about how this is all going to work and how our systems are going to interact with New Mexicans. I'd love to work with the schools on that.
Thank you for that. And just the other place that I want to, being in my community, there is one of those at-risk hospitals, rural hospitals, our Alta Vista Hospital, that always keeping at the forefront of a lot of these changes. And in particular, I guess maybe my question is more the flip. We're talking about, how there's these hospitals that may be at risk towards down the road loss in Medicaid, which is absolutely true. But currently, I guess more on the positive, like the influx of funds. And maybe, I don't know if this is in your rural health or another, but with the Rural Health Transformation Program, if I'm getting that titling right, the $50 billion coming in, starting in FY26, I know the states will determine how those funds are distributed. And maybe that was something on the conversation, possibly that I wasn't able to attend. But I don't know if your department has any say or any leeway on possibly some suggestions to maybe get that influx into our rural hospitals in anticipation for those cuts coming later on. Thank you, Madam Chair.
Madam Chair, Representative, we will be. Our agency is the lead for all of that funding. We are onboarding an expert to sort of help us manage all of those funds and kind of create a system for getting the money out as quickly as possible. We're expecting guidance from the federal government in mid-September. So kind of planning for that. And awards will be due to states, I believe. Those announcements will be due by the end of this year. So that's a pretty quick turnaround time to try and get money out. I don't think it's a windfall. I wouldn't probably characterize it that way, but it is a way to sort of mitigate some of the coming losses. Yeah.
Okay. Minority Whip Martinez. Okay. Representative Chavez.
Yes, thank you, Madam Chair. Thank you for your presentation. I just have a couple questions. My first one is regarding the 88,000 New Mexicans and the 23,000 or more marketplace individuals that you're saying are going to lose coverage. Is that all encompassing of those specific issues you put underneath, or is it because of the federal poverty level eligibility that we have raised? What is the specific issue for that large of a number of New Mexicans losing coverage?
Madam Chair, Representative Chavez, can I just clarify? Are you asking about the Medicaid losses or the marketplace losses, or both? Okay. Thank you for the clarification. Madam Chair, Representative, on the Medicaid side, it's really going to be the primary driver of those losses is going to be related to the work requirements and sort of not deciding not to, or not filling out the paperwork. I mean, I kind of talked about this, most people are working. It's really about administrative burden. The same is true for the additional re-verification. So we do that once every 12 months, every 6 months, it's just more often. We expect folks just don't respond. It's a lot of paperwork, it's confusing. It's our duty to make it less confusing, but that's really the reality. Right now, about 42% of New Mexicans renew on time. So that's on the Medicaid side. On the marketplace side, I think what you're going to start to see is people, their coverage might become more expensive. Some of the tax credits are expiring for folks. We are starting to see there's going to be fewer people who can actually purchase coverage because of immigration status. Our agency is trying to preserve the access for folks under 400% of poverty, but people over 400% of poverty are also losing those tax credits. Many of them are self-employed, folks who don't have coverage through an employer. So coverage will be more expensive for them. And the combination is also that we're seeing requested premium increases come in on the private side. And so coverage is expensive without that help.
Thank you, Madam Chair. Thank you for answering that. I believe it. I did ask about the federal poverty level, so I think that's where a majority of that is coming from. My question then, because of the New Mexicans that we think are going to lose health care coverage for Medicaid, is the state going to open up more PE determiner classes? Because I think that MCOs, community providers, are really running into issues with not enough classes being offered in order to get PE determiners on their work staff.
Madam Chair, Representative Chavez, sure. We would love to do that if folks feel like that would be helpful. I think presumptive eligibility is great. It is definitely, I prefer people to stay on coverage. And if you didn't know, we have real-time eligibility, so it's always faster to try and get an eligibility determination. But I would be more than happy to kind of get that additional education out there.
Thank you. Representative Block.
Thank you, Madam Chair. Thank you, Madam Secretary. So I'm just going to go to page 6 regarding Medicaid specifically. And I think it states under the reconciliation bill about 250,000 New Mexicans will be subject to increased paperwork to stay enrolled in Medicaid. And even though you note that they will still qualify, I just want to clarify how many of those individuals who will still qualify will still get that insurance versus, they have to jump through one more hoop just to ensure access is legitimate, right? So can you just tell me from those individuals, how much would that reduce the number of people getting that Medicaid coverage, Madam Chairman?
Madam Chair, Representative Block, we're anticipating 90,000 losing coverage from that group. It's sort of a subset of that group. the
Okay.
254,000, because the policy changes really are focused on the adult expansion, which is the population that has the increased paperwork. And then of that population, probably about 90 to 100,000 will lose coverage.
Okay, thank you, Madam Chair. And then I don't see a number of total enrollees in Medicaid on the state. I think last time I checked, it was something like 900 and I forget, 900 some thousand people. So I'm just wondering what's the current number we have, and then what's the projected number, and then could you tell me pre, during, and post COVID what those numbers are, and is this just going back down to the status quo pre-COVID?
Madam Chair, great question, Representative Block. We have about 860,000. That's really close. I could get you the exact number. It's about 860,000 today. During the peak, during COVID, was over 1 million people enrolled in Medicaid. That was our pre-unwinding peak. So that was right before we hit the unwinding, and that was due to the maintenance of effort provision that we had to implement. We are right now just below where we were pre-pandemic. So that 860,000 is just right kind of in that same area. So we're close, and we are trending flat. Our enrollment is trending flat. It will start to trend down once these changes take effect, but we are pretty much flat enrollment right now.
All right, thank you, Madam Chair. And then last question. I know that after the pandemic, we got those people off Medicaid, but I think only about 5% went on private insurance or Be Well NM plans. So I'm just wondering how that is affected when it comes to the One Big Beautiful Bill Act and how that affects the people on Be Well NM. Because it's about only 5,000. I think it was about 10,000 individuals post-COVID. So what is that going to do when it comes to those individuals who, I mean, it's a very small minority of people who got off Medicaid and onto private insurance. Madam Chair.
Madam Chair, Representative, I'm not sure if I actually have a projection in terms of growth. What I've seen mostly is a shrinking sort of enrollment target. So I don't think they're anticipating a lot of growth from these roll-offs from Medicaid, primarily because most of them probably still qualify for Medicaid. So folks you can't enroll and get help on the exchange if you still qualify for Medicaid. The challenge will just be how the federal government implements that provision and whether people can come back on Medicaid easily or if there's that lockout provision.
Thank you, Madam Chair.
Thank you. Representative Jones.
Thank you, Madam Chair. Somebody has their mic on. Is that you? Oh, no, it's you, of course. Sorry. I don't know if you've been turning it off or not. No, I guess it works with two of us, right? Yeah. Thank you, Madam Chair, and thank you, Secretary Armijo, for the new information. I appreciate that there's a little less speculation. It helps with, future, looking into the future, but I have no additional questions. Thank you very much. Thank you, Madam Chair.
Vice Chair Lopez.
Thank you, Madam Chair. Just a question, and I think you did mention it, Madam Secretary, that the feds still haven't put together their rules for the Medicaid changes?
Madam Chair, Vice Chair Lopez, that's correct.
Okay. Do you already have a committee chosen for New Mexico as to how we will implement the rules that they bring forward? I hope they give us a little leeway. Madam Chair, back in the day when PRORA, the TANF legislation was passed under President Clinton, that was my first term up here. And I remember it took us a full year just to go through and figure out how the changes were going to be made for implementation. And that was some huge changes to the welfare to work program, TANF as we call it now. So I'm hoping, if you already have a committee, do you?
Madam Chair, Vice Chair Lopez, we have an executive, we have sort of an internal agency structure around these changes that has been implemented. We also have our Medicaid Advisory Committee, which our Medicaid Director is talking at length at all of those meetings to really sort of talk about how things get executed and implemented there. We also now have a Beneficiary Advisory Committee that just launched. So that has real members who are participating. And so that's also really exciting. And so all of those are kind of the forums that these changes will be discussed primarily. Happy to have additional stakeholders involved. happy to get additional feedback on that. But we do have a structure and things are starting to move forward. But it will be challenging in the absence of guidance. We're really hoping that we can get some information out from the feds pretty quickly.
No, and I appreciate it. I mean, the Medicaid Advisory Committee existed back then, but I would hope that you do some outreach for some of the organizations who work with community. I know the ACLU was part of it back then, Center for Law and Poverty, and a few others, but I would hope that they would also at least be able to participate as you begin to put the rules together for New Mexico's program. And then, Madam Chair, I know there's, I think the B2 to 3 bill has, I think, about $50 billion in it for rural hospitals. Is that the information that you were sharing or talking with Representative Gonzalez about?
Madam Chair, Vice Chair Lopez, that's correct. I think that is the same pot of money.
Same pot of money. Madam Chair, and $50 billion doesn't go far. So I know we don't need to expect that we're going to get a huge chunk of change because there are many others across this country who are also going to be applying for monies. So that's not just a savior for our rural hospitals. It's just seeing where we've been in the past years and where we are at this point. Madam Chair, what about our FQHCs, Federally Qualified Healthcare Centers? What is the department looking into? Have you had a conversation about FQHCs?
Madam Chair, Vice Chair Lopez, we have. We've actually had a couple of conversations with FQHCs and about FQHCs. I'm worried about our FQHCs primarily because as people roll off of Medicaid, I know they're going to keep serving people and they're going to serve them with even if they can't pay. And so we really are going to need to think about what to do for our provider network. I think especially when their mission is around serving everybody who comes in the door. And so, yes, we have had some conversations with them, thinking differently about, what we may need to do now. And so we are actively working on that issue.
Well, I'm glad it's on your radar, Madam Secretary, Madam Chair. I know when the portal was not accessible earlier this year, one FQHC in my community in the South Valley of Albuquerque had the possibility of losing $650,000 a month. And those are throughout the different grants and such that the organization has written in order to keep the doors open. And of course, we serve about 50,000 people in the Albuquerque area and Valencia County as well as Torrance County. So that's a huge chunk of change. Multiply that, as you know, we have over 200 in the state of New Mexico, FQHCs. So I anticipate, Madam Chair, that some of those might be closing also, just because of their reliance on Medicaid. So the other thing I wanted to mention, Madam Chair, is we all have these little machines, computers at our leisure. There was a report back on June 19th. This was by New Mexico News staff and posted on the Roosevelt General Hospital and Clinic's website, talking about the U.S. Senate. And there was conversation during the budget process of the B2 to 3 bill. And in there it did list where they said that New Mexico had actually 15 hospitals that were on the list for potential closing, not just the 6 to 8. Of course, this was back in June, so maybe there's more positive at that point. But what they were looking at there in the U.S. Senate Budget Committee was those hospitals that rely on Medicaid. So that it's more than just the 6 to 8, but it did mention Alta Vista, Eastern New Mexico, Espanola, which of course is part of Presbyterian, Plains Regional Medical Center, Rehoboth, Carlsbad, Covenant Hobbs, Roosevelt General Hospital, which of course is in Portales, Lovelace Regional Hospital in Roswell, Socorro, Dr. Dan Trigg Memorial Hospital, which is in Tucumcari, Lincoln County Medical Center, Ruidoso, Miners Colfax Medical Center up there in Raton, Mimbres, which is in Deming, and then Holy Cross, which is in Taos. And this was based on some information from the Senate Budget Committee back in June. So I just wanted to mention there is a list of hospitals that were mentioned because they rely heavily on Medicaid. So Just an FYI, that's all. Thank you, Madam Chair.
And I will go to you, Senator Pope, but I have a slide from the presentation by the Hospital Association that talks about the Rural Health Transformation Program. It's $50 billion split over 5 years, 2026 to 2030, $10 billion dispersed annually, $5 billion evenly to each participating state, so $100 million per state. So Montana gets the same amount as New York and California, which, okay. And then $5 billion at CMS administrators' discretion. There's limited direction in the bill for what rural providers are eligible. There's some guidance for what funds can be used for, but not how states must disperse funds to rural providers. And now my tech, I don't want to add a caption. So basically it says that the Healthcare Authority must create a transformation plan by some unknown date, which the things have to be pretty much buttoned up by December 31st. So I'm assuming that you are working on this, even though there's not much direction and you don't know when it's due and you don't know what to do with it. So can you just briefly talk about how you are preparing for the unknown?
Sure, Madam Chair, and thank you for talking about that. I mean, it is, I just want to be really clear, there's still a very big gap. These funds will sort of be a very little Band-Aid on a much bigger problem. And I'm happy to kind of give you that gap between what the Medicaid funding is and what we'll be getting, because it's still billions of dollars in a gap. So we do have a procurement posted to onboard an entity to help us with the rural fund applications. That is currently posted and underway. And we're expecting that pretty soon. So we're trying to ramp up and be prepared. There has been discussion about the avenue for getting funds out once we in New Mexico have the funds. And it may look something similar to the Rural Healthcare Fund, where we sort of have a application process or a way for hospitals to access the money quickly. That's been a very successful model. So we're really looking at what will the avenue be to get the dollars out the door quickly, not sitting on them at our agency, but really trying to prioritize getting those out and just preparing. So we really are doing everything we can in the absence of guidance just to make sure that we're ready as soon as the guidance comes out, because we are expecting announcements in about a month from CMS about what the application needs to look like. So we're trying to onboard some resources to help us get those funds as quickly as possible.
So I will remind folks, some of you weren't around, that we did a bill in 25, I guess, to fund, no, 24, to fund rural hospitals. And we did the bill, and we come to find out later that hospitals were not necessarily transparent, that there are so many ways that they can count, they can consider this a loss or they can consider this a debt, and so we gave money to hospitals that didn't need money. And the Hospital Association said, well, the information on what hospitals actually have is proprietary. And I'm of the opinion that the state taxpayers' dollars should also be proprietary. If you don't want to tell us what you have, then we can't decide whether you need more. I'm just putting it out there again that if you don't want to give us what your hospital financial picture is, maybe don't expect a bailout from the state. Just throwing it out there because that made me almost lose my mind. So Senator Pope.
Thank you, Madam Chair, and apologize for coming in late on this. Appreciate the presentation and you just laying everything out. I think it's important to highlight so many folks who are on Medicaid that are working, how these SNAP cuts are going to impact folks. Just want to remind everyone that, we have members serving on active duty in the military that use SNAP with their families. We have National Guardsmen that use SNAP, and some of them are on Medicaid because they're like weekend warriors and working part-time. So this narrative that folks are using the system and not working is just not true. My question is, you've laid out a lot of things, and I'm worried about other unintended consequences of what's happening with this funding. We're looking at cuts to the VA, folks who are on the VA most likely, no one's really going to probably go Medicaid to VA because they probably would have just went to the VA, right? So they're not going to be able to go there, but that's going to be some limited resources, IHS in our state. Is there a thought of how we're talking about funding and losing rural hospitals to where it impacts some of these other clinics, just like was mentioned with FQHCs? Can you talk about that, or is that something you're kind of looking at with some of the other unintended consequences of what's happening with this funding?
Madam Chair, Senator Pope, I think that's a really good point. I mean, the strain is going to sort of be there for everyone, and whether you're on Medicaid or not, if you access the VA, right? Which isn't just for Medicaid or IHS. These are going to be pretty strained provider network resources. We are thinking about ways to try to protect coverage, try to protect those SNAP payments, but we will be somewhat limited in what we can do through the Medicaid program. So as we kind of think about special session or those kinds of conversations, a lot of discussion happening right now about what kinds of ways we can be really creative in mitigating these when we don't have the traditional way, which is through Medicaid, or is that going to be a general fund purchase of Medicaid coverage? I mean, those are the kinds of conversations that are happening now. But so much is done through that leveraging of Medicaid for all of our provider network. So if they start to reduce the rates, that has a big pressure where they can get a payer that helps them be a little more flexible. It's like the FQHC question. If they have more payers over here, they can serve more people who can't pay. So those are really the kinds of issues that we're questioning right now. I just want to be clear, there's probably not a magic bullet on this. These are pretty big losses and pretty big policy impact, really generational changes in terms of changes to our healthcare system and safety net. And so we're doing everything we can try to think of. We're working closely with other states too to try and think through like, what are they doing? We're wanting to make sure that we're doing everything we can to leverage relationships. But these changes are happening one way or another. So, there is going to be strain on our provider network. And we're going to have to think through how do we support them here in New Mexico for the people who need them. And I don't really have all the answers to that, unfortunately. I sure wish I did.
Well, I appreciate that, Madam Chair, and I appreciate what you're talking about. And none of us have the magic bullet and the answer either, but I just think we need to have these conversations and understand that the system was already strained. Access to folks, the resources to get there. I mean, we did a bill a couple years ago to just go ahead and pay for our National Guardsmen to get TRICARE, which is really subsidized on the federal side. So we need to really look at what we can do here in the state. Hopefully it's for the short term, but I don't know. We just can't let folks go without. So thank you, Madam Chair.
Thank you, Senator. I'm going to go back to Representative Anaya for a brief statement.
Thank you, Madam Chair. I just wanted to make a quick suggestion on funds distribution. I'm really glad that we mentioned the Rural Healthcare Delivery Fund. My understanding about the way that the money ended up across the state was actually much of it was allotted to some of the larger hospitals. And so I would just like to make a suggestion that as we are trying to figure out where this money goes, how is it that we're not necessarily like allocating based on beds, but we're figuring out like who has some of the slimmest margins, right? Like who's barely getting by? How do we make sure that we are prioritizing that money first? And from what I understand, like some of the like county-owned hospitals, right, are some of the like folks who are like tightest. And so I hope that as we're allocating funds, we can take that into consideration because we do have multi-billion-dollar hospitals that are owned by out-of-state corporations. And we also have these like super slim margins with like county-owned hospitals. And so I hope that that is something we can take into consideration as we're distributing money and prioritizing where that needs to go. Thank you, Madam Chair.
Thank you. And I do have a few questions. So in terms of the more frequent eligibility checks, and you may not know this, I mean, there are some people who don't need to have my son doesn't need to have, I mean, he's going to have autism for his life. He's going to require total care. So are there carve-outs for certain groups, and do you know what those are?
Madam Chair, the every 6-month eligibility checks is really related to the adult expansion population. So folks on the waiver, it shouldn't be, unless there's something weird that happens with the federal guidance, we should really be status quo. We've got eligibility from age 0 to 6 for kids. That shouldn't change, at least not now. That probably will expire. That's kind of coming down the pike, I think. But it's really, we're talking about the adult expansion population for those checks.
And then in terms of, I think we just approved that moms can stay on till they're for a year postpartum. Is that going to be affected?
Madam Chair, at this time, we haven't heard that that's impacted.
Okay, thank you. And then I was out in in Tohatchee and Pinedale for Indian Affairs last month. And, when you talk about work requirements, you go out to some of those chapters and there's no work. I mean, there's no volunteer opportunity, there's no internet, and so I wonder there are people who sheep herd for a living. I mean, they raise sheep and they sell them and they sell the wool, and that's how, is there a way to prove that kind of work? Silversmiths, how do those people prove that they're working without a pay stub?
Madam Chair, 2 things to know. One is that the Native American population is exempt from the work requirement. So I think when you're kind of talking about folks who do sort of traditional things in their tribe or pueblo or nation, those things are not subject. Those individuals wouldn't be subject to the work requirement or have to report. So, however, that data is as good as we know, right? It's really for folks who let us know that they're Native, because we don't know automatically. So it's self-reported. But for folks who have reported to us that they're Native American and had that verified, then they don't have to do that. I think a lot remains to be seen in terms of how easy or hard this is, and it's going to be in the federal guidance. So right now, for example, we allow people to give us a statement. There's a discrepancy between what their verification is showing and what, maybe they lost their job 2 weeks ago and it's not showing up in the data yet. So we allow people to do that. I'm just not sure how accepting they will be. So I really can't answer the question yet, but we'll be trying to make it as easy as possible.
And of course, there are people in other rural parts of the state that are not Native who are doing the same kind of work. So thank you. And then in terms of a special session, people are saying, oh, you got to have a special session to deal with this. Personally, I don't feel like we know enough to do anything yet. And I know I'm not trying to be political, but do you feel like we know enough to actually take some action legislatively?
Madam Chair, I strongly recommend that we get started with what we do know and really start to plan out the changes. These are big, big changes that cannot wait until fiscal year 27. They are the kinds of changes that take we're looking at 18 months, not even 18 months really, to implement some major IT changes and get all of our forms updated, onboard new staff. We need the time to do that. If we were to wait till fiscal year 27, for example, we would have less than 6 months really from the time that the budget was in effect to really make all of these changes happen. I don't think it's enough time. We did receive a letter from the federal regulator at CMS basically saying you better get started. We're not going to waive any of these requirements for states for not starting now. So they have also told us we really need to get moving. So I do recommend that we get started and that we start planning and we really take action. I don't think that the agency will be able to execute the changes.
So legislative changes, are they mostly budget, or are you thinking of other, and when you answer that, please let us know, let Xander know what you're thinking so we can be preparing, learning, all of those, because nothing worse than going into a special session and saying, here's an 800-page bill, vote on it. So please keep us up to date and feel free to answer.
Madam Chair, what I can answer today is that the agency has needs in FY26. And those are really for system changes. We got to get our call center ready. So it's our eligibility system, our call center, and then our customer portal. Yes, New Mexico. We got to get all of that ready. We also need to onboard and train staff to meet the new requirements. So those are the main things that we really, really have to have in FY26. I think there's a lot of other policy conversations that can happen around how do we mitigate some of the losses in coverage, the losses in SNAP. Those are sort of separate conversations that are happening, and what I just articulated to you is really the FY26 need for the agency. Yeah.
Thank you so much for your presentation and for sharing with us what you know and what you don't know. Unfortunately, there's a lot of don't know. So thank you for that, and I think we will go to public comment. So if you are on Zoom and you would like to make public comment, please raise your hand and we'll come back to you. We have one person in the room who signed up. Oh, two. Okay. Oh, okay. I see. She snuck it in there on the side. Okay, so we will start with Linda. Ooh, I can't pronounce your last name. Oh, Lynn. Thank you. I can't read either. And then Marlon Beck. So Lynn, go ahead. We'll give you 3 minutes.
That one? Okay, thank you. I need help sometimes. So, good afternoon, all of you, and ladies and gentlemen, I want to say thank you for keeping the public comment in your process, and also want to say yate and welcome to Gallup, New Mexico, the most artistic small town in America. If you have a little time, I could help prove that. I'm here with a couple hats this afternoon, but we recently, I have a place in Red Hill Mobile Home Park in town, and we just in the last couple months formed a Red Hill Mobile Home Park Owners Association, and why that happened is that we realized that we all have one basic concern that affects us all, and that's rent increases. And the last 2 years, each of the years, the rent has increased over 10% each time, which is quite a bit above the rate of inflation for those years. So we decided we need to try to see what we can do about that, because we have a lot of people with fixed incomes. We have older people who've lived there 20, 30, even 40 years, and it causes not only financial stress, it causes some anxiety by people, when they don't know what rent increase is coming next. And so looking at your task list, your topics, you cover such a broad range of things in your committee that I was trying to see which things it connects with. It connects with several things. But I'm here, first of all, just to let you know that this situation exists. We have out-of-state owners of mobile home parks. And in our case, the owner lives in Florida, and we know that there are some state laws that aren't always being enforced in terms of laws that restrict and control the owners. So I wanted to let you know that we have that concern, and we think this year that there's going to be another introduction of legislation that will, among other things, try to put a cap on how much mobile homeowners can increase their rent, inflation rate, or maybe inflation in a little bit, but not up to 10.5% when the inflation rate is 2 to 4%. So I want to let you know about that, and I'll give you a handout in a minute. There is a statewide alliance of different homeowner associations, and it's an alliance. It's not an association by park, but it's an alliance of the various park associations, and the name is the Land of Enchantment Manufactured Home Owners Alliance, and you might be familiar with that. But they're a good group, and we're trying to ally. And one of the reasons we formed our association is so we can link with them and help them as they lobby, presumably in the next session, in terms of some protection for mobile home owners. The other thing, which overlaps with that, in your topics and so on, and you you mentioned affordable housing, which is not only a Gallup problem, it's a widespread problem these days across the country. And affordable housing links in another concern, that is, if you're on the bottom of having, just barely being able to afford your housing, and then you lose your job, what happens next? You're unhoused, you're homeless, right? And I happen to be acting chair also of a Gallup Homeless Unhoused Task Force that we started back in January. Some of us got concerned. I'm not a native to Gallup, but I've lived here 3 times. And seeing unhoused people on the street, I'm afraid we've come to accept it because it's so familiar here. And we pay attention to what's going on. Albuquerque, Tim Keller has been really active in a lot of ways. You got people trying to do things, build small homes and so on. And then up in Kalispell, Montana, for example, it's illegal to even sleep in your car. So we've been trying to see what can we learn and do about the unhoused homeless situation, the street situation in Gallup. And I mention that here because it does overlap with the concerns about affordable housing, and when we've got people just barely hanging on with rent increases in the mobile home park. So there's a possible link there. So I know my time is...
if you could wrap it up. I gave you extra time,
but
I don't want to get
let me
accused
give you
of
this before I
favoritism.
go. It's a good little summary sheet on some points. And I guess the main thing is, I say, when the legislation comes up, if it does, we hope this committee can be supportive of things in that regard. And at some point, maybe even have to look at a whole nother committee or subcommittee dealing with the manufactured home thing and the homeless thing, because it's not getting better, and we're getting more young people, the fentanyl, all the things that are going on. Oh, thank you very much.
Thank you. Next, we'll have Marilyn Beck. Thank you. How do you say your last name?
Heinemann.
Heinemann. Thank you,
ignore
Mr.
the U.
Heinemann. Okay.
Madam Chair, can I make a comment?
Yeah, go ahead, Senator.
I just want to say his group, they spoke at the Military and Veterans Affairs Committee on Wednesday, so I really appreciate just kind of getting this message out. And I know last session there were some bills to try to deal with a lot of these issues, single-family homes, manufactured homes, and trailer parks. So thank you.
Thank you. My privilege.
Thank you. Go ahead.
Does it work? Okay. Good afternoon, Madam Chair and committee members. My name is Marilyn Beck. I'm a little sad we're an hour and 15 minutes early because I think CYFD should have stayed longer. I think it's the most pressing issue in our state. I drove 120 miles to be here, so I have a few comments about addressing the CARE hearing earlier this afternoon. First of all, the Secretary doesn't know how many children have died. It's 4, not 3. It's 4 children have died in the past 3 months on CARE plans. That's public information, and I'm sad she didn't know. One was the 18-month-old who died August 2nd after a failed trial home visit. And so I guess if she's only tracking 12 months, we didn't track the 15-month-olds or the 18-month-old. There is a teenager living in the receiving center, and that's public knowledge. She's been living there since March. So that was a just flat lie. I want to elevate the previous concerns about shadow foster care, kinship guardianship without the support of the state. I have personally brought this issue up to both the Children's Court Improvement Commission and Don Walters at CYFD. This is a known phenomenon, and it must stop. If it is safe to place, it is safe to pay. Lastly, and I just want to give you one good news, we actually have the highest number of kinship care placements in the country. So New Mexico is doing one thing correctly. We do have the highest number of initial placements with kinship. But again, I will reiterate, if it is safe to place, you should pay. And then finally, like many of you, again, I'm here and we're an hour and 15 minutes left to the committee meeting, so I'm just really sad you didn't get to ask harder questions. Because I want to ask you, when is enough enough? In the past 4 months, our state has seen 6 maltreatment fatalities. 6. 6 in 4 months. 2 of them were suicides of teen. There's a teen in a mental health. There's a teen in a shelter in Albuquerque right now in health crisis. And I have said to Teresa and Diego at the governor's office, we cannot afford a 3rd suicide in 4 months. 2 suicides have, 2 youths have felt so desperate they took their own lives. 2 rushed trial home visits have failed. 1 ending in the unthinkable. She was the 4th Cara baby, and maybe that's why the secretary didn't count her, because she wasn't under 12 months, but she was 18 months. 2 former foster parents, actually they were current when charged, 2 former foster parents have been charged with felony child abuse in the past 45 days. The most recent one has a criminal history that includes domestic violence and multiple DWIs. It makes you wonder how she was ever licensed. Like Eleanor Chaffis knows deeply, Bernalillo County has currently a 60% vacancy rate. Other counties, including some of yours, have a 100% vacancy rate. Following the most recent fatality, 5 workers in Bernalillo County were placed on leave, leaving 1 county office manager when there should be 5. And in addition to the presentation you just heard from HCA sounding the alarm about federal funding, the feds just released a report last week. There'll be a presentation tomorrow morning saying that once again our children are in imminent danger. Safety is their number one concern. And if we don't fix the system within the next 90 days to 2 years, we risk losing all federal funding. That's in addition to the Medicaid concerns you just heard. Another lawsuit was filed in the past month over a child abuse fatality in Silver City that had 5 separate failed investigations. 5. Not one time did they put eyes on the kid. She died on her 5th birthday, the day of her birthday. Last week, a father left his young children alone, and it was a very sad situation, to go support their infant child. He was charged with felony child abuse. This was in Albuquerque. Yet when the state takes your children into CYFD and they allow your children to walk out of the receiving center, 4 years old and nonverbal, that's just business as usual. This is not a media perception problem. This is a deadly virus and a corrupt agency that is threatening the lives of our children right now. I'm not going to stop. 6 kids have died in 4 months. I'm not going to stop. These issues of state-sanctioned trauma, thank you for saying that. Tomorrow, I want to say these issues of state-sanctioned trauma are manageable. Tomorrow at 2 p.m., you will hear from the Kevin S. Settlement plaintiffs team. Ask them hard questions. Let them speak longer than an hour. These are manageable issues. Did you realize the Protective Services foster care? There's only 2,000 kids in it. It's the same size of a high school. When we talk about breaking up CYFD, how many kids are in your high school? 2,000. If you call your principal and say, my kid's in second period, where is my kid? They better answer that question. Our secretary didn't know how many kids have died in her care in the past 3 months. I text someone, a legislator, on Thursday night about the KOB hearing, about the wandering nonverbal child from the receiving center at the time where there were 7 nonverbal autistic kids sleeping in the receiving center and a teenager. And do you know what that person said to me? She only has 18 months left. That's what a legislator said to me on Friday afternoon, or Thursday afternoon. Just wait. I want to be very clear. Our children cannot wait another 18 months until we get an election and hope a new leader is finally going to cut it. It's not going to happen. Every day this goes unaddressed is a day our virus is getting worse. Our kids are not okay right now. You go visit the receiving center, you visit AMI Kids, you visit Amistad, you visit Casa Q. Our kids are not okay. I think we look at Representative Chavez's solution because nothing else is working. And the sad thing about that is, why is that solution the best solution on the table? It's because the elephant in the room is that our governor is not addressing this. You know what they said on that KOB hearing? Have Teresa come sit at the receiving center, come work out of Pine Tree. And I'm going to say the governor should be doing the same. If you are not part of the solution, you are part of the problem. 6 kids have died in 4 months. Guys, that's unheard of. That's unprecedented. This is the number one issue facing our state. You know where else juvenile justice is in charge of? CYFD. Youth mental health? CYFD. I will leave you with this. The fierce urgency of now cannot be overstated. Thank you.
Okay, thank you. We have 2 folks online. We have Misha Bitzini. Misha.
Hello, Chair, members of the committee. My name is Micah Bitzini. I work with Bold Futures. I'm a policy manager. And when we talk about CARA, what we hear most from families is that the system focuses too much on surveillance and punishment and not enough support. Parents tell us that reaching out for care during pregnancy often comes with fear of being reported, investigated, or separated from their children. Instead of building trust, CARA, as it's currently implemented with the directive, pushes families away from the very resource that could help them. We've heard directly from mothers who wanted prenatal care but stayed home because they worried that being honest about their substance use would mean losing their baby. We've heard from families who are struggling but who are met with CYFD instead of housing, treatment, childcare. We've heard from grandparents and relatives who step in to keep kids safe but are left without the resources to do so. What families say they need is clear, stable housing, treatment without stigma, mental health support, childcare, culturally rooted care they can trust. They want providers who will walk with them and not report them. The truth is, when we support families, we support children. Every child's well-being is tied to the stability, health, and strength of their parents and caregivers. Punishment and fear do not build strong families. Care, trust, and resources do. I urge this committee to listen to the lived expertise of those who have survived these systems and to make sure care is implemented in a way that centers and supports families so that every child grows up in a safe, stable, and loving home. Thank you.
Thank you, Micah. And next we will have Cueva Hubbard.
Good afternoon, Chair and members of the committee. My name is Cueva Hubbard. I am from Albuquerque, New Mexico. I am a person that has been directly impacted and who works with families in the child welfare system. I feel centering people with lived experience in CYFD decision-making ensures that policies and reforms are shaped by the very voices most impacted by them. Lived experts bring insights no report can capture, exposing system blind spots, offering practical solutions, and grounding change in the realities families face every day. Their involvement also addresses the over-policing of families in child welfare, challenging practices that unnecessarily surveil or punish instead of supporting and strengthening them by advocating for second chances, strength-based language, and practical timelines that reflect the real pace of family healing. Lived experts help design policies that give families a fair path to stability. Including them at the table in decision-making and policy work shifts power from a top-down approach to one rooted in partnership, trust, and prevention. It keeps reforms deeply human, reminding all stakeholders that behind every policy are real children, parents, and communities whose well-being depends on getting it right the first time. Thank you.
Thank you so much for the public comment, all of you. And since we don't have our last presenter, we will be in recess until tomorrow morning at, I believe, 9, but let me look. 9:15. Oh, you get to sleep in. Woohoo. Yeah, and just a reminder about the dinner tonight, 6 o'clock at El Rancho. Thank you all for being here. Thanks to the staff.